Time with a good chance that we can finish in time. Ladies and gentlemen, please take your seats. We start in the name of Allah, the most beneficent, the most merciful, and in the name of the Prophet who brought a message of peace, prosperity, health and happiness to the world. I invite Kashif Nawab to come and recite a few verses from the Holy Quran. Kashif Nawab. My name is August 1986. I had the great good fortune to go to medical school in company of Dr. Khalid Kondal, Dr. Nasir Salwandi, Dr. Zahid Bashir, all luminaries and celebrities in their own chosen fields who are here today. I'm particularly grateful to all those early birds who have braved the traffic and the fog to be here this morning, and so that we have started almost in time, especially Dr. Amir Zisa. So we have a lot of ground to cover, so hopefully we can keep the time. We have a stellar panel of speakers. One of them will be joining us on a video link from Islamabad. Dr. Mahmood Adil, he has traveled all the way from Scotland to be with us today. So I will set the scene. I should thank once again Dr. Khalid Masood Kondal, the boy from Mandi Bahauddin, who came to this college and made his way to head this prestigious institution. Just by dint of sheer hard work and his many talents. And one of his talents is that he can make you feel full of sunshine even on a foggy day like this. So thank you, Dr. Khalid Masood Kondal. So I am a clinician, so my task is probably easier. I can ask a lot of questions, I can set the scene, and I will let my outstanding colleagues who are specialists in their fields to answer those questions. I work in northeast of England near Newcastle, a place called Gateshead. I'm a gastroenterologist by profession. When I started my clinical career, I started in West Medical Ward under the professorship of Professor Mahmood Ali Malik. So because we clinicians like stories, we like clinical histories, and therefore I will start by two clinical histories. So Malik Saab one day brought in a young girl. She was only about 10 years old. She had been seen in his clinic and she could not breathe. In addition, she also had biliary ptosis. So the younger doctors in the audience, what was the diagnosis? So she had myasthenia gravis. So she was treated with the usual treatment. She eventually required a thymectomy. She came from a family who could afford to take her to America. Thymectomy operation was not available in Lahore at that time. She did well. It's a long time ago, 1986. I'm sure and I know that she is well, she has a family and she's fine. At the same time, there was another girl in the bed in the same ward. She had these symptoms. So she had come in with drowsiness, thirst, abdominal pain, hunger, weight loss, nausea, vomiting, and increased urination. So what was the diagnosis? So she had a very high blood sugar. So excellent. So she actually had diabetic ketoacidosis, and she was only 10 as well. And she already had developed nephropathy and other complications of diabetes. So she would be treated, she would get better, she would go home, and then she would come back again a few weeks later. Only because she could not afford insulin. So when you work as a clinician and you come into contact with this deprivation and ill health and simple things which can make a difference between life and death, it does affect you. So there were lots of people who would make voluntary efforts to help patients. There were student organizations, there were blood donation organizations, there were organizations for helping the poor people buy medicine. But my question is, and my comment is, and I've always thought this, that health is not access to health care is not charity. It is a human right. So there are lots of people who have done a lot of work. My class fellow, for example, Nasir Islam Bhatti, he has provided clean drinking water in his own village in Gadamala. Another class fellow, Asif Jah, he is a civil servant, in a very senior position. He has worked in disaster relief. He has provided clean drinking water in Khair. But my view is that it is impossible to provide universal access to healthcare based on philanthropy alone. It is not charity, it is not philanthropy, it is the duty of the state and the right of the citizen to have access to healthcare. I'll tell you another story. So I went on to work in Gagaram Hospital. I worked in this was early 90s. I worked in the medical unit. I've done my part 1, I was ready for my part 2. We had a professor, we had an associate professor, we had an assistant professor, we had 2 senior registrars, 3 registrars, 4 medical officers, 16 house officers for a ward of 25 beds. So we were well provided in terms of workforce. So I went to visit my friend Jaula, who was a district surgeon in Kasur. And he was the only consultant in the district that I knew and still know who would go for a ward round in the evening. And when I went to his ward, it was also a 25-bedded ward. On every bed there were 2 patients. He had done thoracotomies for, gunshot wounds, Kalashnikovs, etc. And I asked him, where are the juniors, who will take the notes and carry out the orders. So he said, I've got 1 house officer, and see across the road that clinic, he's doing a private practice there. And then he took me to the medical ward, and the medical ward was empty. There was a consultant who had been appointed, but the medical ward was so empty that they had put all the beds on top of the other to protect them from dust. So Kasur is, not in Africa. It is just 30 miles from here. I'm not sure what things are like now. I hope they're much better. So, but the question is, why is the access so different in the same health system? So the argument was that the house officers should train only in teaching hospitals. They can't be trained in any district like Kasur. But the point is, have we developed our healthcare system to employ doctors or to treat patients? So the healthcare system is, obviously, I understand that doctors need to be trained so that they are up to the job. But why can't we upgrade all the hospitals so that, you can have house officers there, junior doctors there who can be trained? So things have moved on. There's a great deal of connectivity nowadays. You can use telemedicine to provide access. You can use smartphone application, WhatsApp, etc. You can provide ambulances, also air ambulances. There was a discussion yesterday with the Chief Minister about that, and they're quite keen on it. But something we need to develop and explore. So another story. I had a colleague in Gateshead where I work. She's a surgical consultant. Her uncle, who is a PhD doctor from Imperial College, was in Karachi. He had a previous gastrectomy and brought back too. He required an ERCP, which was difficult because of the post-surgical anatomy. So he went to the top hospital in Karachi. They tried for a couple of hours, they were not successful. And they said, yeah, this is it. You have to go home and, palliate the symptoms. Whereas I knew somebody in Karachi who could do the procedure, and I referred this patient to him, and suddenly asked my friend to perform the procedure, and the patient was fine. The procedure took about 15 minutes. So, why is quality so variable, quality of treatment? So, if you want to see a good quality hospital which comes up to the international standards, you should go to Shaukat Khanum Hospital. I think it is a miracle. I visited it, I wrote about it, I was fortunate that my mother got treated there and got better. But they have done something. I don't know how they've done it, but they developed the systems. They're integrated. They work, well together, and it is a whole system and or the whole ecosystem which is efficient, which works and works for international standards. Another outstanding example is Lahore General Hospital. My friend Yasin Abi Tayyab, and go and visit his unit, see how gastroenterology and endoscopy can be done. Staying in the public sector, using the limited public resources, dealing with the dynamics of the local administration, you can make a world-class unit. So I think his principles are that you have to understand the local dynamics and you have to open up to the international faculty. So you will see people visiting from America, from Britain, who come and teach and learn actually from him. So, a bowel cancer screening program in the UK is an outstanding example of how to ensure quality. So they set parameters and they set a competition. Unless you come up with that competition, neither the gastroenterologist nor the hospital can undertake bowel cancer screening. So, you know, a lot to learn from those stories. So, my last story, this is about, I was working in the chronic care unit in Gangaram Hospital. A lady, a very fine, very defined person, elderly lady wearing a sari from Hyderabad, came in with an inferior MI. She was using a bedpan under the influence of morphine which we had given for pain relief, and she fell out of the bed and broke her wrist. So this was mortifying for all of us. Somebody comes in for treatment and goes out with another problem. So she was fine, alhamdulillah. And then her son was staying there day and night. He was a lecturer at London's University, and he wouldn't go home just because he was so worried about his mother. And then a few years later, I was working in Gateshead, and I looked after an elderly lady who had come into the urinary tract infection, and told me, "Doctor, do you know my son is also a doctor?" So I said, "Yeah, okay. So where does he work?" "He works in London." "So what's he called?" So I forget the son's name now, but she said, "You know, he's the president of the Royal College. It's called Professor Albert." So a lady, you know, admitted under my care. Nobody phoned me, nobody, thought it was necessary to ask the hospital administration to look after this lady who would be very special. So there was a universality. There was, so in Britain, one of the developed systems, you have access at the primary level, secondary level, and tertiary level. And whether you are in Plymouth or whether you are at Land's End, you get the same kind of treatment. If you need paracetamol, you'll get it. If you need brain surgery, you'll get it without any cost to the patient. So I think one thing we have to do is, this country runs on goodwill of the doctors, of people who are God-fearing, who do charity and who do philanthropy. We should value that, but we should integrate that into the state system. So education, I guess I must mention, because it is known that the best way to do family planning and limit the size of the family is girls' education. So we have to integrate the social sector with the healthcare sector as well. So just very few quick words about the funding of the healthcare system in the advanced economies. In the UK, everything is free, all healthcare is free, and it is provided by the taxpayer. The hospitals are run by the government, the doctors are employed by the government, and we treat patients like you do here in your hospital, for example. So in Canada, on the other hand, people who provide healthcare, all the doctors are independent, but the patient doesn't pay. The patient goes to the doctor, gets the treatment which is free, and the doctor will send a bill to the government, and the government will pay them. So that is called universal health insurance. In America, probably the worst of the systems in the developed world, it is all private insurance. You insure yourself by paying monthly amounts, and then when you need healthcare treatment, you go to a doctor who will not bill you, but bill your company. But the problem with this system is that if you don't have the means to insure yourself, then you can run into a lot of trouble. So there are comparable economies. I think people will talk about it later, so I'll just skip over that. Where do we stand in terms of human development? So this is Kerala, southwest India. Kerala has the same infant mortality rate as America, whereas at the 1/10 of the per capita income, and their income per capita is only slightly more than ours. So why is it? What have they done that we can't do or haven't done? And they're actually different from the rest of India as well. So these are some eye-opening statistics, very simple. This is data from 2010-2015, infant mortality rate. Pakistan 70, Bangladesh 33. Sri Lanka 8, as you can see it is comparable to the UK. So we are worse than Bangladesh. We are actually the worst in the region of South Asia. So this is alarming. Bangladesh, the land which was stricken by cyclones, famine, deprivation, are ahead of us. Whereas, if you look at the income, they are still poorer than us. So so therefore, there must be some things. It can't be resources. It must be the management of resources or something else. So we have to sit down and think, what is it that they can do over the past 40 years or so that we haven't done or forgotten to do? Life expectancy, Pakistan 66, Bangladesh 72. Fertility rate for women, Pakistan 3.1, Bangladesh 2.1. Literacy rate, and I think this is a key, Pakistan 56%, Sri Lanka 93%, and Bangladesh is still ahead of us. So here are some numbers. $40 billion. I traveled on the PIA. My travel to Pakistan from Manchester was probably subsidized by you, the taxpayer, because we pay $40 billion to the PIA to keep it running. And this is the same amount of money by which you can issue a health card to all the poor families in Pakistan up to 5 lakh rupees each per year. I think it must be an eye-opener. Some other numbers. The total loss of Pakistan steel mills, 200 billion rupees. Those are, and this is the total the total health budget of Punjab per year. So, a cost of 2 F-16 aircraft, 20 billion. This is the annual health budget of Balochistan. Food for thought. So I think we need equity, equality, we need access, we need quality, we need universality, we need to monitor our outcome, and we have to think of how to fund the healthcare system. I'm sure there are many people from India here and going to be here later as well. So there cannot be any capacity without demand. Unless you are shouting from the rooftops that you need your rights, nobody will listen to you. So you have to fight for your rights. You have to raise your voice. The need is immense, but there is not enough demand. People who actually need to speak up don't have a voice. They don't have the resources. They don't have the means to speak up. So we have to speak for them. So we need political activism. We need to send our representatives to the assemblies, and we need to hold them accountable. We need to ask them that, what is it that you're doing for us? What is the timeline? When will you finish? When will you deliver? And this can happen by disseminating information, making people aware, and actually media, publication, visual media, very powerful. It is the duty, I think, of all of us that we should be interacting with them. So thank you very much. So that's my talk. I'm not sure if Tabinda is here. She wanted to say a few words. Would you like to? So Tabinda is my friend from King Medical College. We did our house job together. She is a consultant in diabetes and endocrinology in Cornwall, and she has been actively involved in teaching and training and helping out, poor patients, welfare projects in Pakistan. She has some views about, rural health access, and she wanted to say a few words.
He has said everything that I wanted to say because we didn't actually share our presentations, but mainly what stuck me when I was trying to prepare for this presentation was that it is the corruption that stuck me, that no system can survive when there is so much corruption. And the corruption is not only on the monetary level, I think it is in the intent as well. And I think patients who want access to primary or secondary care are daily affected by the corruption. The corruption that they face when they try to get in, bribing people to get in, and then bribing people to get all the needs that they have in medicine or in the care. So I think no system can survive if it is corrupt. And I think that we should admit that and get on with that and try and make ourselves fair towards the patient. And the second thing that struck me was that I think there has been a lot of emphasis on how we need doctors. But I think Pakistan is one of the countries where the paramedics are seriously outnumbered by doctors. So there's a 2-to-1 ratio between doctors and midwives, nurses and all that. So if we try to get to the grassroots level, which is the villages and the rural health, where my roots are from villages, both my parents come from farming background. And I see that every day, that the programs that were started there, like, there is a lot of emphasis now on the growth stunting of the kids. So there used to be these projects from WHO where dried milk was, for example, provided. And these dried milk were getting sold on the village shops, so people would go and buy it instead of being distributed. So again, I go back to the corruption factor. So I think we have to try and say that we have to be fair in what is there and equitable, and make it equitable and then provide it to people. The other thing that struck me was, which Athar was also saying, was that how we are lagging behind, and we take no pride in the things that we do. We're lagging behind in the region with 12 countries who have similar economic backgrounds like us, but we lag behind in our healthcare. So, and things that strike me when we go out on the roads, people don't take any pride in what they do. Even right from the way they ask you for charity, people have no pride in how they ask for things and how they do their things. So anything that we do, we should take pride in what we do, no matter how small the job is and how big the job is. We should take pride in what we deliver. The other thing was that this is the only country in the world that doesn't have a national health ministry, and so therefore I think it is a blank canvas to start off, which is what this day is about. So we all face these challenges, and I think the challenge that Athar has pointed out, the organs of maternal and child mortality, and he has pointed out that we have got very high maternal and child mortality. And again, I think the nutrition is bad, 40% of the kids are malnourished, and then the growth stunting, which is being addressed. The low public spending, the population growth, all these challenges. And I think where I come from as a diabetologist, endocrinologist, is the lifestyle factor. I think nobody is looking at the factor of how the diabetes and the obesity. So 1 in 4 adults here in Pakistan is obese. So we're talking about malnutrition and obesity in the same sentence. So basically, these challenges of smoking, poor roadworks, and ongoing issues with health like poor nutrition, we have to address those. And the screening program that Athar talked about, the bowel screening program, nobody here is aware of, like, say, the retinal screening program that the UK is running. It's the only country in the world that runs a retinal eye screening program for diabetics. I don't think the diabetics here, Dr. Asad Aslam may know, they might have a program, or they might want to develop a program for perhaps screening the eyes of people who have diabetes. It is so common. There isn't anything, and it's a cause of blindness and things like that. So there's lots of things that we can work from. So I'm not going to take much of your time, but I wanted to end my talk by a quote from John Adams, which said, "If we don't lay out ourselves in the service of mankind, who should we serve?"
Here is Professor Asad Aslam Khan. Before I invite him, can I also thank Azimuddin Zahid, my friend, whom I forgot to mention earlier. He is very active in the provincial and national politics, and also graduate of 1986 class, and hopefully will be involved in defining, informing, and actually developing the health policy in the future. He's also one of the very few people whom I can, go take ball to and who understands, which makes me happy. Apart from probably Zahid Kamal, who's also here. So, thank you, Azimuddin Zahid. Professor Asad Aslam Khan was a year ahead of me in school, and he is light years ahead of me now in developing the healthcare services in the Punjab. He is an ophthalmologist, and he will tell you what he has done in preventive strategies to prevent and cure, also to cure health diseases in Lahore, and also extending it to the whole of the Punjab. Professor Asad Aslam Khan.
Bismillahirrahmanirrahim. Before I start my presentation, I must congratulate the organizers, especially Professor Khalid Masood Golden, Professor Aisha Shokar, Dr. Saeed and Dr. Tabinder Dugal for arranging this important symposium on universal health care, which is a great response to achieve the Millennium Development Goal and a great response to World Health Assembly resolution on universal health care, of which obviously eye health is an essential component. My talk is basically focusing eye care services, how we plan a strategy to provide equitable eye care services to the masses at the community level. To meet the challenge of providing equitable eye care in Pakistan, this is in fact a success story based on public-private partnership for the whole country. I must acknowledge the Government of Pakistan, the Provincial Health Department, the World Health Organization, and the international NGOs, mainly Brian Fodder Regional Institute, CBM Germany, Red Hollows Foundation Australia, and Sightsaver UK, who made a tremendous contribution in this strategic plan. Let me start from 1947. We all know freedom, partition of India, and birth of Pakistan. It gave a mixture of joys and sorrows. Indo-Pakistan wins freedom, but the partition caused death, disease, destruction, and displacement of some 20 million people. Our main challenges were rising population, aging population, poverty, illiteracy, extremism, political instability, and regional conflicts. We are more than 200 million population now. Aging is another challenge, and ignorance and disease, they all ultimately lead to poverty, deprivation, extremism, and violence. And in Pakistan, 40% live below poverty line, and average literacy rate less than 50%. 1947, what was the situation of eye care services? There was only few missionary hospitals, Sir Fadden and Sons in Quetta and Shikarpur, Novel Christie in Texla, Mayo Hospital in Lahore, Civil Hospital in Karachi, and few family-owned cottage eye hospitals. 1950 to 60, new eye department came up in public sector, mainly in Karachi, Multan, Peshawar, and armed force hospitals across the country. But no organized services were available to 80% of the population. These are the two gentlemen, Professor Nadet, Lieutenant General retired Wajid Ali Barki, and Professor Raja Mumtaz, who ultimately throw some light and made tremendous effort for eye health. 1962, it was a golden period for Pakistan. College of Physicians and Surgeons, JPMC, Pakistan Medical Research Council, and Pakistan Medical and Dental Council were established. 1980, it was a wake-up call. When Professor Hugh Taylor from Australia, he visited Pakistan, he was appointed by WHO to have some idea about eye care services in Pakistan. And he reported that the prevalence of blindness in 1980 was more than 2%. 80 ophthalmologists for 100 million population in the country. There was gross human resource mismatch. Cataract was the major cause of blindness, and 45 out of 64 districts at that time were without ophthalmologists. 1998, we did situation analysis of eye care services in Pakistan. And these were the results that at teaching hospital, in every teaching hospital, technology was 10 to 15 years old. out of order equipment, no concept of or existence of such specialties like vitreoretinal, pediatric ophthalmology, glaucoma, and cornea. There were no posts of community ophthalmologists, optometrists, refractionists, orthoptists, ophthalmic technologists, and ophthalmic technicians. There were no programs for continuous medical education or skill development of district ophthalmologists. At DHQ level, 53% of the DHQ were doing intraocular lens implantation. In every DHQ hospital, technology was 15 years old. There was no separate operation theatre. Eye surgeons used to share with general surgery, orthopedic and gynae. There were single room OPD. There were no post of optometrist, ophthalmic technician. Cataract operation per year ranged from 0 to 300 per year. Affordability was another challenge. Poorly organized and unsupervised eye camps and no referral team. At DHQ level, 98, no eye department, though no eye specialist post was there. There was no post of optometrist or ophthalmic technician. At RAC, no eye care services or screening services, and no post of optometrist. And none of the lady health workers had any training of primary eye care. So 46% of the district were without services, and with 54 ophthalmic microscopes were available only in 54% of the districts. This was the total number of ophthalmologists trained in intraocular lens implantation in Pakistan. This was a total outpatient and total number of surgeries across the country in year 97. And only 17% of the surgery they were being done with intraocular lens implantation in 97. This was the status of human resource at district level in 98. You can see almost no ophthalmic technician, no essential eye care services was available at district level in 98. Cataract surgery 0 to maximum 300. And this was the situation of human resource in 98 in Pakistan. There were less than 1,200 ophthalmologists. There was no post of pediatric ophthalmologists. Only 2 vitreoretinal surgeons were there, but they were doing general ophthalmology and vitreoretinal. No post of optometrists, no post of investigative oculists, orthoptists, ophthalmic technicians, and none of the primary healthcare workers were trained in primary eye care. And the prevalence, and in year 2002, we did a survey and it revealed the prevalence of blindness of 0.2%, 9% in Pakistan. So this was what we had. Then the National Committee for Eye Health, which is working under the Ministry of National Health Services, Regulation and Coordination, we planned for a national plan. So the results of situation analysis and the national survey to meet the challenges of Millennium Development Goal, to provide the latest technology for eye care at different levels, to develop infrastructure at different levels, to provide human resource at different levels of health care, and to provide the facility of eye care at the doorstep of the world. To meet the global initiative Vision 2020, to which the government of Pakistan is signatory, and to honor the World Health Assembly resolution on Vision 2020, the objectives, targets, and strategies for a national plan for eye care were determined in a major planning meeting of the National Committee. An objective was presented to the Ministry at the 7th meeting in April 2005, and the concept was to train and deploy ophthalmic team at Center of Excellence, teaching hospitals, district level, and sub-district level, to provide latest technology for eye care at all levels of healthcare, to develop infrastructure at Center of Excellence, teaching DHQ sub-DHQ level, to impart primary eye care training to primary healthcare workers, to develop refraction and low vision services at district level, and to develop capacity in research in 7 centers of excellence across the country. Subspecialty was another part and essential component of the plan. Our main focus was pediatric ophthalmology and vitreoretina. So, the plan was to provide technology, human resource and infrastructure, 7 centers of excellence, 20 teaching hospitals, 63 DHQ hospitals and 147 THQ hospitals. So 4 centers were identified in the country. One in Peshawar, Pakistan Institute of Community Ophthalmology, one College of Ophthalmology and Life Sciences Mayo Hospital, one in Balochistan and one in Sindh. And after training the essential human resource, this is the situation over a period of 15 years. Now we have ophthalmologists more than 2,400 in the country. We have doctors practicing surgery, eye surgery other than degree holders, 450. We have now vitreoretinal specialists, 46, and 2/3 of them, they have been trained by King Edward Medical University through College of Ophthalmology. We have 30 pediatric ophthalmologists in the country. Again, 2/3 they have been trained by King Edward Medical University through College of Ophthalmology. We have 92 community ophthalmologists, and we have now 37 training institutes in the country to train these people. These are the figures after training during the last 15 years of Allied Vision Sciences personnel, which are optometrists, orthoptists, ophthalmic technologists, ophthalmic nurses, ophthalmic technicians. At present, during the last 15 years, in Pakistan we have trained more than 1,700 optometrists, 84 investigative oculists, more than 50 orthoptists, receptionists, ophthalmic nurses, and ophthalmic technicians. Now we have 20 institutions during the last 20 years in Pakistan who are imparting training to Allied Vision Sciences personnel. This is the situation of available eye care services at different levels of healthcare. In Punjab, we have 18 out of 18 tertiary eye care department fully operated for eye care services. Sindh, KPK, Balochistan, KJK, so all the teaching hospitals across the country, they have been upgraded. This is the situation of district level. Only 47% had eye care services. Now you can see more than 80% of the THQ hospitals across the country, they have a good eye care services. Now this is THQ level. No THQ hospital had any eye department or ophthalmologist. Now, if only in Punjab, out of 103, in 79 new eye departments have been established in THQ level, and 47 ophthalmologists, they are available, they have been recruited. The rest of the eye department where there is no ophthalmology, the eye patients are being screened by optometrists, and they are being referred to the nearest district health hospital which have ophthalmologists available. This is the situation of establishment of new eye department at sub-district level in other part of the country. And more than 70,000 lady hair workers across the country, they have been trained in primary eye care. Now the primary eye care module is an essential, is a chapter in the lady hair curriculum of the lady hair workers, and refresher training are regularly being imparted. So this is the impact of intervention. You can see, you can compare 98 versus 2016. Ophthalmologists, the figure is more than 2,400. Pediatric ophthalmologists, none now available in the public sector, they are working. Vitreoretinal specialists, none to 14. Optometrists, none to 520. Investigative oculists, none to 44, and so on. These are the posts created by the government of Pakistan, not only in Punjab but in other provinces through the national program. And more than 80% of these posts have been occupied after due advertisement. Impact of the eye care services at district level. At district level, during the last 15 years, we made a comparison. There is 97% increase in attendance in the outpatient department. 94% increased access by the females. 111% increase in access by the children to DHQ and THQ level. There is 81% increase in the number of surgeries and 78% increase in the intraocular lens implantation. This is the pattern of disease at DHQ level. The figures in green, these patients were being referred to teaching hospitals. Now they are being examined at the DHQ and DHQ level in Pakistan. And cataract surgical rate during the last 15 years from 300 it has crossed the figure of 3,000 per year. This is a comparison of ophthalmic services. 98 was in 2017. You can see the ophthalmic technician, essential equipment, intraocular lens implantation, everything has remarkably increased. The impact on subspecialty development. Now we have a vitreoretina and pediatric ophthalmology center, 6 in Punjab, 5 in KPK, 4 in Sindh and 1 in Balochistan. And I have the honor to tell employers that these persons were trained at College of Ophthalmology and Library Sciences in Gadar Medical University, and then they went back to their own provinces and they started these centers. And now these centers are being subsequently approved for further training by College of Physician and Surgeon and by the universities. Impact, now cataract, the kits are being provided at a very affordable rate for free of cost. Trachoma is near eradication, children are being screened, diabetes-related blindness, the patients are being screened, same is true for glaucoma and for low vision. Now, way forward. Now we started from teaching, now reached to the DHQ level. Now we want to move further. Our next strategy for the next 5 years is establishment of eye screening and service delivery centers at rural health centers across the country. By creation post of optometrists, they will screen, they will do the refraction, they will prescribe glasses, and they are competent enough to diagnose cataract, glaucoma, diabetic retinopathy, and age-related macular degeneration, and refer these to the nearest DHQ and teaching hospital where the services are available. And obviously, we will provide equipment. Our next target is in the next 5 years, training of the nutrition supervisors and school teachers in vision screening. We have already requested the Honorable Minister for Health and Minister for School Education to incorporate a column of eye health in the annual report, and no child will be promoted to the next class unless his or her vision is mentioned in the annual report. So he has agreed, and hopefully it will be done. Our next 5-year plan is provision of PEEK, the portable eye examination kit to lady health workers, and they will be connected to the rural health centers or to Tehsil Headquarters Hospital. And the patient who have some eye diseases, they will be referred to the nearest eye care facility. Professional and international NGO commitment is there. All we need is continuous political and bureaucratic support and will, and inshallah we will keep the target. Thank you very much.
Excellent presentation. The next speaker is Professor Sarwat Hussain from Worcester, or I don't know whether the Americans call it Worcester. I was penalized for saying Worcester in England, where the original Worcester is, or Worcester is. So he is a professor of radiology. He will talk about how to reduce medical errors and improve quality. Professor Sarwat Hussain.
Assalamu alaikum, ladies and gentlemen. Bismillahirrahmanirrahim. Thank you to the organizers for organizing such a wonderful program in this glorious setting. My topic today is about opportunities of healthcare quality improvement, reducing the risk for harm. Now, I remember in 1969 when I graduated, I took oath of Hippocrates in this very hall at the convocation. And one of the first part of the oath is not to do harm. Do no harm. First do no harm, and then you do some good. But in our practice, we know that surgical site infection is not uncommon. but we also know that 50% of the surgical site infection in elective cases can be reduced only by washing hands. And it has been shown also in Sri Lanka, for example, the reduction in surgical site infection can be as much as 70%, only if you get the doctors and the nurses to wash hands before they perform any procedure. We also have seen that the way to wash hands has been prescribed internationally and universally as how to follow the process of disinfecting hands. More lately, we have sanitizers that will do that job with much less resources and much faster. One of the commonest medication errors is the wrong dose given to the patient, which causes loss of life, as we will see the data in just one moment. Non-compliance to the processes such as checking the oxygen cylinder before they brought to the operation theater or at the site of service. And errors, clerical errors in blood transfusion has led to death of many individuals. And the clerical error is really checking the parameters of the patient and matching with the parameters of the blood that is being infused. We also know that 89% of pregnancy-related deaths are in fact preventable, which is a very large figure. And similarly, 3 major preventable causes of infant death include severe infection, complication from preterm birth, and poor antenatal care. So statistically, now these were the anecdotes, but here are the statistics that have been reported from Pakistan and from across the world. The president of the Pharmacists Society of Pakistan has stated in an interview that as much as 500,000 deaths occur due to medication errors in Pakistan. And figures from UK is as many as 850,000 medications error yearly can occur in the US. But the most striking number is from the United States, where in an article published in June 2017 at BMJ, no less, stated that an estimated 251,000 people die of medical error in the United States. It has also been estimated that 4.8 million deaths occur in low and middle income countries due to poor quality of health care. But there are other high-risk industries, and medical health care actually is an industry, of course. We provide services to the patient, and we follow the results. The industry has gone much further than healthcare in their safety record and their safety practices. One of the industry that is of high risk is aviation industry, and let us see how aviation industry has achieved quality in order to reduce or virtually eliminate risk of harm to its customers and its patients. As we just noted that up to 251,000 people die of medical errors in the United States, the third commonest cause of death in hospitals after heart disease and cancer. Figures from aviation-related deaths in the United States for the same year, 2013, are 224 compared with 251,000. There is something wrong with this picture. What happened? How did the aviation, and for that matter, other industries, have achieved quality in their business? Now, the aviation industry developed processes and systems. They predicted possibilities of error and made corrective action in the processes so that the chance of errors, chance of mistakes, chance of variation in certain processes does not occur. And medical healthcare needs to follow this. Now, when we talk about terminology in any situations, we need to define it also. Now, what is a process and what is a system? Now, a system is a group of processes which are interrelated with each other. Now, what is a process? Process is actually being able to do certain action for certain ends. And here is a good example of a process. A process of wudu before salat. Everyone does it in the same way. Everyone does it to prepare for namaz and salat. And it is followed even if nobody is watching. And you need to make sure that if there is an error in the process, that you do the process all over again. If we can define the steps and the processes within healthcare and follow it to the extent that we do for salat, before salat, for example, we could reach the safety standards of the industry. Now, how did industry actually start? Early in 1900s, the two masters of healthcare quality who introduced the processes in manufacturing were the Walter Sheward. And Walter Sheward, PDSA cycle, owner of the PDSA cycle, is the person who started a repeatable process in manufacturing industry, provided by the philosophy of Edward Deming, who was one of the pioneers in healthcare, in industry, by virtue of which the Toyota and Bell Labs were pioneers in the quality of manufacturing with very little or very little faults in their manufacturing processes. Similarly, the aviation followed. Each and every step in aviation is listed, and irrespective of the fact how experienced the pilot is, the pilot has to go through the steps that have been defined for a certain process within the aviation industry. Now, healthcare was late in adopting the lessons learned from the industry. And this was done by Donald Berwick, and I'm sure there are other pioneers in healthcare quality improvement in the UK and the rest of the world. But Donald Berwick was one such individual who brought the lessons from industry into healthcare and started an Institute of Healthcare Improvement, which is still functional, and brought the process or system of evaluation, processes, and protocol into healthcare in order to improve quality. Following this, there were bodies that were regulatory bodies that were established in various parts of the world, whose job it was to legislate and implement the legislation in terms of healthcare quality. For example, the Punjab Healthcare Commission is one such body that is responsible for instituting healthcare quality improvement in Pakistan. People have heard about Joint Commission International, which is another private institution in the United States, and the Joint Commission for United States that is within the country, and Care Quality Commission from the UK. The owner and the pioneer of that, Dr. Adam Mahmood, is here and you will hear his talk later on. Now, the healthcare itself is a huge part of human rights, as Dr. Athar said. The WHO came up with the Agenda 2030 to transform the world. The United Nations General Assembly approved 17 Sustainable Development Goals for the world to achieve by 2013. Of these goals, goal number 3 is for good health and well-being, ensure healthy lives and promote well-being for all at all ages. And this is to do with universal health coverage, which is the topic of today's seminar. Following this, there was a debate in the healthcare as to how to achieve the Sustainable Goal Agenda number 3 to provide healthcare effectively to the citizens of the world. Various commissions, various bodies, various webinars were held around the world, and I'm going to give 2 or 3 examples here. For example, Lancet Global Health Commission was formed, which consists of large number of academicians, policymakers, healthcare experts from 18 countries in order to find the answer as to healthcare quality system in the sustainable goal era. And this was one part of the report that the Commission came up with, and the conclusion, one of the conclusions was that high quality health system could save over 8 million lives in the low and middle income countries. Another group organized by the Organization of Economic Cooperation and Development, consisting of 36 countries, IMF, World Bank, and OPEC, they have developed recommendations for the rest of the world on delivering quality health care, a global imperative. And they concluded that optimum health care cannot be delivered simply by ensuring coexistence of infrastructure, medical supply, or even the provider. Improvement in health care delivery requires deliberate focus on quality of health services. In other words, if there is universal health care without quality, as we will see in a little moment, it will not have the desired effect. Access without appropriate attention to quality will not lead to the desired population health outcomes. This was the conclusion of the OECD Commission. And quality of care must be seen solely as a concern, must not be seen solely as a concern of high-income countries or addressed when access has been expanded. Which means that you should not wait for to bring in the quality after you have solved the basic problem of access. It has to be part, quality improvement has to be part of all plans, all systems to deliver healthcare quality. The healthcare quality in low and middle income countries, there are obviously constraints of resources in low and middle income countries. And, but even in those situations where the resources are very short, there will always be a number of low resource starting points for the healthcare quality improvement. It may be, for example, getting people to wash their hands. Getting people to wash their hands can, as we said before, reduce substantially the post-operative infection rate. A focus on quality should promote more efficient, effective and integrated service that increases value for money, it provides. Value can be provided if there is quality. If there is no quality, all the investment can go down the drain. And here is a practical example from India, where Janani Suraksha Yajama was a program introduced by Indian government between 2005 and 2015, where they provided cash incentive, money to the women to get facility birth instead of birth at home with midwives and dyers. They were giving money if they were to go to facilities, government facilities for birth. Over the period of 10 years, approximately 9.2 or close to 10 million cases were delivered under this program. And the money that was spent was substantial. 15 billion rupees, Indian rupees, were given into the system to increase the facility deliveries of childbirth. You would be shocked to know that there was no statistical improvement or reduction in fetal or maternal mortality rate after intervening at such a large scale. And the reason was that the quality of care was not sufficient in order to make a difference. It is not enough to get the women to institutional delivery if the institution itself or the people who delivered the care in that institution are not better trained than the dyers at home. And therefore, high quality of care is essential in order to bring change or improve healthcare indicators even in very large scales. So here is really the message that I wanted to convey today. Performance improvement requires organizational philosophy and top-level commitment to quality improvement. And this is the most fundamental issue that we face in developing worlds. Now, what do I mean by that? Top-level commitment comes from the head of the state, the head of the government, the head of the health services, the secretaries of health, the vice chancellor, the head of the department, the head of surgical units, and the head of groups. Until there is top-level commitment from the top, the resources will not be assigned, and we will continue to fund our health care at less than 1% of our GDP. If the, let's say, the Minister of Health or Secretary of Health are not committed, they will blame the doctors and the nurses on the floor why they are not producing, why errors are occurring, and why the patients are not satisfied, because the resources have not been allocated to at the delivery points. So top-level commitment is extremely important in order to make sure that resources are provided, that protocols are produced, that processes and systems are in place, and they make sure that they are being implemented. And there needs to be a creation of culture of quality and continuous skill improvement as the body of knowledge increases in healthcare, and building excellence and quality in every aspect of the operation that you do. For example, this setup is a high quality setup with the surroundings, with the audio visual, with everything that you see in this. And this is a testimony to the fact that the head of the institution, Professor Gondal, is committed to quality, and it is his leadership that has led to infusion of quality in the rest of the people, leading up to such a wonderful program. In the end, I will have to set a plug, because what I'm doing, what I've said, I've tried to do it myself. I'm a radiologist, but earlier this year, I thought of the fact that healthcare quality, we all sit at the dinner table and complain about how badly such and such person was treated, and then there becomes a debate. Everybody wants to one-up the previous story, and the story ends up usually by the fact that a cat ate an infant in one of the government hospitals in Pakistan, and then everybody kind of stops discussing. So earlier this year, I took upon myself to do my bit in healthcare quality improvement in Pakistan and launched a little company, Global Institute of Healthcare Quality, because I had experience with Joint Commission in the US hospitals, JCI in one of the Middle Eastern hospitals, and of course, as a senior member of the department, was responsible for preparing the department for the inspection. We are working to train staff who can later become quality officers in the institutions, because remember, there is no culture, there is no history of training quality officers in this country. And we also come into the institution and do quality audit, as we did for emergency department at Mayo Hospital, and come up with the gap analysis and recommendation for implementation. This is one-man personal effort, and we have offices in Lahore and Massachusetts. Please, anyone who wants to volunteer students for research into healthcare quality and experts into helping forwarding the agenda of healthcare, and Dr. Mahmood from the UK is one of the pioneers in UK healthcare quality. I invite him also, and all other individuals who are here, please help us in this endeavor for the benefit of Pakistan. Thank you very much, ladies and gentlemen.
Before I welcome Khalid Gondal, who's the next speaker, can I introduce to this audience Professor Dr. Tanzim Haider Raza. Is he in the audience? Yeah, so welcome, sir. So Tanzim Haider was senior to us in college, a firebrand student leader who was a revolutionary. He went to Britain and joined the Imperialists. Or there is, I think, controversy whether it was the Imperialists who joined him. So he was honored by the Queen for his services in setting up acute medical units and developing the structures. And he is the officer of the most distinguished order of the British Empire. So Dr. Tanzim Haider Raza, OBE. Welcome, sir. I also welcome Professor Aisha Shaukat, my fellow moderator, who is known to transform these meetings with her magical touch. And also Aisha Najib, who is representing Kamkana. She has done a lot of work in pediatrics, in deprived populations, and also has done a lot of social welfare work in Pakistan and remote areas of Muzaffargarh, helping affectees of flood. Welcome, Aisha Najib. Professor Khalid Masood Godal has done a lot of work in medical training in collaboration with the Royal College of Physicians. So he can be a key to developing a medical workforce in Pakistan in future. So he will share his vision and his experiences with us. Professor Khalid Masood Godal.
Thank you, Professor Akhtar Ahmed Saeed, Professor Saeed, Chairman of Pathology, and Dr. Azimuddin Zahid for this innovative idea of this very important seminar, and I am sure in the end we will have some guideline for some policy for national health. Next 20 minutes I am going to discuss something about the current challenges in the field of medical education, some strategies to cope with those challenges, the medical workforce available, and the training of this workforce nationally and internationally. As far as the challenges of post-medical education they are concerned, There are global challenges and challenges specific to our region. The challenges, they are according to the training, variation of training, and induction of postgraduate residents, and challenges during the phase of the training. In the training framework, the challenges, they are related to the accreditation of the institution, standard of various institutions in the country and abroad, accreditation of the supervisor, who should supervise these training. Then the curriculum, whether we have revamped these curriculum or not, what model of the training should be implemented, are these students, they are really supervised or not, and there is a proper system of monitoring available or not. Then challenges related to the evaluation, examination system, whether that is standard, structured, transparent, and something about the certification. As far as the globalization of medical education is concerned, you know everybody, there are models. In the past we used to have the process-based, product-based, apprenticeship-based, and currently the model is the competency-based, the outcome-based. And the focus of medical education in general, and particularly the postgraduate medical education, has shifted because of the enhanced healthcare expectation of society, accountability demand, exploring in the knowledge and technology and information technology. Then the global challenges, they also include diverse in the standard of undergraduate medical education, and this is also true in Pakistan. Variation in the clinical practices, disease pattern, diverse ethnic, culture and social background, language barrier, and these challenges also operate even in the same country, in Pakistan also. These specific challenges, they include, around 50 years ago, there were very few people who were opting the local qualifications. Most of the people, they used to go to abroad, UK and USA for qualification. But now, College of Physician Surgeons in Pakistan established in 1962, and the universities. Now because of the credibility of national qualification, now the things have been changed. A lot of people, they are being inducted, and there are issues related to quality of the training and monitoring. The specific challenges faced by the postgraduate medical education in Pakistan, that include rapidly expanding network of postgraduate medical education, inadequate preparation, and another important is male to female ratio. When I was graduating from King Edward Medical University, we had 20% female students. Currently, the ratio is another way. 20 to 30% are the male, and more than 70% are the female. And when you go to the postgraduate, around 50 to 55% they are the female. And when you see in the practical field, the 25 to 30% they are practically working in the field. Then monitoring, examination and quality assurance. The proposed strategies to cope with these challenges, I think these are important for Akhtar Ahmed Saeed also. We should have the defined policies, uniform policy, uniform criteria for accreditation, and there must be the criteria of de-accreditation of institution, supervisor and the monitoring system. The curriculum, they need to be updated. There should be timeline and minimal standard of induction, uniform system, effective monitoring, and preferably through the electronic monitoring system. Faculty should be properly trained through a continued medical education and continued professional development, revamping of examination system, including the incorporation of some latest like on-site monitoring and on-site assessment, then computer-based examination, implementation of quality assurance tool in letter and spirit. As far as medical force that is concerned, something about the medical institution, general practitioner available in Pakistan and registered specialists. This is, I speak the current statistics. Currently in public sector, we are having 55 medical schools, and in private they are 103. So private currently is ahead of our public. So total number of the medical schools and the colleges in Pakistan, they are 158 presently. As far as the faculty is concerned, this is today's figure. In medical registered faculty in Pakistan, Medical Dental Council is 23,361, whereas the dental faculty, they are 528. Similarly, the registered medical practitioner in Pakistan, they are 244,000. 178,000 are general medical practitioner, and 20,000 they are general dental practitioner, whereas the specialists they include 43,000 and dental specialists they are around 2,000. I think this is around 1/3 of the requirement of Pakistani population. The number of general practitioners, as I already mentioned, the MBBS 178,000, BDS 20,000. Specialists 43,000, in dentistry around 2,000. Now, College of Physicians in Pakistan, along with the university, is the main body providing the specialist force to this country. And the current statistic of the college is 32,000 specialists, they are the member and the fellows of their college. Out of these 32,000, 22,000 they are having the major qualification, the FCPS, and over 9,000 they are the MCPS. And currently 22,000 training, they are in the process of structured training program, and they have got the system of accreditation of the supervisor and the trainee. 3,400 are the supervisor and 285 are the accredited institution in the country and abroad. This is the province-wise ratio of CPSP. The major chunk is in the province of Punjab, around 55%. This is the 11,126 I would say, they are in the Punjab, followed by the Sindh, then KPK and the Balochistan. Now this is something we must consider. When we were doing the post-graduation, 15 to 20% was the ratio of female and the rest was the male. Now the female ratio is 54% and 46 are the male. I think female are more hardworking and more inclined, but we wish all these females should be properly utilized in the field also for the aid in humanity. And if you see the ratio of male to female in the province, the Punjab male 42%, the female 58%, Balochistan 50-50, Sindh more female like 61%, AJK 75%, KPK has got a little control, I don't know how. The female ratio is 37 and male is 63. When we make a policy, we must see the justification of this ratio in undergraduate, in the postgraduate system, and then the utility in the field and in the specialties. There are various systems of monitoring. One system of monitoring which the college has is the electronic monitoring system, and effective monitoring system is very important to address the issue of variation of training. Capacity building is very important. Professor Aisha Shaukat is very effectively looking after the Department of Medical Education of King Edward Medical University, and here we are having a regular training courses for under and postgraduate. The statistic of CPSP is that they are having in last 5 years the instructor and provider course, there is advanced skill department, 23,000 participants, they participated in the provider course and around 500 in the instructor course. They are having these advanced skill courses, and we are going to have these advanced skill courses for King Edward Medical University also. And then in the evaluation system of Pakistan, we generally involve, especially the CPSP, the external examiner, and just we wanted to know how our evaluation system is going on, and the feedback is taken from the president of the Royal Colleges and other examiners, and in the light of feedback, we try to improve our system.
I think if we're going to have international...
He is the president of Royal Auspician College, Michael Holland. He was external examiner with me in our surgical examination, and we just asked him, how do you feel about the evaluation system of Pakistani qualification?
I think if we're going to have international class care for our patients in our hospitals, then we've got to expect international class academic qualifications. And I've just spent some time here being an external examiner, and I was very impressed by the rigor training of all of the people who sat the examination, and particularly the professionalism and the transparency around the process, which was world class, and the quality of the material presented for the trainees. And I think people in Pakistan can feel very comfortable that their surgeons and no doubt their physicians are very, very well trained by this college. And from my experience as an examiner in my own college, the standard is absolutely world class.
Mentioned about one word of professionalism. A professor of medical education, Professor Junaid Sarfaraz, is sitting in this hall, and he is the teacher of medical professionalism. That is very important competency, need to be inculcated in our postgraduate resident. Then Atar mentioned to me that you should discuss something about the foreign exposures of this training to the foreign training program. Currently we are having the MOU with the Ireland and the UK, and our postgraduate training, they are getting training for 2 years in Ireland and also in the UK through Health Services Executive, and this is the interview going on through video conference, and 361 training, they are getting training in Ireland for 2 years, and through this MOU signed with Health Services Executive. And 3 years ago we also signed with MOU with the various Royal Colleges, and I must again recognize here and mention Professor Tanzeem Raza. He is the founder of our training in UK. He was the member of Council of Royal College of Physicians in 2008 when we first time visited Royal College of Physicians, and because of his relationship with the Royal College, Professor Ian Gilmore and the whole council was standing outside the Royal College of Physicians to receive us. And then we opened the door of training in the UK, and since then we are sending our training in various programs. Currently in University Hospital Birmingham, 108 training they are working, in Russell Hall 47, in Walsall 30 training, and in Hull and East Yorkshire 28 in junior fellowship and 50 in the senior fellowship program. These are the numbers of training presently working in 11 disciplines in Ireland, 287. The program started initially with 8 disciplines and then expanded up to the 11 disciplines. And the beauty of this program is that each and every trainee has to report back to Pakistan after 2 years. Adil yahan baithe hain, Tanzeem sahab baithe hain. Ye tasra jab कि पाकिस्तानी वहाँ जाके तो वहीं के न रह जाए शादियाँ करने ट्रेनिंग सिस्टम में, but there is a control on this system, and the training of 2013, 14 and 15, 99% training they have reported back. सिर्फ एक training skip हुए, and is part 1 and other training that was cancelled, and now he is requesting to reinstate his training and he is trying to report back. This is the compulsion that they have to come back to Pakistan. They will report Pakistan for at least 2 years, serve the people of Pakistan, and then they could go abroad. This program was picked up by the World Health Organization, and they declared this program as a role model. And there was a documentary on CNN and Al Jazeera. I just wanted to share the clip of that documentary.
The International Medical Graduate Training Initiative is a 2-year program where trainees come from the training programs in Pakistan. While they're here, they're still registered with the college in Pakistan. Their training here is recognized by the college, so we're not prolonging their training. And then ultimately what we're hoping is that they want to go back to their own country and that we're not depriving that home country, in this case Pakistan, of a really precious asset. Our international.
And another important thing, when they trainee go there, they work there, the feedback is they are happy. They work in the evidence-based medical environment, some financial incentive, and they learn something from these people. And the most important competency they learn is the professionalism and ethics. एक बच्ची वापस आई, मैंने उनसे पूछा कि आपने क्या सीखा? कहते सर और कुछ सीखा है तो नहीं सीखा, मैंने 2 साल में पाकिस्तान में इतनी मरतबा सॉरी और थैंक यू नहीं कहा जितना मैंने 1 महीने में आयरलैंड में कहा। तो हम यहाँ पे भी सीख लें अपने इमरजेंसी आउटडोर में बैठे हुए पेशेंट को सॉरी और थैंक यू कहना। This is feedback of one of the trainees, what he has learned when we expose them to the foreign training program.
Dr. Mohammed Always is working at the Coogan Women and Infants Hospital in Dublin, Ireland. He's come from Pakistan as part of an innovative scheme to give foreign doctors specialist training. When his 2-year stint here is over, he will return to Pakistan.
As per my contract, I have to go back home after completing 2 years of training and get my fellowship degree. And try to implement good things, positive attitudes over there in Pakistan.
Now this is the official website of Royal College of Physicians and Surgeons Ireland. In July 2017, 33 doctors they landed in Ireland, and we accredit their supervisor and institution also. And on this website, they have written, we are delighted to welcome these 33 doctors. On last time, the Royal College's the president representative, they received them on the airport. They had the official dinner in that the building of Royal College of Physicians. And then the last line they have written, we wish them the very best of luck. और फिर 1 लाख मरतबा वेलकम कर रहे हैं. I think जो हमारी एलुमनाई इस वक्त आयरलैंड, यूके, अमेरिका, कनाडा में you are working, you are the ambassador of Pakistan. ये आप लोग हैं जिनकी वजह से पाकिस्तान का, पाकिस्तानी यूनिवर्सिटी का, पाकिस्तानी कॉलेजेस का नाम है. Because of your work, now they are giving respect and honor to us. ये इज्जत आप लोगों की वजह से मिली. Then we have got the monitoring system of these training we are implementing in the colleges and the universities. And every year we interact with these training. Last year I was deputed to go there and I gave a presentation about the electronic monitoring system of Pakistan and the CPSP. Their president, they are there. And in the end, they were very happy with the monitoring system of our postgraduate program. And Alice McGorman is their health services chief, you all know. She has been the president of Royal College of Surgeons Ireland and presently she is the chief of health of Ireland. She wrote, Dear Professor Gondal, I wish to let you know about the response of your CPSP e-log system. My colleagues here in NDTP, along with our training bodies, were hugely impressed. They all are saying we should introduce something similar. I think this is a satisfying thing for us that some Gora is saying that we should introduce something similar that could be used for all training body here. At present, all training bodies use a different system, so they cannot talk to one another. They all ask me to pass on their contribution to you and the college. Atar and Dr. Tabinda and other colleagues from UK, they are there. Through MTI scheme, some of the residents, they are working in UK also. Last year, 322 they appeared, 64 they are presently working. Out of 283, 58 they are working. And then we had the meeting with the Saudi Health Commission just to tell the Saudi people that the Pakistani doctor, they are equally good. उनके सऊदी वालों के पास होता है ना जी, अगर रंग थोड़ा सा गोरा हो, पासपोर्ट डिफरेंट हो, अट्रैक्शन इज डिफरेंट. But we have told them this green passport and these brownish people, they are more competent than these whitish people. So जो सऊदी अरब के current regulations हैं, these are the current regulations. इसमें पाकिस्तान की qualification that has been equated with the international qualification, and people will be directly appointed as a senior registrar and the consultant. And let me tell you, in the same qualification, they have written the Pakistani qualification is higher than Indian, Sri Lankan and Bangladeshi qualification. अभी अतर साहब स्टैटिस्टिक दिखा रहे थे बांग्लादेश, इंडिया और पाकिस्तान का. I stand here and I say, in the field of medical education, Atar Saab, in the field of medical education, training and monitoring, Pakistan is far ahead than the sisters country, India, Sri Lanka and Bangladesh. I think last month the Chinese vice chancellors and their president, they visited Pakistan. The Canadian people, they offered all their support. And we had the meeting with the president of various royal colleges on the similar collaboration and international training. Something about the King Edward Medical University. Now the experience which I have gained from the international exposure since 2008 onward with my friends like Tanzim Haider and others, now we are utilizing that for King Edward Medical University, and our objective is the trainee of King Edward Medical University should be exposed to the best training center in the world, UK, Ireland, Canada and America. Already our undergraduate, they are going for limited time, and inshallah in the future the training of King Edward Medical University will be specifically exposed. And during last 6 months, I think the delegates from all over the world, they have visited King Edward Medical University and they have offered their wholehearted support. This is the letter which I received from Royal College of Physicians Surgeons Canada, and this is the first of its kind. I've been going there for the last 10 years in the International Medical Educator Leadership Forum, and Andrea Patmos and Professor Shangon is their president, and they have written to the Vice Chancellor King Edward Medical University, and they have extended the wholehearted collaboration and support. And my request to them is, our undergraduate, they are going to US for their rotations. I will request them that some of our undergraduate students should also avail the facility in Canada also. And then, with the courtesy of Saira Afsal, Professor Sheila, the Professor of Tissue Engineering, she visited King Edward Medical University, and we are going to have collaboration in the field of research. We have established a new department in biomedical engineering, and inshallah with this expert, the collaborative research will continue in King Edward Medical University. This gentleman I mentioned, Professor Zhu, he is Professor Mila. He is the president of, he is the president of all the vice chancellor of China, Chinese Medical University, and we had a formal meeting with him at King Edward Medical University, and Chinese Medical University and King Edward was declared as the sister university. Yesterday I have received an email from him, and he has requested the two academic council to convey us how we can help collaborate, facilitate Pakistan and King Edward Medical University, and we will see what we can give them and what we can take from them. In the field of medical education, I personally feel we are in a position to deliver, to facilitate them. Professor John Corby, Professor Amar Aziz Loh, he is teacher of both of us. He is the international chair of ATLS and other advanced skill courses. He also visited King Edward Medical University with Professor Aaron, who is the Vice Chancellor from Turkey University. Both have sent the email, and they have committed to support in the advanced skill courses King Edward Medical University. Mahmood Adam, we are very grateful to you. I think you are the product of this university. Mahmood Adam is the Campbellian of 87 with his courtesy, the delegate of Specialist of Public Health from Scotland and England, led by him. He is the director, medical director and global health champion at NHS National Service of Scotland. They came and he extended his support to strengthen the OREC department of KE, which is one of the important requirements of Higher Education Commission of Pakistan. I think this is how you are going to pay back your country and your alma mater, for which we are very grateful to you. I think our friend from UK will be knowing Professor Vincent Emre is the Senior Vice President of Global and Professor of Immunology. British Embassy and Higher Education Commission of Pakistan invited 10 Vice Chancellors from UK, and they selected one university as the role model. And these 10 Vice Chancellors, they visited King Edward Medical University, selected by the Higher Education Commission of Pakistan. And in the end, they were happy to see the facility, the training program, the quality, and they extended their wholehearted support. And we are going to have future collaboration with the universities of UK. And in the end, one of the TV reporter asked one of the Vice Chancellors, what do you see about how do you feel about the King Edward Medical University? I think you are sitting in a graceful hall. It's building, but the more important people are its alumni, its undergraduate, its postgraduate. And I am just going to share the feeling of the Vice Chancellor of the UK with you.
Tell us, are you quite satisfied from the University King Edward Medical contribution in medical sciences and medical research?
Absolutely. This seems to be, it is an absolute, it's a centre of excellence. It is one of the leading institutions in the region, and it is one that we would really like to work far more closely with in the future.
So ladies and gentlemen, I conclude by talk. We are facing challenges in training, assessment and monitoring of clinical competence. These challenges need to be addressed by strengthening on-site supervision and e-log monitoring and exposure to the good foreign training institution. Proper incentive to attract the medical workforce in the rare specialty, that is very important. I think you all know कि हमारे जो professors को कितनी pay मिलती है, I don't want to discuss that. But you need to have some respect, the incentives. Then establishment of training academy for quality training of medical professionals. We have the academy for the CSS, junior and senior. We need to have a separate academy for medical people. We need to have a separate bench in Higher Education Commission of Pakistan. I've seen in Higher Education Commission of Pakistan, all the members and the chairmen, they are from other departments like education, the agriculture, the engineering. Not even a single member from the medical profession. Then autonomy of the institution, but this autonomy should be with the accountability and responsibility. A close liaison with the institution, regulatory and regulating body, especially Pakistan Medical Dental Council, Higher Education Commission of Pakistan, College of Physicians, Surgeons and University. And I'm very happy. Professor Atar Ahmed Saeed today has invited the President of Pakistan Medical and Dental Council. He is in the city and he is going to join us along with the President of Medical and Dental Council, Dr. Sania Nishtar, Professor Yasmin Rashid, Azimuddin Zahid, and all these stakeholders, they are there. And I'm sure after the panel discussion, we will have some the concrete guideline and the policy for our country, national health policy for the way forward. Thank you very much,
for your excellent work, contribution, and for your leadership. And thank you very much to this very responsive audience. Many of you are, or all of you are leaders of the future. So thank you for coming. One or two housekeeping rules, announcements, sorry. There is tea served. If you want to have tea or coffee, it's available until 11:30. The toilets are at the back and at the front for men and women. Who is holding a meeting on the 1st and 2nd of February, is that right? On a similar theme where he has invited world leaders in providing health care. So all of you who are interested, especially people who want to develop or need in health services, I think should attend. Shalamar Hospital 1st and 2nd of February. I'm not sure if Professor Rayasul Nabi Tayyib is here yet. No, so the next speaker will be Dr. Fareed Zafar in that case, and I will ask Aisha Shaukat to introduce.
Assalamu alaikum, ladies and gentlemen. Dr. Atar has assigned me a very, very tough task of introducing the next speaker. He is Dr. Fareed Zafar. He is President of Society of Gynae and Obstetrics. He graduated from National Medical College in 1989, did his FCPS, and he did his Masters in Reproductive Endocrinology from Monash University, Australia, got trained in Singapore National University Hospital. He is the ex-Vice Chancellor of Faisalabad Medical University. He will talk today on a very important issue, and that is the maternal mortality in Pakistan. So I invite Professor.
Who knows better the husband than, wife is the best person to introduce. Professor Gomi gave a very comprehensive view of, what is happening about postgraduate education. I will also touch few data about maternal mortality. So, respected Vice Chancellor, Professor Gondal, Dr. Tanzeen Haider, Dr. Azimuddin Zahid, Dr. Athar, Organizer, Dr. Saeed Ahmed, Organizer, Dr. Nabila Dugal, Professor Laik, Professor Asad Aslam, Dr. Sabat, Dr. Aisha Najib, Dr. Sarfaraz, Junaid Sarfaraz, Dr. Sajid Ubaidullah, Dr. Mahmood Sadiq, Sara Afzal, Dean IPH, Dr. Naki, ladies and gentlemen, Assalamu alaikum. Today's topic is very interesting. What is actually happening about maternal mortality and maternal health. Now, for the last 1 or 2 years, we have realized that maternal health and maternal mortality is one of the indicators of development of the country, which I think previously we were not sure. When a woman gets pregnant, they go for baby shower, they go for goodies, they go for gifts. But one thing she forgets, that in Pakistan there is a chance 1 in 140 to die once she gets pregnant. So this is a physiological phenomenon, this is not a pathological phenomenon. So why a woman should die? As President of Society of Gynae and Obs, we are fighting this menace and this problem. So there is no tool for development more effective than empowerment of women. And now we have a women health minister. Jannah under mother's feet. This, all of us as a Muslim, we know that this is the one important thing that, Jannah is under feet of mother. When Holy Prophet was asked, thrice he said mother and then he mentioned father. So we have to give importance to the mother. This is yesterday's in dawn. Pakistan won worst performance on gender equality. And out of 149 countries, Pakistan is 148. So this was the headline yesterday in Dawn News, and this is really alarming. This is October 2017, Daily Times, and here they say, the writer says that it's really a shame that Pakistan is not focused on maternal health. And the main problem, all of us know about SDGs, Sustainable Development Goals, that the objective of SDGs by 2030, the MMR internationally should go around 70. And now they are reporting that Pakistan is nowhere near that point that it will achieve SDGs. When MDGs, Millennium Development Goal, were launched, that time the focus of Pakistani nation started on the maternal health. Before that, only gynecologists were working, but not as a nation we were working on it. And by 2015, when MDGs were about to end, Pakistan was among worst 10 countries in MDGs. And then Ban Ki-moon, he came forward in the United Nations with SDGs and it started. And now, if today, we decide that, okay, we have to do it, only then we can achieve. Because otherwise, this news says Pakistan is nowhere near. One woman dies every minute. This is one statistics. The other is, every day 830 women die from preventable causes related to pregnancy and childbirth. Yesterday news says that in every 37 minutes, one woman dies. So we started this session at 8:30. And it's almost 10:30, and now you see how many women have died in Pakistan. Every 37 minutes, one woman is dying. In this slide, you will see population growth rate. This is very interesting. In 2016, it was 1.45, and this is 2017. Instead of going down, this is 2.1. This is PDHS survey. Dawn yesterday said it is 1.93. But you see here, instead of going down, it has gone worse. And things cannot improve like this. These are the different causes. Of course, a gynecologist, obstetrician, the thing which is dreadful for an obstetrician is PPH and bleeding. And I personally feel that ops is more dangerous than cardiac surgery, because when patient comes for bypass or cardiac surgery, he already thinks 50% mentally prepared, and attendants are also prepared that this person will die. In ops, they say previous delivery was conducted by a birth attendant and now she's ended up in the hospital. And she had this PPH and you're transfusing blood. So this is a very, very dangerous moment for obstetrician. This, I think, we have covered. Now the challenges which we are facing. Deficiencies noted from, let's focus on RHC and then we go to the tertiary. Directives and guidelines were not followed. Lack of blood and blood products in THQ was when we had an epidemic of dengue. The blood components were not available. Substandard management of PPH at THQs. Delays in transferring. Government has developed blood banks in the districts, important districts, and it is going to the Tehsil headquarters also. So that thing is going to be managed. Plus, they have started a maternal health ambulance, which its telephone number is 1034, and now we have around 220 ambulances which are working for maternal health in the periphery. Obstetric patients in the periphery, most of them seen by TBAs, LHVs, unsafe clinical practice, inadequate postnatal care. More specialists at tertiary care hospitals are required. This slide suggests that maternal mortality mostly occurs in extreme ages after 40 and before 20. Let's go to the teenage. Pakistan, you will see here, teenage between 15 and 19. It is 48 per 1,000 births per 1,000 women, which is, if you compare with US is 34, but lowest is Switzerland. Switzerland is almost 2. So we are getting better as far as teenage pregnancies is concerned, because previously in 90 to 2000 this was going very bad. We realized, you see the data, we realized in 2006 and 2007 that this is the state of affairs and we should stop this, and these teenage pregnancies should be discouraged. These are different challenges: topography, transportation, logistics, and especially the Saraiki belt south of Punjab and Dera Ghazi Khan and certain areas of Sindh and Balochistan and KPK. The region of Dera Ghazi Khan, it joins all the 4 provinces, and the problems and challenges are very, very high. Our CM is now from that area and he is doing troubleshooting for that place. What should we do? Every hospital has its own need. HR is very, very important, and especially we have to change the attitudes, and you need dedicated people. People should volunteer. They should not look for these shortcuts. And of course, medical equipment. And this I have already touched. The ambulance which is available now. All antenatal and postnatal mothers should be considered as high-risk pregnancy, which means importance should be given to. We are working in such an environment. In 2014, the delivery rate of Gangaram is 33,000 deliveries a year. And there were days we delivered 200 patients in just one day. We have done hundreds of sections, all complicated deliveries lining up. And I went to the labor ward and there were 35 patients with placenta previa. There was a separate way for placenta previa. So this, I think PPH I have already covered. In blood banks, we should ensure optimal pre-pregnancy care and family planning services. Personal audit is very, very important. Audit of near misses is important. We encourage hospital deliveries. EMOC, emergency ops care, is very important 24/7. And now the government are asking private hospitals also, to some extent, they should work for these poor patients and emergency care. Prepare army of trained LHVs, LHWs, TBAs, and community health workers. This is very, very important. We are at the moment working in an initiative program with Minister of Health, and we are this as a trained army of LHVs and LHWs and community health workers, and they are bringing the data and we are working them. This is very, very important. Unfortunately, some of the people say that they do not have an important role, but in my opinion, people who are living with them, they have their faith in them. You give a prescription, they go back to the LHW and ask her that, is this prescription okay or not? This is very interesting data. Underestimation of maternal and perinatal mortality. This is April 2018, revealed by enhanced surveillance system. You enhance the surveillance system with community health workers, which are different from LHPs and LHWs. You will get proper data. They conducted a study in Ahmedabad and in northern areas, and they came out with this conclusion, which I think the government of Pakistan is focusing on now. Structured training program for postgraduate trainees. Dr. Mondar has already touched this topic. Awareness seminars and camps. We have to go to the peripheral areas, to their houses, and this was the camp where we did cesarean section. We worked in floods, we worked in IDPs, we worked in dengue, we worked in earthquakes, and our society goes to that area and deliver and do section in tents also. We have to eliminate violence against women. Otherwise, this problem of maternal health will never improve. Harassment. If you educate a man, you educate an individual. But if you educate a woman, you educate a family. And child will always speak mother tongue. He would never speak father's tongue. That is the problem which we are facing. You maltreat the mother and the child suffers and the whole nation suffers. So this thing is very, very important. Contraceptive initiative, it is launched by the government. We have designed this performer, which we are working in all the peripheral areas. This is interesting figure. Contraception prevalence in Pakistan, 2012 and 13, 35%, and 2017 and 18 is 34%. Instead of increasing, it has gone down. Some people analyze it and say that it is just static, but it's almost 6-7 years. Even if 1% it goes down, that is dangerous. It should have been more than 50% and not 34%. That is the problem which we are facing. Yesterday I got the figures. Prevalence of Lady Wellington and Lady Asian 40%, Jinnah Hospital Ahmedabad 40%, services 61%, LGH 35%, Nishtar 30%, and some of the professors were of the view that people who are saying that this is 40%, 50%, 60%, I think they are not giving true data, and it is much, much lower than 30. Some of the senior professors who were working, they were of this opinion. They said it's better not to give our data. So that is, I have not put it over there. Near misses are touched. We are working on near misses, and from which pockets these patients are coming. We are working with those TBS, and we have to evaluate what the important causes are. 2013 MMR 170 causes we have touched. Gates Foundation worked on this. MMR decreased 385 in 1992 to 216 per 100,000 in 2015. Interesting data of US. It's not only Pakistan. In US, maternal mortality ratio is increasing. It was 14 years ago, 14. Now it has gone to 28. So only Pakistan is. We have different causes. US has different causes, but it has gone up from 14 up to 28 in 14 years. Due to they have other medical causes. This is a very comprehensive study, 1980 to 2008. Very interesting. These are the 4 authors, and Bill Gates Foundation, Seattle, and Queensland University, Brisbane, Australia. They were the main people behind this, and that's how they collected the data: registration, census, surveys, verbal adoption. Interesting thing which came out in this data, 50% of the maternal mortalities were taking place only in 6 countries. India, Nigeria, Pakistan, Afghanistan, and Ethiopia. Let's go to this slide. Global MMR, 1980 was 422, 1993, 20, 2008 to 51, 2015 to 16. Let's see this. Future is not that bad. In 1990, where we were, and in 2015, where we are. So we have not done that bad. If you see this graph, it gives you a little bit, energy and feeling of happiness that, when Pakistan started working on it, things were different, and it's 28 years, you have improved. In SDGs, 70 deaths per 100,000 in 2030. These were the countries who worked very well in MDGs. Malaysia, just Malaysian city, and then a little bit about the data I have about institutions, just one graph. Mahathir Mohamad, whenever there was a mortality, he would take all the health department and would go to that house and would find out the cause. And that's how he brought down maternal mortality. And next time that problem did not occur. This was written, it was published in British Journal. It was written by Ravi Chandran, 2000. This SDGs, all of us know that now we know it's not only if we start focusing on maternal health we can improve. You have to look for so many other things. You have to educate them. You have to improve their economy. There are so many other things which you have to do. It's not, and it's a global effect. It's not only the maternal health. If you focus, you will improve. These are the countries with lowest MMR. Rural areas, this graph shows 26% women, urban 62%. 85% of women have medical care, but who are rich, and people who are poor, they are way down, around 30%. This study was conducted in 1992 in Karachi, JPMC, and you compare it now. So it is not that bad, but still the alarming situation is MMR is 452 per 100,000. We say WHO has data and says it is 178 per 100,000. And our department said that it is 260 per 100,000. Different organizations are working, they have their own data. But this is a tertiary care of whole of the countries, not only Punjab. It is 452 per 100,000. This doesn't mean that, we are killing people, these institutions. The problem is that all these pregnancies, they complicate in the periphery and then they land up in the teaching institution. The near misses, the dead patients you see, then they go in the data of tertiary care. So, but this is alarming. We have, especially Nishtar, Faisalabad, Pindi, some hospitals of Lahore, Lady Wellington, LGH, who are in the periphery. Then there are Ghazi Khan Medical College, then Raimia Khan. It is more than 1,000 per 100,000. And if you calculate overall, it comes out to, in Karachi and interior Sindh also, it's alarmingly high, Nawab Shah and all that. So, we have to work on this, and I think let's take an oath today that all of us will work for maternal health. Objective of this is the last slide. Childbirth, the miracle of life, should not become a nightmare of death. Objective of our society is to reduce maternal mortality, to work for maternal health. We have started one UK chapter in August, and Khalid Khan was editor of British Journal also. He was made patron-in-chief. And one team is coming, led by Faraz Saeed. They will be in Karachi, in JPMC and Dow, and they are coming to Lahore on 26th, and they will be having their workshop. We have started one chapter in UAE also, working for the labor who is working in UAE and they do not have an insurance system. And we are having different MOUs with Royal College. Royal College is very, very positive of gynecologists in UK about the chapter we started. And one thing more, we recently went to Brazil, and there was a conference of FIGO, which is the highest body of gynae, and whole of the world is a member. And out of 130 countries, Pakistan stood 8th. And India got out very early. So then I came out, and because I was not canvassing, I asked people that, who is voting for Pakistan. And then Royal College came to me and they said, American College came forward and they told me we voted for Pakistan and we did not vote for India. So that is another thing which is, and whole of Africa voted for Pakistan. Pakistan would have come in first three, but then Sudan was there, so all the Africa voted for Sudan reform. So I'm very grateful. This is an interesting topic. We are working, we are funding different hospitals, we are giving HR to different hospitals. And I hope people who have come from UK and US, they work with us, the universities, the galaxy of scholars who are sitting here, they should work with the society. We can sit down and we can have a plan and let's save our lives. Thank you very much.
Surely your miracle of life should not become a nightmare of death. My next speaker is very well known for transforming skills in clinical gastroenterology, hepatology, and interventional radiology, especially in public sector hospitals of Punjab. He served as a principal at Amiruddin Medical College and is the Dean of the Postgraduate Medical Institute. I invite Professor Qiasul Nabi Tayyab to share with us his experiences on developing specialist services infrastructure in Punjab.
Introduction. I'm really thankful to Professor Al Mondar, Dr. Azhar Ahmed Saeed, Professor Mohammad Saeed for inviting me here to speak on a very interesting topic, although let me admit that I'm not an expert in the development, but having developed certain sectors in the public institutions and currently given the task of developing GI units and endoscopy suites in the 17 autonomous medical institutes in the province, Dr. Adha thought that the experiences that I've had in the recent years, I should share it with the rest of the colleagues. And in that context, I don't have any disclosure except that I'm project director of one of the projects, but then that assignment doesn't include anything on the things which are going to come in this. Now, certain things that I'm going to discuss in the next 15-20 minutes. Introduction of the health sector of the province and what are the specialist services in the health sector. Now, we need to identify the missing areas and procedure to develop the specialist services in these missing areas. This is what I'm going to discuss in the next 15-20 minutes. Now, the health sector of Punjab is basically divided. You all know that there's a private sector and then there is a public sector. In the private sector, we have a huge family practice, which as a matter of respect to them, and to be honest, 80% of the health cover is being provided by the family practices, which are there in almost each and every corner of the province. And then there are hospitals, which may be university hospitals, private teaching college hospitals. Then there are general hospitals, which are divided by the health administration into category A, B, C. Now this categorization is just recent and it's arbitrary. What is the basis of this categorization? Still it is vague and the rules are not really well defined. And then there are lots of nursing homes in the various parts of the province. And then there are specialty care hospitals like eye hospitals or gynae hospitals or specialized hospitals which are catering for just one discipline and they are not general hospitals. And then there are public hospitals. In the public hospitals, we have a division between two sectors. One is primary and secondary healthcare department and the other is specialist healthcare department. The primary and secondary healthcare department, just like any administrative service, we have an administrative cadre which is governed by a secretary, and obviously on top of them we have a Minister of the Health and her secretariat. In the primary and secondary health department, we have district headquarters hospitals, tehsil headquarters hospitals, depending upon the location of that hospital. If it's located in one of the districts, we call it district headquarters hospital. And by name and by the location, one can understand that the district headquarters hospital has to be bigger, the tehsil headquarters hospital has to be relatively smaller, and they give the basic services which are maybe the the specialist services as well as general services. In general services, we have the general duty medical officers, we have the emergency services. In the specialist services, we have all the basic departments. For example, medicine, surgery, gynae ops, pediatrics department, radiology department. So the basic departments which are needed to run a hospital, they are all there in this district headquarters hospital, in the C headquarters. And they are served by the specialists, which are posted as district hospitals, and they called the field specialist or district headquarters specialists, and they are brought and they are named in the category of special services. And then to support the rural population, we have got basic health units. Then there are lots of projects which are there to serve these people. They run through the center, and the center is always located at the secretariat. And then lots of directorates which regulate the various activities which are going on in various sectors. Then we come to the teaching side, which is governed by now specialized and specialist healthcare department and medical education. And then, just like the primary and secondary healthcare department, we've got the administrative setups. And we have got universities like the Edward Medical University, Fatima Medical University, and similarly other 3 or 4 universities which are there in the province. And then teaching hospitals which are attached to the autonomous medical institutes like Services Institute of Medical Sciences, Ameerpur Medical College, Postgraduate Medical Institute, Sheikh Zayed Medical Institute, and similarly, if we go out of the city, this city where we are sitting, then Gujranwala Medical College, Sahiwala Medical College, and each autonomous medical institute has an attached teaching hospital where 2 kind of human resources serve. One is the teaching specialist, which are required as per the requirements of the PMDC, and then there are lots of specialist services which have been inherited out of the historical posting which they got in the process. Now on the teaching side, undergraduate medical institutes are dictated by the PMDC rules and regulations, and as per PMDC rules and regulations, certain specialties have to be there before they are going to get the accreditation and before they maintain the accreditation for continuity of the medical education. So main departments like internal medicine, surgery, gynae ops, pediatrics, radiology, pathology, these important departments, the basic departments, important departments which are an integral need of the medical education of the undergraduate medical students has to be there, and they're all staffed by professors, associate professors, assistant professors, senior registrars as defined by the PMDC. So kind of structured formula which is given by PMDC, followed by Punjab Health Department, and then implemented in all the autonomous medical institutes. And in these institutes, according to the need, as per the history, at times there are lots of additional units as well, which are needed for the care of the patients who are there in the community. Then comes the university hospitals and postgraduate medical institutes, where although one has to meet all the basic requirements, all the basic units which are needed as per the PMDC criteria, as per the PMDC guidelines, but then the additional units also exist. Then super specialty units are a rule, are a need, and are placed in these very hospitals. If you go to the postgraduate medical institutes, if you go to the university hospitals, you'll find lots of those units which are not really needed for the undergraduate medical institutes, but for the management of the patients in the community and to develop super specialty services. These units exist. Now they are need-based and depends on the interest of the people who are serving that institute. So these are the basic 2 criteria on the basis of which these units come. Either they are historical or they come up with a posting of a particular person who is there. But then it is not in an organized fashion. And these teaching hospitals, may it be university hospital, may it be non-university hospital, just attached to one of the autonomous medical institute, there are non-teaching specialists as well, which are historical. For example, it's a hospital which was not initially teaching, and then the human resource in the category of specialists like radiologists, pathologists have been posted over the years, and they're continuing in those services. These services are by and large unregulated, unsupervised, and there are lots of duplication services, and it is best that with the coming days, they need to be scrapped, and just the teaching units should be there, reporting to the professors, and professors should be looking after all these activities. Now, if you have to develop some service, the task which has been assigned to me by Dr. Atasai, we obviously have to identify a need. Now, once a need has been identified, the pool of patients which is there in the community, that needs to be analyzed. Availability of the specialists who are there to cater for the treatment of these patients, for the care of these patients, need to be identified. Then, kind of impact which is going to be brought when a service of this kind is to be introduced, that needs to be analyzed. And obviously, nothing is possible without the availability and dispensation of funds. So for that fund requirement, one has to calculate in a certain fashion, and the fashion is that we have to look at the problem in three-dimensional way. And three-dimensional way is, for example, we are sitting in this hall, there are lights, there are furniture, and then there's IT equipment, there's a projection equipment. And for a special service, we need furniture, fixtures, equipment, IT, human resource, and then we need a building like this to house all these things, which is called civil component. So these are technical tasks for developing any kind of service. Now, we have to sensitize the administrative circles, and administrative circles can be political, they can be administrative. They are by and large, most of the time, we are lucky that we have a doctor, health minister, but most of the time, it's a non-doctor health minister. So, to develop any service, to make them understand that this is what a pediatric cardiology is, or this is what a gastroenterology is, and why is it needed in the community. We have to sensitize them based on the facts, based on the number of patients that are in the community, based on the unmet needs, these kind of patients. We sensitize them, we pitch them with the numbers, we build a consensus amongst the specialists, amongst the expert pool, with the help of societies, professional societies, with the help of people who come from abroad, like the Afghan people, or the people who have come from UK or America on regular basis to attend various conferences that we hold, and they get to meet with the policy makers. Then, building of the framework. Framework means that the paperwork on the basis of which process has to be initiated and a specialty has to be built, presentation of the framework in one of the administrative bodies, and then approvals from various administrative circles. I'm going to come down to the approving bodies in a short while. Now, the administrative circles in the specialized healthcare and medical education are obviously the three wings in the department. One is the admin wing, the other one is development and finance wing, the third one is technical wing, and each wing has a mandate of their own. Although they do overlap, and when they come to the approval meetings, they all sit down together, but then they have assigned roles. For example, the admin wing has to provide the baseline, ground situation, patient statistics, and HR statistics available in an institute, available in a specialty, and available in the community. Then the development and finance wing obviously ensures the audits, finances, development frameworks, and the providing coordinations between the various departments. For example, it's not just the health department which has to do the approvals at their own. Rather, the approvals have to come from the other departments like finance department, PM department. I'm going to come down to them in a short while. And finally, the technical wing, which guides us on the rules and regulations which are needed to develop a new specialty, which are needed to develop a new special service, and the technical support which is required from various sides, mainly the federal department, from the private sector, or from outside Pakistan. And then in the political side, we have to have the concept approvals, policy directions, cabinet committee approvals are needed, and cabinet committee means that it's not just the CM office, it's not just the health minister office which is going to approve a particular thing. Various ministers and the sporting secretary, they sit down together, they look at the proposal, they look at the papers in detail, and only then one gets the administrative and financial approval. They prioritize, and the public announcements are made by the political. And they always in line with some kind of policy, some kind of framework, and the current framework is Sustainable Development Goal 2030, which has been adopted by Government of Punjab. Professor Fareed Zafar has very rightly shown a set of 17 goals throughout, and you have seen them. Universality is required, integration is required, and transformation is required. I'm not going to go into the details of that. But important thing is that priority social sectors are health and education, and in the past few years, a lot of work has been done thanks to these sustainable development goals with this. Now, coming down to nitty-gritty details so that the people who are sitting in the hall, they may understand what is really required to develop a service. It's an organized work. It's not that a person has conceived an idea, he has presented that idea to minister or chief minister, and things have started. It has to be proceeded in a certain fashion. And what's that certain fashion? One has to conceive a plan, and it is based on a need. And need is identified based on a survey, based on some kind of scientific study, which may be in the form of a publication in an international journal or a local journal, or may be in the form of an informal kind of survey, which is to be presented to the government. And then sentinel sites offshore data is a key thing, which is adopted by the technical wing of the health department, presented to the administrative circles, and then the things proceed. Now, once the need has been identified, then one has to identify the ways and means to meet this need, meaning by unmet needs. So it is a technical kind of thing, and in the technical, one has to identify what kind of human resources available in the community to bridge that gap. Do we have the dedicated human resource available in the community which can provide this kind of service, or we have to send them abroad or somewhere else in the other part of the in the country for their teaching and training? Their infrastructure is required, dedicated to that service in the form of a building, equipment, and then financial impact, financial resources which are required to run that service, and then obviously the administrative setup which is required for that. So this is done in the form of a new concept note with a preliminary information, project description which includes the title, the description of the idea, problem statement, justifications which are required to build a service. One has to identify the execution agencies. Mostly the execution agencies are at least 3-4. For example, if one has to develop a civil structure, in the civil structure we have the CNW department, Communication Works department, or IW department. For information technology we have PITB, the representatives are here, and for equipment purchase, in the past it used to be a central purchase department, but now each and every hospital or every project has a purchase department of its own, although the activity is regulated by the PMO, which have a technical support wing. And then the target beneficiary groups. The target beneficiary groups are obviously the people in the community, and geographical coverage. For example, I see this more prevalent in the south part of the Punjab. So one has to develop a service on priority in the south Punjab as compared to the central Punjab or north Punjab. Service is grossly deficient in one part of the country. So the service has to be developed in that part of the province, that part of the country as a priority as compared to the rest of the areas where the things are going on. Then we got the project cost, and strategic context has to be in the form of Sustainable Development Goals 4, which are to be completed by 2030. The impact, outcomes, and outputs, they have to be defined in the project concept. Once this has been done, it has been approved, it has been accepted by the administrative authorities. Then comes the PC1, in which we have to give the general details, technical details, financial details. One is to give the timelines. These are all timeline activities, and one is to give timelines. Critical pathways have to be defined. The methodology of execution of a project, methodology of institution of special service across the Punjab has to be defined in a certain way, and finally execution agencies have to be defined before the PC1 is going to be presented and decided by the administrative authorities. Now, which departments are involved in these kind of approvals? Obviously, your own parent department, and then the planning and development department, which has a huge board, and that board covers all the various important social sectors. For example, the environment experts are going to be there. They're going to be people from the social side, there are going to be people from the general side, there are going to be people from the finance side, and similarly, there are going to be people who are there in the policy making. Everyone is there on that board, and they review the project only after a thorough threshing of that paper. Then the approval comes in. Obviously, finances, that's the key thing. Unless the finance department pledges that we are ready to, and we are willing to give this much money, the projects don't go forward. A new special service don't go forward, because one has to have an initial cost, and then there is a recurring cost. And then obviously law department, SNDAB, regulation wing, they all come into this. Approvals are made through the administrative wing of the special healthcare department, P&D approvals, finance department, capital committee approval, and then that's the time that the project is reflected in the annual development book and the project goes forward. Then comes implementation. In the implementation, the civil work, we have got CW and IDA, the revenue, various components which have to be taken up separately, catered for separately, and implemented in a separate way. Generally, the project duration is 1 to 3 years. Revisions can be made and projects can be extended for a stipulated time to meet the target, but then they need special approvals. Otherwise, they are time-bound projects. In usually 1 to 3 years, one has to complete the projects. Now, in the project development, we have got budgets. One is called development budget, the other is non-development budget. Development budget is basically a baby of the P&D, they approve, and then the finance department is pledged to provide that budget to the project or to the department for development of the service, but for the medicines, for the maintenance contracts of the equipment that is being purchased, and similarly for the salaries of the employees which have been employed in a new service that has been met through the annual budget which is given by the finance department to the respective or non-development institutes, and that comes through the non-development budget. Those who are not familiar with the working of the autonomous medical institutes, for them this may look as a dream, this may sound as a dream, but this is the way the things work. Now, once the project has been complete, the service has to be internalized, meaning by the devolution from the center to the autonomous medical institute, regulatory authority has to go down, PPSC has to induct the gazetted seats, the non-gazetted seats, meaning by the people of support staff like nurses or technicians, OT technicians or service technicians. They are inducted at the local level. Maintenance contracts are awarded at the local level, and similarly teaching trainings. They become an important component if more than one hospital, more than one institute is being developed. Then it has to be integrated exactly the same way as Professor Fritz explained in his presentation, that there is a central body which takes care of the teaching and training of the people who have been employed in a new specialist service till such time that they have gone up to a stage where they should be able to provide optimal service. And all these services have to be integrated. They have to be project their data, their activities on a dashboard, and it is always done with the help of a local administrative controls and through the local hierarchy. I thank you for your patient listening with the message that we have at ERCSEB course coming up on 21st to 23rd February in the Hospital.
Thank you, Ayaz, for all your good work and your presentation. When we get posted as a consultant in the UK, all of us have to undergo what is called a management course. And all of us are told how to write a business plan. So if you're setting up a service, then you have to think of the need for it, the finances involved. In Pakistan, this is done at the level of the health department. And to most clinicians, you know, the pathways can seem very bureaucratic and very Byzantine. So therefore, I think it is essential if you want to develop your services like Prayas has done to a very high level of quality, that you know how the system works and how to navigate your way through it. So well done, Prayas. Before I invite the next speaker, I would like to thank Sajid Abdullah, who is my friend from school, excellent professor, very well known and very well loved by his patients and trainees. So next speaker is Dr. Asim Yusuf. He is the Chief Operating Officer in Shaukat Khanum Hospital. As many of you may be familiar with Shaukat Khanum, it was an act of faith. When it started, Asim was working in the UK as a consultant. He came back to Pakistan, and at that time the future was very uncertain and people were actually not convinced at all that it had a future. So they used to go to the hospital in the form of a convoy because of the security reasons. And if you go and see it now, there's a whole city around it, and I have no hesitation in saying that if you want to compare any hospital, any one hospital in Pakistan to international standards, Shaukat Khanum will meet and exceed them. And I think if you've not seen the Peshawar hospital, you must go and see it because it is just a very beautiful structure and also staffed by very competent and extraordinary individuals. So Dr. Muhammad Asim Yusuf, welcome. He will talk about the reforms in Khyber Pakhtunkhwa and what we can learn from it. Asim Yusuf.
I'd like to thank the organisers, especially Dr. Khalid Masood Gordon and Dr. Azhar Ahmed Said, who both happen to be my classmates, so clearly no nepotism there. Thank you, Atar, for the kind words about Shaukat Khanum. I can't let this opportunity go to remind everyone that we have Dr. Nahid Usmani here, who's president-elected wrong organisation. But most importantly, was one of the original 10 group of people, consultants, who started Shaukat Khanum. I was one of those. But I was a much lesser entity than Nahid, who was the only pediatric oncologist in Lahore and at Shaukat Khanum. So she set up the pediatric oncology program, which is thriving today. So I'm going to talk about the healthcare reforms process in the Khyber Pakhtunkhwa, what we've learned from it, how we intend to improve it there, and also what towards the end of this talk, what the plans are for the reforms process in Punjab. So I have no financial or other disclosures, and in particular, because this keeps coming up, I have no financial, I've received and have, I do not receive and have never received any financial compensation for the work with the public sector hospitals in the KPK or elsewhere. So there have been previous attempts at reform of the healthcare system. Here in the Punjab in the 90s, a form of autonomy was granted to public sector hospitals, but budgets continued to be controlled by the provincial health and finance ministries, so they were, if you like, hobbled from the start. In the KPK, in the military dictatorship period in the early 2000s, they started a system of reform which was heavily centered on forcing the consultants and the faculty to start institutional-based practice. This really was a disaster. It led to paralysis of the healthcare system in Peshawar, in particular, with mass resignations of the faculty. And perhaps an unwanted corollary of that was a massive growth in private sector facilities. So some of the best private sector hospitals in Peshawar were formed by groups of former faculty members from these teaching institutions who had resigned in protest. So when I'm not a representative of the PTI government by any means, I'm just describing the act that they passed. So the healthcare reforms process in KPK started when the PTI formed a government there in 2013. And they passed a Healthcare Reforms Act that same year, which was designed to provide autonomy to the government-owned medical teaching institutions and their affiliated teaching hospitals in the KBK, so as to improve performance, enhance effectiveness, efficiency, and responsiveness for the provision of quality healthcare services to the people of that province. So a noble aim. In essence, what the Act did, and it was initially rolled out in 4 of the major teaching hospitals, so the Khyber Teaching Hospital and Complex, Lady Reading Hospital, and Hayatabad Medical College and Medical Complex in Peshawar. Now that's 3 in Peshawar. And the 4th was the Ayub Teaching Hospital and Medical Complex in Abtabad. So each of these was to be headed by had a board of governors to run the institution. The medical school was to be headed by a dean. There was a hospital director who had many of his roles formerly fulfilled by the medical superintendent of these hospitals. A nursing director, which is fairly similar to the nursing superintendent, and a new position of a medical director. So the medical director was meant to look after the medical side of things in the hospital. All the faculty were supposed to be responsive to him or her as regarded the clinical care provided in the hospital and maintenance of quality standards, while the hospital director was essentially meant to ensure that the facility ran optimally. Security, utilities, IT, air conditioning, repairs, maintenance, that kind of thing. So the board had numerous powers assigned to it. Sorry, this is probably a bit small. The board was responsible for ensuring that the objectives of the MTI were fulfilled, overseeing effective management and providing strategic direction, policy making, prescribing procedures for appointments, promotions, and so forth, approving the vision and mission statement of the hospital or of the institution, approving the annual business plan and the budget, review and approval of major transactions, approval of new programs and services and monitoring organizational performance, approval of bylaws for the medical staff and the processes of appointment of medical staff, constituting the executive and other committees of the subcommittees of the board, and compliance with government policies and standards, which were meant to come from the Ministry of Health. The hospital director, as I said, was responsible for all non-clinical functions of the hospital, preparation of the annual budget and the business plan for presentation to and approval by the board, maintenance of the building and engineering services, and maintenance and development of all the ancillary services, including the pharmacy, nursing, materials management, human resources, communications, and security. The hospital director was also required to act as the principal accounting officer. The medical director, which was a new position, was responsible for all clinical functions of the hospital, including but not limited to ensuring clinical excellence in all aspects of hospital function, ensuring timely and appropriate management of patients, ensuring the best outcomes for all patients, undertaking clinical governance, assessing and auditing existing programs and developing new clinical programs, and developing the annual clinical budget, including capital equipment requirements and personnel, presentation to the hospital director and thence to the board. Efforts to improve primary and secondary healthcare commenced in parallel with this. So there were lacunae in the Act. From early on it was realised and that these had to be amended twice. So the first was the initial way that the boards were formed included a significant number of civil servants. So the first amendment actually removed all civil servants from the board. It was all members of the public who were on the board, health professionals, others, lawyers, businessmen, eminent people from society, and so forth. And the second one was a more mundane procedural issue. So the boards of governors were initially met with a variety of emotions: incredulity, amusement, who are these people, who are you, who gave you the right to be on the board, what makes you qualified to be on the board, etc. And you can go on with that. But the last one is particularly important because 2 or 3 of us were from Shaukat Khanum. Dr. Berki, Noshirman Berki, Imran Khan's cousin, was the author of the healthcare reforms, was our own first, let me get this right now, first medical director, first chief executive officer, continues to be the chief medical advisor to the board of Shaukat Khanum, and is a member of the board. But, he's also a professor of medicine in the United States and has been for many years, a published and eminent researcher and so forth. So his qualifications are not all related to Chokathan. Nonetheless, so there was that aspect too, that, you know, it's Chokathan's going to take over the KGK and run all the hospitals in its own model. There was initial resistance, coupled with contempt, derision. A lot of people thought this was amateur hour, and I must say initially the first year or so, some of the things we did were very amateurish, were wrong. We had to go back and fix them, because we were all new at this as well. We were not being helped, we were being most definitely hindered in our efforts, and so we made a lot of mistakes, undoubtedly. There was a gradual coalescence of interest groups against the idea of the reforms and against the boards in particular, until we had a united opposition combining junior doctors, faculty, nurses, paramedical staff. In Ahmedabad, where I was on the board in particular, it was very easy to get headline news because the hospital and the teaching complex are on the main road which goes, the Karakoram Highway, which goes up to China. It takes about 6 people to block that road, and the entire traffic is brought to a standstill. So that was a common occurrence. Luckily, Edward is off the miles. There were also, within the boards, there were opposing views as to what the role of the board should be. As I pointed out, the functions enshrined in the Act are very clearly to do with governance rather than management. These boards were envisaged to be governing boards, to provide leadership, policy, direction, but not to manage day-to-day affairs of the institution. There was a period of settling in, a learning curve, as I've said, a mix of physicians and non-physicians, which was obviously needed, but was challenging in its own way because a lot of things that was very evident to the physicians on the board were not at all evident to lawyers and others, to whom all these things had to be explained at some length. And again, the crucial issue of governance rather than management, and this was dual-edged. Some members of the board and some boards were more interested in being a managing board, particularly when they had a lot of members who were local to that area and who could therefore come to the hospital every day and see what was going on. And then there was also a definite feel from within the institution that they would like a management board because that's what they were used to. The faculty were used to reporting to the health secretary and others and getting guidance on all manner of things. And here they were being asked to take more responsibility and control for their own actions and to be answerable for them, which was something that perhaps they were less used to. And then, of course, we have the courts. You'll see this is part 1. So we had stay orders against practically everything. I don't know what it's like in Punjab specifically, but in KPK it seems that it was very easy to get a stay order. You could get a stay order against practically anything, including the suit I'm wearing and so on. So there were stay orders very early on against the Act itself, against the boards, the composition of the boards, why these people, why not these people, how were they selected, and so on. Although the Act lays down very clearly how the boards are to be selected, and that's exactly how they were selected, but nonetheless, since the Act was being challenged, so the boards were also challenged, and there were stays on the functioning of the board, so much so that once I set out from Lahore to attend the board meeting in Ahmedabad the following morning, I got to Islamabad at about 6 in the evening to hear that there had been a stay order had been issued and that it was going to be illegal if we attended the board meeting. So I turned right around and got back to Lahore at 10 o'clock that night. So, there was constant drama. And then there were stay orders against individual decisions of the board too. So you could have someone being promoted and then suddenly there's a stay order. And there was a complete hiatus then as to who's actually in charge of that department and so forth. So the list was fairly long. And most of 2014 was spent in a state of near paralysis because of this. Very little was done. And there was even talk about turning the whole reforms process around, abandoning ship and saying, well, okay, we'll go back to the drawing board and try again. But eventually all these, justice eventually prevails. And all these petitions were finally clubbed together and presented before the Peshawar High Court, where the Chief Justice of the Peshawar High Court finally heard all these cases simultaneously and dismissed all cases pending against the MTIs. So that's when we really got started, 2015, 2 years into the term of office of that government. Now, there were various other forms of interference. Surprisingly, there was always political interference. There were always individual politicians who had an axe to grind in a particular institution. So maybe I I need to be careful about what I say here, but maybe M&A from that city had a personal interest in someone getting promoted, or maybe their spouse was on the faculty in the medical school or something like that. So, you know, there was that kind of interference. We had people who would insist on trying to barge into the board meetings to influence the decisions of the board and so forth, which were all resisted. And then, of course, the most important thing was trying to get people appointed, and literally from the position of dean down to security guards, there was no one that we didn't get pressure from to appoint these people and not appoint the others. Promotions. And then there was also a problem with fostering and supporting militancy, particularly with regard to junior physicians, nurses and others. Some of the strikes we found were being actually supported from within by members of the faculty and others. There was also bureaucratic interference. I think there was an issue of finding it difficult to let go. The bureaucracy had run these hospitals for decades, and suddenly they had no say in anything. You know? So they could no longer influence promotions, they could no longer threaten to transfer people if they didn't do what they said, and so forth. And again, appointments, promotions, and so on was a constant struggle. And attempts to muscle in and run things their way continued. It really was about not being able to let go, we felt. Government departments losing authority, and to some extent even employees looking back through rose-tinted spectacles at this time that, oh, it was actually so much better when the health ministry was running things. Maybe it was, but that wasn't what's going to happen now. And then the boards actually had to stand up to the government as well. I'll narrate this little incident. When we took over as the board at Ahmedabad, it's a very large 9-story building called the Maternal and Child Health Building. Quite similar to the ophthalmology building that was built here when we were medical students. I think it's still there. It was completely derelict, unfinished, empty, unfinished. And it had been built some 3 years earlier, so I think it had been completed in 2010 or 2011. But it was mired in controversy, and there had been a provincial inspection team which had done an inquiry and said that the building was substandard, it wasn't fit for human occupation, it wasn't built to hospital specifications, etc., etc. I think half the faculty had been implicated in allegations of corruption in the construction and so on. But surprisingly, not one person was the government, the ministries who presumably approved, as Riaz just pointed out brilliantly, I couldn't even remember all that stuff, but clearly this building had gone through a similar process in the KPK, the PC1s and the approvals and this and that. So not one person from the government or from the buildings department or the engineers who had approved it or built it were implicated. It was only the clinical faculty who were being held responsible for everything that had gone wrong. Each of them was being asked to pay upwards of about 11 million rupees in damages to the government. And the building was just lying there, unused. So as a board, we said, the first thing we're going to do is let bygones be bygones. If the government wishes to prosecute these people or do whatever else it wants to do, they should feel free. They have the police, the NAB, whoever else, the FIA and so on. So they should do whatever they want to do. They can come and arrest whoever they want, but we're going to finish the building and we're going to get the hospital up and running. So that's what we decided in 2014, I think. We hired an outside consultant to decide what needed to be done. So it's a 5-story building, no lifts, Ahmedabad, which is freezing cold in the winter, no heating, no medical gases. So, you know, these are huge things. So we commissioned someone to advise on this. We floated tenders and we got companies to come and do this. Hundreds of millions of rupees were spent in upgrading it and completing all these requirements. And eventually the building opened earlier this year and is now functional. But in the process, the board was hauled up to the government. How dare you do this? Etc., etc. Many of us were threatened that we were going to get fired, that we would get arrested for having done this and so forth. But we said, well, look, if you want to fire us, that's fine. We're only honorary anyway. But we're going to do what we think is right. And it was a huge struggle. 2 chairpersons lost their jobs during the time. 2 board chairpersons. One resigned and one was fired because of this. But the board stood its ground. And today that building is functional. If we hadn't, I think it would still be an empty shell 5 years later. So was it all doom and gloom? No, absolutely not. We implemented a number of things, some province-wide. So we implemented the hospital information system, which was a gift from Chowdhury Hospital. to the hospitals of the KPK. In all those 4 teaching hospitals that I mentioned at the outset, all are now running the Shokathanam information system to varying degrees. None of them are doing online medical notes yet, but they're doing their patient registration, they have labs. Each hospital has a terminal in each ward in the hospital where doctors can look at lab reports online. They don't have to wait, they don't have to print them and so on. Prescribing in some places and so forth. But we've given them the whole thing and they're rolling it out gradually. As a side... As a corollary, I point out that some years ago, the Shokathanam healthcare system also offered this information system to the Punjab teaching hospitals. Considerable investment took place into infrastructure, rehabilitation and new equipment. Salaries and service structures were improved. Institutional-based practice has been implemented in all hospitals, but at a varying pace and without the coercion that was employed in previous regimes. And patient and bed management systems have been implemented and so forth, many other individual achievements, which I'm not going to go into here. So what were the lessons that we learned? The most important lesson was getting the right people on the bus. You have to have the right people on the board. If this is going to work, you have to have the right people in the key executive positions, the dean, the hospital director, the medical director. These have to be people, and the nursing director and so forth. These have to be people who are committed to and invested in the reforms process. If they're not going to support it, the board can't do anything on its own. It has to be run from within the institution. We also learned, sometimes at great cost, to try and implement high-impact and low-cost initiatives initially, because it is important to keep the public goodwill, to keep the media on your side. You have to show results, not only in the medium and long term, but you have to be able to show some short-term results too, because there is considerable resistance and opposition, as I've highlighted. And persevere, and keep persevering. Then there's part 2, the courts. So, when the interim governments were formed, many of us thought that that would be the end of our term. And while we were still contemplating whether we should, send in our resignations or thank the government for being allowed to do this, the interim government and the courts fired us all. So before we could resign, we were all summarily terminated. Inquiries were instituted into everything that had been done, obviously. There was determined efforts in some areas to try and roll back the reforms process as quickly and as substantively as possible. But fortunately, there were only 3 or 4 months in which this could be done. And of course, through perseverance comes salvation. And we and the government stuck to it. The reform process in KPK, at least, is here to stay. And new boards were constituted in September 2018. And just when we thought everything was going to be fine, the court's part 3, and we now have stays again against appointments of departmental chairs, initially in the civil courts, which we managed to have vacated, and as of yesterday, the Peshawar High Court has also issued a stay against the appointment of departmental chairs. The stated reason is that acting deans and acting hospital directors cannot appoint department chairs. They can do everything else, but they can't appoint departmental chairs. So obviously we're going to obey the court to the letter. Now just a few slides on what's been proposed for healthcare reform in the Punjab. A similar MTI Act, starting with those medical schools and affiliated hospitals which are already universities. This has already been discussed with the Vice-Chancellors of these universities. And then to extend that to the remaining medical schools. Each institution will have a one-line budget, as they do in the KPK. So therefore that's a major difference from the previous reforms process attempted here in the Punjab, where financial autonomy was not granted. And there'll be, as a corollary, complete administrative and financial autonomy within these institutions. There's retention of accrued benefits for staff, so if you switch to become an institutional employee, you carry all your benefits that you've accrued over years of service with you, pension and so forth. And you get to opt in or opt out of this at 2 points. You can opt in or opt out to become an institutional employee. If you become an institutional employee, you carry your benefits with you, and you would gain any additional advantages offered by institutional employment, such as a higher salary, for instance. If you opt out, then you can remain as a civil servant, remain in your current position, and continue in your current salary and benefits. The second opt-in and opt-out is institutional practice. So it won't be compulsory, it's voluntary. We fully expect that the more senior faculty will not opt into institutional practice because they only have a few years to go, but we hope that junior faculty, as has been the case in the KPK, will opt for institutional practice once facilities are improved and brought up to standard, as they have done in KPK. So primary and secondary healthcare is also proposed to be reformed. There's a plan to introduce an act, which I believe is going to be passed soon, forming district health authorities which will look after the healthcare in individual districts, each to have its own CEO, to run the authority with the hospital director, medical director and a nursing director reporting to them. These district health authorities then report to a regional health authority. It's planned that there will be 9 of these for the 36 districts of the Punjab. The regional health authority will set targets for the districts and will monitor implementation. In particular, one of the major key roles for these institutions will be to ensure that referrals from secondary to tertiary level care are appropriate. A fracture of the radius should not be coming to Mayo Hospital because it ought to be dealt with in the districts or at the regional level. So the healthcare reforms process, KPK, Punjab, wherever, represents a sincere and determined effort to bring about improvement and change. Is this the best way to do it? Probably not. Is it the only way to do it? Definitely not. But working together, we hope we can improve healthcare provision for everyone in this country. Thank you.
That was a tour de force. So I think I find it quite astonishing that people like yourself, who are clinicians, have gone on to develop a larger, bigger and overarching vision so that you have built institutions and you have transferred that experience on a much larger scale, hospital-wide and province-wise and health services-wide. So that's, I think, a wonderful achievement, and we have a lot to learn from it. I think I find it a difficult boundary to solve, the borderline between the judicial activism and the right of the civil administration to implement management and governance. So although both are moved by very noble intentions, I think that this boundary of maybe territory, I should call it, probably needs to be solved, and it will be eventually, I'm sure, if there is goodwill on both sides. Professor Khalid will want to welcome our chief guest, who is Mr. Rai.
I think let us welcome the chief guest of today, the President, Pakistan Medical and Dental Council. We are greatly honored, sir, you have graced this very important seminar on policy making as the chief guest. I think the speaker will continue with their talk, and in the concluding session, then the speakers and the chief guest will come to the stage, and the Honorable Health Minister will also join us, and then we can have the question-answer session later. Thank you very much, sir, for honoring King Edward Medical University. You also honored just a week ago, and we had got a very, I think, productive workshop for training of the faculty. The first time Pakistan Medical and Dental Council is supervising the research of all the medical institutions. They had an excellent workshop in Peshawar, and I feel honored that Honorable President selected King Edward Medical University for capacity building, and in Punjab the first workshop on the research and capacity building of the medical teacher, editors of the journal, that was conducted in King Edward Medical University. Thank you very much.
So I would like to introduce and welcome Rizwan Rashid. Rizwan is an amazing guy. He has been the sub-regional IT director for the UNDP for the Asia Pacific region. managing about 25 countries. He was the managing director of the Punjab Information Technology Board. And when I visited his office, I was very impressed. He showed me the programs about the control of dengue, about the monitoring of vaccination programs, how you can monitor the basic health units. I worked in the UK, and they started a national program for IT. I think Mahmoud Adil will be familiar with that. It was at the cost of about $15 billion. And after a few years, it all went down the drain. It was abandoned. So I think the two outstanding programs in Pakistan that I have seen are Shaukat Khanam actually, which as Asim just told you has been rolled out to Pakhtunkhwa hospitals as well. And also the PITB programs. So Rizwan and followed by Sablan Haider will tell us about their achievements and how the IT can provide a backbone for health service development and delivery. Welcome, Rizwan.
Dr. Gondal, distinguished medical practitioners, ladies and gentlemen, Assalamu alaikum. I guess I had a feeling that perhaps I, along with the plan, with the odd people out here, as the only techies, but I was pleasantly surprised to find my old schoolmate Hassan Moin Usmani here, who's also as non-doctor a person as can be, though he's married to an extremely distinguished medical practitioner. I would want to go through my presentation very quickly because I believe that we are running slightly late here. It is going to be in two parts. I'm going to be talking more at the strategic level, and then Saklan, my colleague at PITB, is going to be talking about specific projects that were implemented. Now, I'll start off by basically setting the scene, talking about what the current situation is, and there's been a lot of discussion about what policies should be followed, what model we should be looking at. And there's one model that, in my humble opinion, I think can seriously be looked at. And then we have a very, very good systems that we put into place in Punjab. Now, as you know, I don't have to tell you guys that as far as healthcare is concerned, it's fundamentally three areas: quality, cost, and access. You want high quality, low cost, and ideally universal access. Since I am an IT practitioner, one thing which I want to put across very clearly is that IT is an enabler. Forgive the type, R is missing. It's not a panacea. So you have to have the right systems in place for IT to come in and make all the difference that it can. Having said that, the way technology is evolving at this point in time, particularly in the areas of AI and whatnot, IT is going to become extremely disruptive down the road insofar as the way things are being done now would evolve. Like IBM Watson is a case in point, and so on and so forth. There was a discussion earlier, a talk earlier in which the gentleman mentioned that one of the biggest causes of deaths is actually giving the wrong medicine or the wrong dosage to patients. So technology even comes in there because there are solutions. There's an Icelandic company known as Medai that actually uses computer vision to ensure that wrong dosage of medicines is not provided to the patient. The medicine in the hospital at least is identified through computer vision, linked with the hospital management information system, and warning is issued that the wrong dosage is being given, and so on and so forth. Now, what do we have at this point in time? What we have at this point in time is implementation of IT solutions in different institutions, varying degree of quality implementation, but say Shaukat Khanam is a case in point where they've implemented hospital management systems. Aga Khan has done it, but it is at the end of the day a bottom-up approach. So these are disparate, isolated systems that have been put into place, and there are a number of other IT systems related to medical practice that are there, but there is no linkage between them. So the thing that needs to be understood, internalized, and looked at very closely is that this bottom-up approach is not the way forward. The way forward basically is a top-down approach where you actually take serious policy-level decisions on what bodies should be in place, how these things should be linked together, and then systems are put into place. So if this were sort of, I would give an analogy, it would be like a large picture with small jigsaw pieces. So what we have right now are some pieces in place, but the full picture is just not there. So we really need to look at that, take things forward. So, like I said, the recommended approach is to have a comprehensive health ecosystem in place, which is then supported by relevant IT systems. So this is a top-down strategic approach. And for that, we need to go ahead and develop it ourselves, or do we need to look at a successful model that has been done elsewhere in the world? Now, I just had the opportunity while I was working at the ITP to work with the Turks. And the Turkish model truly impressed me. The reason for that is that Turkey in about 2004 or 2003 was more or less at the same stage that we are at this point in time. Totally messed up. They completely transformed their health system in about 10 to 14 years. So this is a 180-degree turnaround in 14 years, to the point where some of the indicators, some of the KPIs are very close to OECD levels. So this is a model that may be worth emulating. I looked at it from an IT perspective, but this is, so I talked to my Turkish friends and I said, send me a slide that gives an idea of how you guys are actually functioning. This is an extremely busy slide, and I just don't have the time to actually explain it. To be very honest, I know some bits and pieces of it, but not the whole picture. So I'll be leaving this slide with Atar and others for you guys to look at. But my recommendation is that the Turkish model should be looked at very carefully. But what needs to be done is a lot of things need to be put into place. For instance, we keep talking about hospital management information systems, but we do not have the legalese in place to actually ensure that the patient record sanctity is there. There's no enforcement of standards like HL7 to ensure that the various hospital systems are actually talking to one another. There's no way of actually ensuring that the hospital systems that are put in place way down from DHQ to RHC to PHQ to DHQ to tertiary level actually talk to one another. And then all this data flows up in a way where proper analysis can be done on it. Predictive analytics down the road can be done on it, and so on and so forth. When I was talking, I went to go to Turkey and I went and looked at various government bodies. There was one that had the name of this particular entity was numbers. What they were responsible for was just to ensure that the patient record is they were gatekeepers for the patient record. So if I went to a hospital in a village, for instance, and then later I stepped out and went to a tertiary care hospital, the doctor in the tertiary care hospital would then contact numbers. They would make sure that the doctor that was contacting them had good reason to ask for that patient record, and then that patient record was made available. So the sanctity was maintained. And the multiple examples of various systems that are there in place to actually get the ball rolling properly, all the way from the GP level to the tertiary care level, health insurance, and so on and so forth. But the message that I want to put across from an IT perspective is that IT systems need not be put into place in a bottom-up level. First, the strategic picture has to be there, and then the relevant IT systems need to be put into place so that they eventually talk to one another, and all this data is meaningful. We end up with some meaningful output out of it. Having said that, we've done some excellent work at PITB, and for that I would request my colleague Saptan Heather to come and talk. Saptan is somebody that I've worked with very closely for 3 years. She's a force of nature, extremely competent individual, and I think he was the right person to take things forward and talk about various things that we did at PITB.
Thank you very much, Advansa. Thank you very much, everybody, for having me here. It's such an honor for me. I'll be talking about various thematic areas on which PITB, in fact, had been working and continues to work in the years to come. The very first thematic area in which we had been working, that is basically the deployment of hospital information management system. There have been loads and loads of talks about it. Everybody had been trying to basically crack the problem. But today, standing here in front of all of you, alhamdulillah, this is something where I can say that the system is successfully operational in around 27 facilities all across Punjab. That includes DHQs and DHQs, hospitals, DHQs and DHQs of Nankana, Rajanpur, Lodhra, Kamuki, and so many others. Just a few numbers here. We have served more than 6 million patients using this system so far. More than 25 million units of medication has been dispensed using the system. Then more importantly, around 1 million lab tests in fact have been described using the system. What you see on the screen right now is basically on the right hand side of the slide. It's basically the revamped registration area of DHQ Kamuki. So that is something which wasn't available in the past. There are certain business process re-engineering measures which have been taken while deploying the solution as well. And those in fact that every patient who basically comes into an OPD will have to go through the process of triage, where mandatorily the paramedics, which are basically placed over there, the nurses, captures the vital statistics as well. That includes the blood pressure, the weight, and all those things. What you see right here at the bottom of the screen is basically a link, which is tajziya.punjab.gov.uk. This is public, available to public. You can type it into your browser, and you can basically review the numbers, the patients who have been basically seen by who have been basically served via this data, and is in the various hospitals where the system is operational at this point in time. Before I move on, there's this small video which I wanted to basically show as well. I try and basically play a video from here, if it works.
महकमा सिविल और पंजाब आईटी बोर्ड के इश्तराक से आवाम की खिदमत और सहूलत के लिए एक और इनकलाबी कदम। खुशामदीद, आपकी तशरीफ आफरी का शुक्रिया। आने वाले मौजूद मरीजों से इल्तमास है कि बर वक्त और बेहतर इलाज के लिए इन हिदायत पर अमल करें। बराए मेहरबानी नज़्म और ज़ब्त का मुज़ाहरा करें और अस्पताल के अमले के साथ ताउन को यकीनी बनाएं। कतार बनाना महज़िब कौमों का शेवा और इस्लामी तालीमात के ऐन मुताबिक है। इंदराज के लिए अपना कौमी शनाख्ती कार्ड और मोबाइल नंबर जरूर फराहम करें। रजिस्ट्रेशन अपने कौमी शनाख्ती कार्ड और राब्ता नंबर के हमरा रजिस्ट्रेशन काउंटर पर अपनी बारी पर तशरीफ लाएं और अपना अंदराज करवा कर टोकन पर्ची हासिल करें। नर्सिंग वाइटल्स टोकन हासिल करने के बाद अपने इब्तदाई तिबी मुआयने के लिए तजवीज़ करता नर्सिंग काउंटर पर तशरीफ लाएं और अपना ब्लड प्रेशर, टेम्परेचर, हाइट, वेट और पल्स रिकॉर्ड करवाएं। बराए मेहरबानी अपनी बारी का इंतजार फरमाएं और काउंटर्स पर लगी स्क्रीन पर जाहिर होने वाले टोकन नंबर के मुताबिक तशरीफ लाएं और अपने वाइटल्स रिकॉर्ड करवाने के फौरन बाद नर्स के तजवीज़ करदा फिल्टर क्लिनिक पर तशरीफ ले जाएं। फिल्टर क्लिनिक नर्स के तजवीज़ करदा फिल्टर क्लिनिक पर लगी नशिस्तों पर तशरीफ रखें और अपनी बारी का इंतजार फरमाएं। अपना टोकन नंबर स्क्रीन पर जाहिर होने पर मुआयने के लिए तशरीफ लाएं। हमारे मोअज़्ज़िज़ डॉक्टर हज़रात आपकी खिदमत के लिए कोशा हैं। आपसे इल्तमास है कि अपना मुआयना इत्मीनान से करवाएं और बाद अज़ मुआयना डॉक्टर के तजवीज़ करदा नुस्खे के मुताबिक डिस्पेंसरी, लेबॉर्ट्री या कंसल्टेंट बुकिंग काउंटर पर तशरीफ लाएं। फार्मेसी डॉक्टर की तजवीज़ करदा मुफ्त अद्वियात हासिल करने के लिए फार्मेसी तशरीफ लाएं। आपकी सहूलत के लिए मर्द व ख़वातीन और बुजुर्ग हज़रात के लिए अलग-अलग काउंटर्स का इंतज़ाम किया गया है। मुतल्लिका काउंटर पर कतार में नज़्म व ज़ब्त के साथ मुफ्त अद्वियात हासिल करें। लेबॉर्ट्री डॉक्टर के तजवीज़ करदा लेबॉर्ट्री टेस्ट करवाने के लिए फ़ीस अदा करें। फीस की अदायगी के लिए बिलिंग काउंटर पर तशरीफ लाएं। फीस की अदायगी के बाद रसीद जरूर हासिल करें और लेबॉर्ट्री में तशरीफ ले जाएं। कंसल्टेंट बुकिंग काउंटर डॉक्टर की तजवीज़ करदा माहिर अमराज से मुआयने का वक्त हासिल करने के लिए कंसल्टेंट बुकिंग काउंटर नंबर 20 पर तशरीफ लाएं और अपनी बुकिंग करवाएं। स्टाफ की हिदायत के मुताबिक माहिर अमराज के क्लिनिक के बाहर लगी नशिस्तों पर अपनी बारी का इंतजार फरमाएं और वक्त पर मुआयना करवाएं। किसी भी शिकायत की सूरत में हॉस्पिटल में लगे कंप्लेन बॉक्स में अपनी शिकायत या तजावीज़ लिखकर डालें या हेल्पलाइन टोल फ्री नंबर 0800 99 000 पर राब्ता करें। आपकी तशरीफ आवरी का शुक्रिया।
हमारा अज़्म सेहत खिदमत, सेहत इबादत।
The footage which I have just shown you, that was basically taken from DHQ Nagana. I think the most important aspect over here is, this is something that we all possibly would have understood by now, that IT is something, and specifically talking about health IT. That is not something which could work out or which could possibly work in a silo. So we'll have to basically take into account all the other different problems as well. And then if there is any requirement of a business process re-engineering, that is something what we'll have to do as well. So the most important aspect as far as the patient experience of OPD is concerned, what we did, we established these filter clinics. So not a single patient basically goes directly to the consultant. He'll have to go through the route of filter clinics first. And if an MO sitting in a filter clinic basically refers a certain patient to the consultant, only then he goes there. Goes without saying, if there is a repeat visit of a certain patient to a consultant, he could go directly. Anyways, moving on to the next thematic area. This is another area on which Punjab Information Technology Board had been working. There is this process flow which I am basically trying to show. That once a patient is basically reported from a certain hospital, there is this portal which is available in all the hospitals all across Punjab. So the confirmed patient basically gets reported into the portal online. Then more importantly, field officer gets an intimation onto the smartphone which has been given to him. This is specifically operational as far as the regime of dengue is concerned, or alternative technique, vaccine preventative diseases. So the field officer gets this automated job order onto his smartphone. He goes into that specific location, maybe the residential address of that particular individual, and then he basically carries out the surveillance activity over there. So these are basically the 4 steps which in fact I am basically trying to highlight over here. The map which you see right there at the bottom, that is in fact taken from the polio campaign which was run in the April last year. And all those red spots are basically, all those red polygons are basically those areas where no activity was conducted, where there was no, this door-to-door campaign was in fact conducted. Goes without saying, excuse me for the typo there, but there are 14.2 million patient interactions which we have into the system at this point of time. There is this weekly bulletin which we publish as well as the disease incidence in this province is concerned, and more than 200 publications in fact have been made so far. Moving over to the next thematic area. This is an initiative which is operational in all DH2s, RHCs and DH2s all across Punjab. There are these biometric devices which are in fact installed. And specifically talking about the secondary hospitals, DH2s and DH2s, the attendance in fact have risen from 58% to 85%. We get more than 63,000 check-ins on a daily basis. And this is the system which is operational 3 years now. Moving over to the next thematic area, that in fact is the automation of drug regime. What you see on this again is a very busy slide, but I think at the same time this is something which is really important as well. What you see on the left hand side is basically, there is this abbreviation written which says CDSL. CDSL is Centralized Drug Sale Licensing System. This is the system which we had launched in Punjab around 2 years ago. And more than 27,000 applications in fact have been processed using this system so far. There's another mechanism for our drug inspectors. They have been given these smartphones. So they carry out these spot checks having these smartphones in their hands. So we are able to basically get hold of their geolocation as well as the timestamp as well. More than 60,000 inspections have been made using that. DTLs, there are around 5 DTLs all across Punjab, and all of them in fact have been automated. Which precisely means that when a typical DTL receives a sample, there is this secret barcode which is printed on it. Throughout the process, nobody could basically figure out that this sample came from which specific source. We are working on the automation of the quality control boards as well, DQCP and PQCP. There is this mechanism of medicine procurement, centralized medicine procurement, and typically medicine more than 6 billion worth of rupees is procured using this system. There is this mechanism of medicine inventory, which is working in all hospitals all across Punjab, DH2s as well as tertiary care facilities. Local purchase happens to be one of the important concerns. So there is this online bidding platform which BATP has set up, and this is specifically in use in tertiary care facilities all across Punjab as we speak. Moving over to the next thematic area. That is basically this integrated blood transfusion. So the idea was none other than a fact to basically put together some sort of a donor database as well, and then at the same time they have access to the centralized blood inventory from anywhere all across Pakistan. So this entire system is in fact operational in BIC at this point of time. We are in coordination with SPDP in Islamabad at the same time with the army as well to somehow implement it all across Pakistan. I'm going to move over to the next thematic area. That in fact is basically the inspection of facilities. So there was this regime which was set up where we have MEAs, monitoring and evaluation assistants. In most of the cases these are ex-army. So these are the individuals who in fact have been given tablets, and there is this application which is operational with them. So they carry out these surprise visits into the different facilities regardless of the fact if that is DH2, DH2 or any of the primary sector facility. They carry out these surprise visits and report against different parameters. These parameters could be attendance of the of the facility staff, availability of the medicine, patient experience, outlook of the facility, availability of the utilities, so on and so forth. Up till now, more than 200,000 visits have been conducted. Moving over to the very next thematic area. That in fact is the concept of telemedicine. So this is something what is operational in 4 facilities as far as the pilot is concerned in the district Mandi Bhaude. What I'm going to do now again, it's not a long video, it's around I think 40 seconds or 50 seconds. So if you bear with me, I'm gonna run another video for you that will explain the entire concept.
हुकूमत पंजाब के इस प्रोग्राम का मकसद बुनियादी मराकज़ सेहत में इलाज की सहूलियात मुहैया करना है, जहां डॉक्टर की हमावत रसाई मौजूद नहीं। प्रोग्राम के पहले मरहले में मंदी बहाउद्दीन के 4 बुनियादी मराकज़ सेहत में मरीजों को लाहौर में वाक़ई टेलीमेडिसिन हब में मौजूद डॉक्टर्स इलाज मॉनिटरिंग की सहूलियात मुहैया कर रहे हैं। बुनियादी मरकज़ सेहत में आने वाले मरीजों की बायोमेट्रिक निज़ाम के जरिए रजिस्ट्रेशन की जाती है। ऑटोमेटिक क्यू मैनेजमेंट सिस्टम से टिकट लेने के बाद मरीज के वाइटल्स का इंद्राज क्लाउड क्लिनिक इलेक्ट्रॉनिक मेडिकल रिकॉर्ड सिस्टम में किया जाता है। बारी आने पर मरीज का मुआयना टेलीमेडिसिन हब में मौजूद डॉक्टर से करवाया जाता है। चेकअप के बाद उर्दू ज़बान में कंप्यूटराइज्ड प्रिस्क्रिप्शन मरीज के हवाले किया जाता है और अद्वियात फराहम करके रिकॉर्ड को महफूज किया जाता है। इस प्रोग्राम के दायराकार को 250 बुनियादी मराकज़ सेहत तक बढ़ाने से न सिर्फ पंजाब के दही इलाकों में सेहत की सहूलियात फराहम होंगी, बल्कि ख़वातीन डॉक्टर्स के लिए मुलाजमत के मौके फराहम होंगे।
चेकअप करने की और अचीवमेंट दी बहुत ज़्यादा अच्छा है।
This was obviously the pilot project, but as per the latest discussion with CM Punjab and his blessings, and obviously Minister Sahib as well, this initiative will be expanded in the various districts of South Punjab very soon. Moving over to the next thematic area, and that obviously is the last one, because I think I have eaten up a lot of time already. So there is this centralized health line which Punjab Information Technology Board has set up. We provide medical advice. We have doctors basically placed over Terrace as well as this health line is concerned. Health line is operational from the last 5 to 6 years now. And more importantly, an area which is specifically very, very close to Minister Health, that is basically getting hold of the complaints and resolving them at earliest. So that is another area on which Punjab Information Technology Board is working. So that's it from my side. Thank you very much for bearing with me, and thank you very much for having me here. Thank you.
The next speaker is Dr. Tariq Kaur. He was at medical college with me. He spent the college years as if he was on a very long extended vacation. So for his carefree attitude towards life and everything in life, he was called the Prince. So I was lucky to be appointed for our first job in Multan, in National Hospital. And we went down to Multan, and luckily Tariq was posted a few miles away in Bihari, in a small GHU. So I think Tariq is probably the only person, at least he was at that time, who used to go to his clinic on horseback. So which I thought was quite exciting. And we used to spend weekends together in the farms and wandering around the rural villages of Punjab. So that was great fun. And I think also Tariq is the only person who went on to go to the UK and became a GP principal there. He is a trained surgeon. He has done his FRCS, also his FRC GP. So therefore he is very highly qualified. He is very heavily involved in teaching and training younger GPs. And therefore I think he will offer you a very unique insight in how the UK system works and what we can learn from it. So over to you, Dr. Tariq Mahmood Kaur. Welcome.
Thank you very much, Sahar, for your very kind words. I'm thankful to all the other people really for having me here and sharing my experience. I think a little bit different about me is so far I've had listened to so many exciting talks about hospitals, development, charitable organizations doing fantastic work. But primary care has been, I think, not touched upon very much here. And I think that will be probably one of the main themes where I will be probably addressing to. Adar has already told something about my background. At the moment I've got various hats. I'm running a GP practice where I'm the senior partner, which employs about 30 staff. In addition to that, I am a GP tutor for East Midland Deanery and a GP tutor for Leicester University, Nottingham University, and I'm also now getting some students from University College London. So there is some teaching side to it, but in addition to that, I'm also a director at Northwest Leicestershire GP Federation, which basically deals with about 15 local practices. Now, my theme really is to talk about mostly my experience as a GP in UK. A lot of the people who are from UK are probably familiar to some aspects of it. I'm going to just do some overview of how NHS works, but particularly the role which primary care plays in it. And I think that is, in UK setup, quite a pivotal role. And a quick overview of the training. Adar has set up some questions for me and try to address those during this talk. I'll try to address some of those, but it is a huge long list and time is really very short and I wouldn't really want to take too much of your time. You can address that in Q&A session if I am not able to do that. Now, regarding the UK was probably one of the first countries which actually introduced universal healthcare with the inception of National Health Service in 1948. It had basically three core principles, and I think that is what the nub of the matter really is. That a good quality health care available to every single person in the country, and it should be based on clinical needs, not the ability to pay, and it should be free at the point of delivery. Now these three core principles, NHS has done a lot of modifications, a lot of changes during even my time, but these three core principles have remained unchanged throughout these 70 years of development of NHS. NHS has grown to a big organization. It employs 1.7 million people. So in UK, by far is the biggest employer in the UK. It is, in fact, I was a bit surprised to know it is the 5th biggest employer in the world. So it's a huge, big organization. The doctors make about 12.6% of the workforce, out of which 2.8% are GPs. Interesting thing about the NHS is it's a huge big organization, but it is 98.8% funded by government with the taxpayers' money and some national insurance. Only 1.2% of it is funded by the patient who can afford it to do some charges and things like that. If we want to have a quick understanding of how NHS is being kind of organized, I've heard about so many, I was so much kind of frightened with Dr. Ghyas's presentation earlier on and then Asim's presentation, that there is so much of bureaucracy involved in everything. While NHS setup, if I could lay it out, if you could follow the money, how it works, is that 122 billion is the budget which is given to Department of Health from Parliament, and some of that is top sliced. 4.2 billion go to public health, which is delivered through local authorities. 7.4 billion goes to the basically regulating authorities like CQC and NHS improvement. There is a slight change in that as well. Now CQC, which is the Air Quality Commission, which is there to ensure quality provision by the providers, is now being funded by the providers themselves by instituting a levy from them. Important part of that really, I think, which may be relevant to me as well, and I think Professor Gondal mentioned about that before as well. The training of the doctors is done by Health Education England, and they are given a protected fund from the top of the budget. Most of the money is given to NHS England, 1.5 billion in this case, and that money is then allocated. Some of about 12.8 billion goes directly from there to primary care. That is me. It comes towards us directly from NHS England. 15.4 billion is going to specialized services like prison services and people with learning disorders and that sort of thing. Now, important thing in here is that the way the money is distributed to the providers is through clinical commissioning groups, which are called CCGs. This is a relatively new body, which is started in 2012. This body is primarily made out of GPs. It is headed by a GP. They are locally elected. There are some other representation like representation from pharmacists, representation from lay members on the board as well. It is primarily driven by the GPs, and they are responsible for commissioning services from the hospitals. So hospitals basically get money from CCGs, ambulance services, mental health services, and community services. They are all allocated their funds through clinical commissioning groups. And that, in a nutshell, is the general layout of the NHS. Now, where do the GP sit in this setup? Now, a GP is a kind of a strange breed. As you have seen before, the NHS employs 1.7 million people. But GPs are not actually employed by the NHS. GPs are self-employed, though 90% of their income comes from the NHS, but they are quite independent in organizing themselves. They are actually, they've got a core contract with the NHS. That is what they are contracted to provide a certain service. Another thing really about the system is that every single person in the UK has to have to be registered with a GP. They do have a choice of registering with a GP, but they generally have to have a GP to access any form of service. And GPs are set up basically to provide a basic level of service, which is a significant level of service now, because GPs are not single-handed anymore. They usually pool their resources. There usually are kind of 7 to 8 doctors in a board where they can actually provide a reasonable level of service themselves. But the services which they can't provide, then they are under obligation to provide an appropriate referral to the secondary care. But they are the gateway towards the secondary care, and that is one way I think the demand is managed quite effectively there. The other things which GP do importantly is keeping patient records. I think somebody already mentioned about the role of IT. GPs have been the trailblazers in use of IT in the UK. They have been ahead of secondary care, tertiary care, because that is where their income comes from. They have to be good at counting things. And that is why they always had good IT skills. They are virtually paperless. Most of the time they do not really use, I now don't even have to use my signatures to sign a prescription anymore because it is all done electronically. Important thing about this is that they carry out, have the most complete record of the patients. They have the record of the patient from the birth till death. Every single event which is relevant and sometimes even irrelevant is actually kept in those records, and they are all kept electronically, and that record travels with the patient wherever they go. If they change their location, they go to a different part of the country, they change their GP, that record is transferred there. And that is a very important bit of the care. Again, GPs are the ones who coordinate any care in the community. In some ways, if when a patient is admitted in the hospital, consultant is in charge of the care. But when patient is discharged out in the community, when they are living and doing their normal activities, their GP basically take full responsibility of their care while they are in the community. So GPs basically organize any kind of care which is coordinated in the community. They have multidisciplinary teams, particularly for palliative care in the community. They are vitally important, where these multidisciplinary teams have community nurses there, palliative care nurses on it, social workers on it, all the other relevant agencies which are useful in providing this kind of care. Lastly, there's a list to go on, but I think an important thing which GPs have to do is to liaise with the other practices and feedback to the CCGs, basically who hold the purse and distribute the resources. Now, just a quick word about, because I'm into training and teaching, where how the training is organized. Medical school obviously is 4 to 6 years, which is depending upon which way people enter into it. After completing medical school, they go into F1. F1 is the previously called pre-registration house officers. After F1, you are eligible for full registration. But in UK, you cannot actually work unsupervised, even if you have a full registration in most of the places. You still need to have something more. So they go for F2, which is previously used to call SHOs. But after F2, then people decide about various specialities. And GP training is a kind of specialty in its own right there, where they have a 3 years training program. This 3 years training program consists of basically 20 months of that are spent with a GP practice under a supervision of a GP tutor, which is spread in those 3 years. The rest of the 16 months are spent in various relevant specialities in the hospitals. Again, they are batches of 4 months of those specialities, and they are designed basically to train them, to give them the right kind of exposure, to prepare them for their life later. Now, during that 3 years' time, these trainees are quite rigorously tested, observed, and taught. They have a specific educational supervisor who actually follows them through all their training program. They have to go for this assessment every 6 months with their educational supervisor, who keeps an eye on their progress through their electronic e-portfolios. They have regular work-based assessments, and they also have to go through 2 major exams, which are fairly challenging. After doing all that, then they achieve their final certificate of completion of training, and they are ready for the big bad world, I suppose, and they can work independently. Now, how much this costs? This system, UK is spending about 9.7% of their GDP on their health, which is, again, if you look at this graph, it's a little bit busy graph, and I don't think you can actually read it there. But UK's place there is in yellow, which is about 14th place in OECD group of countries. So it is not spending, if you look at the big line at the bottom, that is where USA is, which is literally spending about double the amount which UK is spending on their health care. And just a quick way how this money is being spent. The main part of the expenditure again comes from the public purse. UK is spending about 190 billion pounds on their health care. So this big yellow part is the one which government is spending directly, and rest of that really is basically a number of other institutions like voluntary organizations, non-profit organizations, various private insurances, and some people pay out of their pocket as well. And another way of looking at that is that on the average, healthcare spend is about less than, just under 3,000 UK pounds sterling, and majority of that is, as seen before, is contributed by the government through the taxpayers' money. Now, this is another slide which I think, again, is a busy slide, but what I want to allude to that really is that how that money which is being spent on healthcare is actually divided between various healthcare providers. Now, the first bit of the graph really is, which is taking a major part of it, is basically the money spent by the hospitals. Now, the green part of that really is where the ambulatory healthcare is. This is the part which is shared by GPs along with ambulance services, mental health services, and few others. Now, what is evident from here really is that number of people who use the primary healthcare is exceedingly more than what is being used in the hospital. But proportionately, hospital spends a lot more money than the primary care does. So it is quite evident that hospital care is the most expensive part of the care. It is a necessary part of the care, obviously, because it is needed for a lot of things, but not for everything. And this is where I think I will allude to that later on in my talk. This slide is basically, again, showing us the expenditure, which is ever becoming more and more so now, is the long-term care expenditure. So there is more than 45 billions of one which is being spent on that. Now, I've been told that I'm running a bit late here, so we'll need to really go a bit further. Where does UK stand in generally ranking of provision of service? They are actually doing fairly well with that, that they are providing value for money. Now, if we come to Pakistan and where Pakistan stands in this scenario, where UK is spending about $4,500 dollars. This is the last WHO data on their health care. If we compare that, UK is 14th in the ranking, and the other one which I have picked out from the same data really is where Pakistan is spending $38 as compared to UK spending $4,500. We are spending $38 per capita. Now we can argue about the data. It is from the same data there, but the implication is fairly obvious. The amount of money which we are spending on our healthcare is minuscule. Another way of looking at that really is, again, which struck me a little bit, was that Pakistan was 135th in ranking of which is basically the size of the economy. But the total health expenditure per capita wise, Pakistan is 170th on the ranking. So we have got only a small cake, so to speak, but health gets even a smaller proportion of that cake. And that is the implication of this particular slide, that health is really a poor relative in our... I will probably skip with various models of universal health care. Just suffices to say that UK falls into a single payer category, where most of the care is provided by the government through taxpayers. There is no private insurances involved in the care of delivery of care. Just a quick look through what kind of universal care is provided by various other people. There are various models being used, and they all have their pros and cons, and they are all doing a fairly good job. The thing to notice there really is that UK is not spending that much of money, as again you can see the United States is spending twice the amount of money, while I think the ranking, this WHO ranking is a little bit of a farce. I think this is out of date. They ranked that in year 2000. It was quite controversial, and they never, I think, did do the ranking again after that. So since, as far as I am aware, after 2000, they haven't done any ranking. The other figures are fairly up to date, where I think UK is faring really well in their health care. Now, the question really is, what is the best model of care? And this is something which is difficult to answer. Where do we look for it? I felt that the amount of money which is spent there is so astronomical. Looking at their model probably is not going to be the best thing for me to do. If we look at the local regional economies, I have seen some good examples in nearby countries where particularly impressive was the Sri Lankan model, which they have started more or less on the same grounds as we did, and their health outcome measures are actually getting better and better and going in that direction. Now, and I have tried to sort of pick out, without going into the details of their health economy, I thought that if we could follow their model, which will be probably more practicable in our environment. And I've just got a few suggestions really out of that. One is, I think it is the elephant in the room, which is, I think, it is the lack of the resources here. We may have very shiny big hospitals and institutions and all the rest of it, but it is really not trickling down to the place where it matters, which is where most of the population lives, which is the rural economy. And the main reason really is, as I've alluded to before, it is the serious lack of resources. There is not really enough resources being allocated to them. So that requires serious investment, and I think current government is promising to do that, and hopefully will. And basic emphasis really need to be, and this is where I think it is quite obvious there as well, that they are trying to shift as much work from the secondary care into the primary care, because primary care can do that work much more cost effectively. And that is where I think we need to really put more emphasis on, that we need to strengthen basic health units. Again, various people have alluded to that, but that the maternal and child health care need to be focused on communicable diseases,
prevention and health promotion aspects of it. Sri Lankans have also now added chronic disease management to it, in addition to managing the minor ailments. And also I think I would suggest more diagnostics at a primary level. Basic labs, maybe even X-rays and that sort of facilities at a very basic level so that they can actually provide more care. And the other thing really is perhaps we need to think about a model where primary care has got, can be used as a gateway for referral pathway to the secondary care, and thereby hopefully trying to manage the demand in the system. And the other thing really is, which is a structured training of the GPs, because here GPs are not really trained at all to do their job. They can do a lot more than they are doing at the moment, but they need to be properly trained for that. And then basically the last bit really of that really is that how do we keep good capable doctors at primary care level? They need incentives. They can't really be treated like poor cousins, and they would not really stay there. So there has to be something I think everybody need to think about. One thing obviously is to increase their remuneration somehow, maybe allowing them to do private practice are some of my thoughts, but that is where I will leave it with those thoughts with you. Thank you very much for being patient with me. Thank you.
So I have now the honor to introduce Professor Mahmood Adil. He is a Cambodian graduate of 1987. He has done clinical medicine and also preventive health. He's very highly qualified. He has trained and qualified in Pakistan, Britain and the US and top universities including Harvard. And he's on the visiting faculties of Yale University. Currently he is with the Scottish NHS in the business unit. He has been the medical director of the CQC, Care Quality Commission in the English National Health Service, a bit like the Healthcare Commission in the Punjab. But very importantly, he has been an advisor to the Turkish government. Those of you who follow the international scene in healthcare will probably know that Turkish is an amazing example of a wonderful turnaround in healthcare, where they have most of the population covered in terms of healthcare access. And Dr. Mahmood Adil has been instrumental in providing his support and advice. I think it would be sad if we did not benefit from his advice, his talents and his professionalism. I'm particularly grateful because he has travelled all the way from Scotland to be here with us today with a brief and forced sojourn in the Middle East. So welcome, Professor Adil.
Honorable guest and Professor Khalid Masood Gondal, I can't see him around, he would be around, my class fellows and all the dignitaries. Assalamu alaikum. Can I ask, can you hear me at the back? Because when I was sitting there, I was struggling at times. Can you hear me? Okay. Right, so I think it's very privileged to be over here, and thank you. I thought one day he sent me an email and a call, and then I said, well, what it would cause, and would be delighted to be over here. And the whole idea is that we need to share knowledge so that knowledge can save lives, and I think that's what the whole program is all about. So I am medical director responsible for many of the national functions of the whole Scotland, and before that I was responsible for quality and efficiency for the whole England. So I think I've seen quite a few things, and what I decided that for my next 25 minutes or so, I should divide my talk into three parts. That first of all, we need to give you an outline that what is a health system. It's just a recap. Second, to explain that what is value-based healthcare approaches to deal with the challenges based on my experience with the UK, US and Turkey. And then to highlight some of the discussion and the points that if I have to advise the Pakistani government and what it should be so that we can be one of the best healthcare systems in the world, inshallah. So ultimately the goal is that we should be achieving good outcomes with fewer resources or with fewer rupees. So the context, just to start with, you go to any health system in the world, you will see those 6 things, more or less. It needs to have a governance and management system, it needs to have a finance, it needs to have a service infrastructure, all the secondary care and primary care and tertiary care. It needs to have doctors, nurses, the whole human resources, and then it needs to have technology inventory of the medicines, and then of course it needs to have information and data system. So this is in a nutshell of a health system. Someone asks what is health system? These six things make health system. Then what is the purpose of the health system? It is not having a health system. What's the purpose of the health system? It is to meet the health needs of the population. So I divide the health needs of the population into health protection needs, health promotion needs, and health care needs. So today I will concentrate on healthcare needs. But in a nutshell, you need to be thinking about health protection, the immunization, the maternal mortality, number of other things, and health promotions. But the goal of the health system is as simple: longer, healthy lives. I say longer. For example, Pakistan average life expectancy is 68 years. The UK life expectancy is 81 years. There is a big difference of 30 years. This means longer life. When say healthy lives, you could be living longer, but you could be having a longer chronic disease. It means you're not living healthy lives. So the notion is you need to have a compression of morbidity. We all have to die one day, but when the good health system, they treat you, they help you in such a way that the last few years of your life should be ill, but most of the time you are having a very healthy life. So that is the ultimate goal of a health system. If you can assess the health needs of your population well. So I think with this context, we need to be thinking, what are the challenges? So the big challenge is, on one side there is a need, on the other side there is a resources. So need versus resources. So if I think about the UK, so our biggest challenges are the chronic diseases. So 1/3 of our population is having more than one chronic diseases. People are living longer. When people live longer, they get more chronic diseases. They become more reliant on number of other services, which needs, of course, resources. New technology drugs are coming, and of course you need to use them, but it's costly, and health inequalities. So that is the biggest gap between the need and the resources. So that's the challenge, and this is the challenge every health system has to take. So again, it's a busy slide. My other colleagues have already mentioned things. These are the 6 developed countries: the UK, the Germany, the Spain, the France, the America, and Sweden. If you look at the lines, these gaps is increasing. Here is the resources, here is the need of the population. Resources, need of the population. As time goes by, the gap is widening. So people need to be thinking, and the system need to be thinking, the leaders need to be thinking, how best we can deal with that main challenge. So one of the way forward, the solution is having a value-based healthcare. So this is the context. What's the health system? What's the purpose of the health system? And what's the challenge of the health system? And here's one of the solutions for value-based healthcare. So what is value-based healthcare? It's again, it means that we need to have the quality, the useful outcomes divided by the resources being used. And the resources are defined as direct cost, waste, and variation. So be mindful that when we say value, it is not just the direct cost, the 122 billion in the UK, or maybe the amount of money less than $40 per capita being spent in Pakistan. It is also the waste and the variation. And again, the purpose of the value-based healthcare is maximizing health outcomes for every pound or every rupee spent. So, when we say quality and outcome, we need to be very clear. In the NHS, when I use the word quality, it is being taken. It's very easily, these are the 3 things in quality. Safety, having no harms. Professor Sarwar already mentioned all those harms. Our biggest 5 harms are inpatient falls, medication errors, DVTs, hospital-acquired infections. So these are the biggest harms. providing evidence-based effective care. We have got NICE, National Institute for Clinical Excellence, and it's expected that all the treatments being recommended, it should be used. So providing the effective care. And third, the patient experience. It is not the patient experience about the hospitality of the service, but also the patient experience about the quality of life before the treatment and after the treatment. So every time we use the word quality all over the UK, we need those three things. So if we want to achieve outcome, these are the three outcomes we would like to achieve. Then come the waste and variation. So I've given some example. If you can't read it, the first one is the patients. For example, if the patient is having multiple histories and multiple investigation, it is a waste. Let me give you an example. In our health system, in every August, there is a new intake of the new doctors. They're starting the health shop, so on. And when I look at the data, in every August, the number of full FBCs has gone up. So the number of tests done on your blood has gone up. And it was very interesting. So I told the minister over there that this is what is happening, that all these junior doctors are coming, and every patient who is coming, they are just saying that this patient will have that particular test. Then looking at the doctors, that if the doctor is not starting their clinic on time and they don't have the right paperwork with them, it means that there is a lot of variation. If nurses are not spending time directly with the patient and they are doing a lot of paperwork, it means that's waste and variation. These are a few examples. There's a lot of data behind it, but I don't have time to show, but these are few examples. Then coming to the developing the value-based healthcare, there are 5 essentials for value-based healthcare. The first one is that we need to have the health service delivery models. It's a big paradigm shift we need to have in terms of our health service models. Next one is we need to have a reliable and comprehensive national health intelligence system, and I will explain that. And then we need to modernize our curriculum to have new skill set, because the workforce, the clinical medical workforce we are having now and in the future, it would be we need to have very different skill sets. And then we need to have the knowledge to action organization which can change the knowledge into actions. And then finally, we need to have the best practice, and this best practice is from the national and international practices. So let me continue while the Minister of Health has arrived, and it will be very timely in talking about value-based healthcare. The big paradigm shift. So what if you look at the UK, the big paradigm shift which is happening is that we are moving from service quality to clinical quality. Second is patient-based to population-based. Third one is from curative to preventive. Fourth one is hospital to community services. And the last one is healthcare to health. Health is physical, mental, social well-being. And when I say health, we are very keen to involve the local governments in order to deal with the broader determinants of health. So these are the 5 big paradigm shifts which are happening in the UK. And this is one of the reasons that we are achieving a lot. So let me explain that when I say from service quality to clinical quality, when I say service quality, the service quality is actually the way it's being defined in the UK. It is the physical setup of the system and the sum of the processes. And the clinical quality I've already explained, the safety, effectiveness, and patient experience. So when this shift is happening, I can give you an example. As I told, I used to be the medical director, maybe the first medical director of the Care Quality Commission, which is our national regulator. So when we were developing the Care Quality Commission over there, we are very mindful that if we want to assess our hospitals should be achieving the ultimate goal of achieving the outcomes, not just to provide the service quality. So let me give you an example. So it means that this is the Care Quality Commission, and we ask every hospital need to publish their quality account. Not only the financial account, but the quality accounts. So it is mandatory by the board of every hospital in the country that they should publish their quality account. Quality again, number of patients who had fallen in the hospitals, how many infections was in hospital, and all other things. And then plus when the Care Quality Commission go in order to register them and in order to accredit them, once a year they look at the quality account and they look at the finance account, look at a number of other things. The other thing we are very key that we need to make it very open and transparent to the public. So this website called My NHS, if you are living any part of England, you put your postcode in, all the hospitals which are in the vicinity, they come up and their quality accounts come in front of you. So if you want to be treated, you can question the hospital why they're having more infection rate, and I do not want to be having my knee surgery or my hip surgery in your hospital. Patient has the right, they can choose the hospital they want to be in. So the quality accounts, the quality indicators are available in the public domain. Then, as I said, I think I had the privilege that from 2012 from 2017, I've been advisor to the Scottish government, and of course, I've been advisor to the Turkish government, and of course, the Turkey has made a big leap in the last 14 years. And when the Minister of Health came, and he was very kind, and he said, look, I really want your help. So I went there, and I think a really small story that he took me to meet with the President. And the President then, I think Professor Donald said that we are the ambassador when we go out. So he said to the President that Mahmoud is helping us to improve our quality and health system. And his response was, because he's our Pakistani brother. And I think that was the best response you can get. And the next question he asked me, when are you going to help Pakistan? Because their indicators are, of course, worse than ours. And my answer was that when the environment was more conducive, it looks like it's more conducive environment now. And inshallah, it will happen. So the Turkey and their quality, and then they went from good to great, is very important to remember. How did they manage that? So this is the Turkish clinical quality indicators. So when we started this journey in 2012, so they followed the advice, they set the standard, they put the accreditation in place, and all those chronic diseases, 12 top chronic diseases, they put the indicators, they collect the data, and then they change. So here, Turkey has got 81 provinces. Here is the map of the clinical quality of all the provinces. Here is Punjab, we have got 36 districts. And I think when Asim was talking about the new approach in the Punjab government, this is music to my ear. Because you need to make the district level accountable, give them the authority, give them the target, give them the indicator, like the way it has been done in Turkey, like the way we are doing over there in the UK. So I think that is one of the ways that we need to be thinking that how best we can improve the clinical outcomes of the health of the nation in Pakistan. Then my second point, which is about achieving value-based healthcare, is data to applied intelligence. I think I very much enjoyed Mr. Rizwan talk, and then what's happening over here by Punjab IT board. But I think this is the cycle. If you want to be effectively using data, it is not the data which is important, it is the applied intelligence which is important. That is where the doctors and the nurses and their understanding about the data comes into play. In simple, this is the cycle that you collect the data, you define the data, you collect it, you analyze it, and then you explore it, and up to here is all technology. After this, the human factor comes into play. If our doctors and nurses and our managers, our politicians, they don't understand that how this data is being interpreted, it's no good to help. Then after that, we publish and share, and then we take actions to achieve value. So this is the cycle of from data to applied intelligence. And let me tell you now about a little bit about Scotland, because like Pakistan, in the UK, although it is one NHS, but the health function has been devolved to to all the 4 nations. So Scotland, England, Northern Ireland, and Wales, they do have their own services, but they stick to the NHS principle. So in Scotland, we have got the best of the best data in the world. There are very few countries in the world which I can think they have got so-called better data than Scotland, maybe Finland and Denmark. But otherwise, we collect about 200 data sets about the whole population. This is not survey. This is the real data being collected from birth to death on 200 data sets. And what we do? So let me give you an example. There are 1,000 births every week in Scotland. There are 20 million drugs being dispensed every week in Scotland. And we collect data on 500,000 of patients being seen in emergencies. All this data is being collected live. So it is not against survey, because a lot of the developed countries, they rely on survey. This is the real data which we are collecting. What we do, we put all that data, let's suppose in a basket, all that data set, you put the CHI number. Every person who is living in Scotland has got a unique number called Community Health Index number. This is only in Scotland, not in England, not to other countries, only in Scotland. And the beauty of CHI number is it started in 1968, so we can do the data linkage retrospectively and prospectively. And then you put the pound sign in, you will know on every patient, including me, that Mahmood, how much NHS has spent on Mahmood. They can look at my whole patient care pathway. So here are some examples of our data intelligence. I say applied intelligence, not the data. So we have collected the data. These my IT colleagues and team. I've got 600 people who work in my team and they just do all that time. But the point is not collecting data. It is about how to apply it. Here is something we do. We call it NSS Discovery. You go on the internet, you will find it. So we have got all the data sets and all the hospitals and their data sets. And not only that, we also collect the same indicators from the 3 other countries. And what we do, here's an example. This is the clinical outcomes on a lung cancer patient. These are all the indicators. These are all the quality indicators. These are all the hospital, each of the quality indicators. It is telling red, amber, or green. It is setting a 6-year trend. So in that way, we can do the benchmarking. So the hospital versus hospital. But as we say, not only that, for example, if you pick up trauma and orthopedic surgery consultants, there's a consultant level data because the patient being treated by consultant, we got the data. We can do the benchmarking on the consultants because how many consultants are there and how much operation they're doing and what are their outcomes. That is called applied intelligence. And once you start looking into this, then you can start improving the services. Here's another example. I think Professor Asad mentioned this morning about the eye services. This is our atlas of variation for our cataract services in Scotland. So it means that it is standardized data by age and by gender. So if there is a variation, the first question being asked by the government, by that health board, why there is a variation doesn't mean that you are wrong, but that open up the conversation why one part of Scotland is having higher number of cataract operation than the other part, while it is age standardized data. Then another example, diabetes. Very much prevalent, chronic disease. So people talk about the diabetes data. I know exactly how many patients have got diabetes, not how many patients have got diabetes. So our percentage, 5.3% of the patients of the population have got 300,000 patients. 10% of the health budget is being spent on diabetes. So this is the biggest spend on any disease in the NHS, that is diabetes. And then this is the information available on an app to every diabetic patient in Scotland. So they can see their HbA1c rate, they can see their blood pressure, everything. If it is in the red zone, they can speak to the nurse. So, and the other point is 80% of our diabetic patients are being cared in the primary care. So the cost of the primary care is less than the secondary care. So we don't allow our patient to get complicated because they are well managed by the nurses, not even by the GPs, by nurses. and this is the outcome of our way. Then why the diabetes is happening? That's another example of our data and intelligence. This is a map of England, and it shows the number of fast food outlets per thousand population. Here is Manchester, and here is Cornwall, here is London. Interestingly, this is the Manchester area. This has got the highest number of outlets like McDonald's and Kentucky and a number of other things per thousand population. The other thing we have done, we have also located that where there are schools and where there are the outlets, and if they are in the vicinity of 1 to 2 miles, the local authority have got the right and they can stop having new outlets, and the government is working with the local, central government work with the local government to ensure that there should not be any new outlets very near to the schools. Now just remember this map, which is the outlet. Here is the map of our diabetes in England. Look, here is the Manchester, it is getting red, it is 2025. So you can understand the nutrition and diet and the data and intelligence is helping you to understand where you're going to get more diabetic patients. Then my third point, which is about achieving value-based healthcare, is we need to modernize our curriculum. I think I was impressed about 2 months ago. I was here and I attended the 52nd convocation ceremony of College of Physics Surgeons of Pakistan. It was very impressive to see there are over 73 specialities. They are producing postgraduate doctors. And then we have heard from Professor Gondal that how excellent that monitoring system is. But my question is that the future medical workforce, they need some different they need some very different skill set. They need to understand about resource and cost. They need to understand about data and applied intelligence, and they need to understand about quality improvement. I think we heard from Professor Server this morning. I'm a fellow of Institute of Healthcare Improvement from Boston. When I did my fellowship, I just realized that this is something which I have never been told in my undergraduate and my postgraduate training in the UK. But because when you want to improve the quality, you need to understand these are 3 very important skill sets we need to inject our undergraduate and postgraduate. When I was in King Edward and I think subsequently in the UK, stethoscope was the key stuff. So everything about clinical skill, the time has come. I was working very hard with the UK Medical School Council, and I convinced them that they need to move from stethoscope to datascope because we have got so much data and health intelligence available. And if our future medical workforce does not make that shift from stethoscope to datascope, we won't be able to meet the need of the health system. Okay, in summary, on the second part of my talk, NHS to value-based healthcare. I don't want to repeat which my colleague from UK already mentioned. The NHS was born on 5th of July 1948, just almost a year when the Pakistan was built. And then, key principle, universal healthcare, free at the point of delivery, and based on clinical need, and everyone should be registered with a GP. But the ultimate goal of the NHS is to improve the health outcomes of the nation. If the NHS is unable to improve the health outcomes of the nation with those principles, then it is not going to help. And this is the first leaflet which was Parliament published on the 5th of July 1948, saying that everyone who is living in the UK, and there was a very good leader at that point in time, he was the Minister of Health, his name was Naib Bevan. He came up with the idea, and then Naib Bevan's idea of NHS was implemented. Now, we celebrated our 70th birthday of the NHS. Look what happened. I think again, the slide has been shown. This is the work done by Commonwealth Fund from New York. They looked at OECD country, looked at number of parameters. UK is number 1 in almost all parameters. How did, within 70 years, they become one of the best healthcare systems in the world? So this is a journey they did. If they can do it, you can do it, we can do it over here. So now the ideas for Punjab or Pakistan for its journey. So this is where I feel that the knowledge needs to change to ideas, ideas need to be implemented, and that implementation save lives in Pakistan. So, first of all is we need to have a very ambitious vision. We need to have a stretching milestones, forward looking. We cannot look back and say what happened in the past, and if you look back at what happened in the past, you will never ever be able to look forward because you can't change. And then we need to have an incremental, stepwise and sustainable actions. So, if I have the option to give ideas, sorry, I have to say one more thing. I told you the challenges we had in the UK, but if you look at Pakistan, you add communicable disease with chronic diseases, you increase the infant mortality rate, you look at the amount of resources we have in Pakistan, it's a big challenge. Then it reminded me that when we went to medical school, and one of the key words in Quran, it says that whoever saved a life, it would be as he saved the life of all humanity. And I feel myself, and many of us, the leaders and the management roles, that we are able to influence the lives of millions of people. So someone asked me, I think a few years ago when I was in England, what do you do? I said, I touch the lives of 55 million people. Like Turkey, you can touch the lives of 80 million people. But in Punjab, you can touch the life of 100 million people. So this is the challenge for us. But again, when there's a big challenge, people say that how we can find a solution. Then look at Prophet Muhammad, peace be upon him, hadith. He said, Allah did not send down any disease, but that He also had sent a cure. If we are a system doctors, then I am sure that God has given the cure, we need to find it. And this, I think that's the journey we have to do, and we have to do in Punjab and Pakistan. But the key contributor to this journey and the people who can achieve it, I just call them nicely, is the politicians, the patient, the public, the policymakers, the press and media, and of course professionals. And of course the press and media play a big role. I think I always say, same in UK when I'm on the podium, that the media need to talk about the positive stories. It is easy to talk about the negative stories, but there are so many dedicated people working in new hospital, working all over Punjab. Same as in the UK, but the media pick up the negative thing. And that brings the morale down. So media has got a big role to play, to engage with the public, to give them the right information, but also to improve the morale. So if I have to write the prescription for success, again saying, being a system doctor, being a clinician, we can't run away from writing a prescription, then I would say that the first is that we need to have applied health intelligence system over here. Not the data, but the applied health intelligence system at the national level, at the provincial level, at the district level. Second one, we need to have quality standards. So we need to have hospital clinical quality accreditation program so that we can accredit our hospital, but the onus is not only Healthcare Commission, but also the PMDC need to be thinking very carefully that how best they can build on their successes, on the quality assurance of the people, of the medical graduates who are coming out. The third thing would be the National Institute of Service Innovation and Improvement. Everything I talk is underpinned by service innovation. We had the National Institute of Innovation and Improvement in England. And then that institute now has been spread all over the country. In every part of the country, there are smaller institutes who are working on that practices. What they do, they act as a think tank. They are acting as knowledge to action, giving how-to guidelines, and they also identify national and international best practices. Because everywhere in Punjab, everywhere in the UK, everywhere in Turkey, everywhere in America, there are pockets of excellence. And if we don't identify that pocket of excellence, how difficult would be that we have to spread them around. So first you have to identify, then we have to spread. And then the academic, industry and health services, they need to collaborate. This is one of my biggest lessons when I was in America. I learned that most of the time we see industry as not as partner. I think we have a good excellent example of airline industry, and then we learn a lot from Toyota. But at the end, if you want to improve services, there need to be an academic industry health service collaboration. Then we need, as I said before, we need to modernize the undergraduate and postgraduate curriculum. The workforce need to be the fit for the future. So from stethoscope to data scope. Then augmenting resources. We can think about, traditionally, we think about resources, either rupees or pound sign. What I did when I was in the Department of Health, we looked at and we realized that we can co-produce health. The notion is co-production of health, not delivery of health services. Because if the time has come, all nations, they need to think how they can co-produce health, and the concept is not so difficult. Yeah, let me give you an example. That the NHS budget is £122 billion. The carers, the people who care the patient with chronic diseases and the people who are elderly, they are adding £120 billion into the country because they are providing a services worth of £120 billion. So how best we can have an expert patient program? So these are the patients. For example, diabetes is a very good example. That we have got expert patients, and these expert patients are helping other patients. And then we need to have efficient care pathways. Service delivery models, I already mentioned, as I said, I think Asim talk was great. He talked about the next step about the district authorities. We need to have a population-based finance and management system. They need to have the accountability, authority, and the right responsibility. We need to think about hospital without walls. So most of the time, the traditional services is that everything is being provided in hospital. So we are moving our patients, we are having our virtual wards now in the community, which can be monitored. It's not only telemedicine, telecare, but these hospitals are responsible for the patients. I visited Spain, and the Minister of Health took me around, and he was saying, these are small little yellow cars, and these are the cars which go to the patients who are actually at home and stable, but we are monitoring from the hospital. And then there's a new concept coming in the UK. It is called not primary care, it is called pre-primary care. Because the apps which are available on your phones, and a lot of things are coming, and it means that the people who are educated, they can understand their health disease better, and the pre-primary care services are booming. And this is another area people need to be considering. So, last but not least, I think we are here. I think I am from UK and my other colleagues from America, and then many others. So we are here to support your health service development. So you're not alone here. I think we would be very, very keen that how best we can help. I think it's a knowledge we are groomed from here. Now it is the time to pay back. But the environment need to be conducive. Again, I said, but it is here now, and inshallah we'll do our best. But let me conclude by saying, I think the way I see, the biggest danger to us is not like we aim high and we miss it, but we aim low and we hit it. Thank you.
Thank you, Mahmood. That was outstanding. Thank you very much for coming from Scotland all the way at your expense, as I'm sure most of us have done from the UK and from the USA. I must welcome and thank Professor Yasmin Rashid, who has joined us today. She has become specially giving up her public and government commitments. Professor Yasmin was a very popular student leader when we were students in a very popular medical college, especially it was very popular at the KAE. Then she became a leader among doctors, a leader among teachers, and now she's a leader of the masses. So please welcome my leader and yours, Professor Yasmin Rashid. She will tell us.
Bismillahirrahmanirrahim. I'm very grateful that you have given me a chance and opportunity to talk about what we are trying to do where health is concerned. Quite a few things which Dr. Saab came up with are what we are already trying to work on, and it's really very nice to hear that we seem to be on the correct track. Basically, our vision is, of course, healthcare, universal health coverage. Everybody understands how important universal health coverage is. It's not only that we provide services, but there should be equitable services and there should be accessible services. मसला तो ये है कि क्या जो सर्विसेज हम देते हैं सबके लिए एक जैसी हैं या नहीं है, या अमीर आदमी के लिए कुछ और है, गरीब के लिए कुछ और है, और जो दे रहे हैं उसकी क्वालिटी क्या है और उसकी एक्सेसिबिलिटी क्या है, क्या एक बंदा गरीब आदमी जो है वो भी अपनी सर्विस खरीद सकता है या नहीं खरीद सकता, दैट इज व्हाट इज इम्पोर्टेंट. सो बेसिकली हमारी विजन जो है, इट इज वर्किंग ऑन हेल्थ केयर फॉर ऑल. Now we have a 100-day agenda. We were given a tough task by our taskmaster Imran Khan because he aims for the stars. उनकी कोशिश ये होती है कि हम मैक्सिमम अचीवमेंट करें. तो पहला 100 डे एजेंडा था मेरे पास, उसमें ये था कि we were looking after nutrition, immunization, health insurance, upgrading emergencies, availability of medicines. We wanted to have uniform diagnostic rates in all the labs which were being run by the government. We were concerned about the human resource because we had all the hospitals were working on 50% capacity. We didn't have a very robust complaint management system, and then we were keen on a public-private partnership between Punjab Health Foundation and those doctors who want to work in the private sector. So what we did was, we did an extremely robust campaign for which I'm very grateful to the support that we were given by DFID. We have a program which is running in collaboration with the government, which is known as IRMNCH program. और उसके तहत हम लोगों ने एक बहुत बड़ा एफर्ट किया. We did a huge effort, and the credit goes to the team which worked. There were more than 15,000 workers, because if you take Punjab and the population that we have in Punjab, अगर आप इसको population के लिहाज से समझें तो आप ये समझें कि ये छठा बड़ा मुल्क है दुनिया का, but that becomes the 6th country of the world. So basically what we did was, अगर आप देखें the total children were screened, आपके सामने फिगर्स है, 80 लाख बच्चा जो है उसको स्क्रीन किया गया. और उनमें से हम जो सबसे बड़ा हमारे लिए मसला इस वक्त माइल नरिशमेंट एंड स्टंटेड ग्रोथ, यू नो, खान साहब टॉक्स अबाउट इट ऑल द टाइम, इज एक्सट्रीमली कंसर्न्ड अबाउट इट. वी मैनेज टू आइडेंटिफाई more than 300,000 children who were either malnourished or they were severely malnourished, for which they required proper treatment. Of course, the sort of environment that we have and bad practices regarding, we still have to teach people to wash their hands before they take food, and dirty water being taken in by children. The deworming process has to be done all the time. So we went through a deworming process of more than 48 lakh children who were dewormed. And then we also provided them, you must understand, of course, there were children who required a lot of help, and I think 27 lakh 48,000 children were provided with MS, ORS, zinc, all these things were given. So it is a part of not only the nutrition, but a part of the preventive program which was running. We identified mothers. There were 19 lakh mothers, more than 1,900,000 mothers who were screened, particularly for malnutrition and problems. And we discovered that more than 100,000, which is a huge number of women who were lactating and were pregnant and they were anemic and they had a lot of problems. So we went on and to provide supplements to more than 11 lakh of women, just to ensure that they have a healthy pregnancy. Because we do believe that when we talk about stunting of growth, it does not start once a baby is born, it starts when the baby is in utero. हमारे तो हिसाब से 18वें हफ्ते पे 18 weeks of intrauterine life, if the mother is malnourished and can't provide proper nutrition to the child, the baby is going to be born already suffering from stunting and growth, which of course is going to carry on for their life. We have established new centers. We basically, there were already 362 centers which are functioning, and we are trying to, these are therapeutic programs that we are providing like for example, we've opened quite a few centers in all the hospitals, where a child who comes with malnourishment and suffering from complications can be admitted and looked after. A child who is not suffering from complications is given supplementary feed and we look after them, particularly the very brassic children who forget how to eat even and are anorexic. उनके लिए एक special feed है which is given to those children for about 40 days, and that is being provided through the DFID program, which actually helps the children to start feeding again and improve their health. So these are the centers, stabilization centers, and we are planning that by the year 2023, we are more than, by the time we are towards the end of our tenure, we should have more than 1,500 centers developed all over. And where the stabilization centers are concerned, we'll have more than 58 centers which are all associated with the pediatrics department for a simple reason, so that the pediatricians can look after these children also. Where immunization was concerned, let me tell you very proudly that among the Southeast Asian countries, Pakistan was the first country to initiate a massive measles campaign. Because we do understand that if a child is already malnourished और उसको measles हो जाए तो फिर उसके मरने के चांसेस बहुत बढ़ जाते हैं. तो हम लोगों ने पूरी कोशिश की कि इस मरतबा एक बहुत बड़ा मतलब इसमें 2 करोड़ से ज़्यादा बच्चों को measles की वैक्सीन दी गई और कोशिश किया गया कि हम कोई बच्चा छोड़े ना ताकि प्रॉब्लम ना हो बच्चों को. और इसी तरीके से पोलियो की वैक्सीन जो है आपको पता है पाकिस्तान में अभी भी पोलियो, we are still known as a polio-ridden country just because we still have children who are being diagnosed with polio. अभी हरिपुर में एक केस डायग्नोज हुआ है. उसकी खातिर हम लोगों को this is the 3rd campaign going on. इस वक्त भी ये कैंपेन चल रही है. So since we came in 3 campaigns have been run और वो भी तकरीबन 2 करोड़ बच्चों को हमने पोलियो की वैक्सीनेशन दी. और जिन इलाकों के अंदर पोलियो की वायरस जो है वो दोबारा डिस्कवर हुई है उस इलाके के अंदर दोबारा we started the campaign to ensure that the children are given maximum protection against this very debilitating disease. Now, health insurance card. When we talk about universal health coverage, the most important thing is how will the people who live under the poverty line, which really form 40% of the population, how are they really going to get all this, what we are talking about? किस तरह की सहूलतें कैसे देंगे वो? तो हेल्थ इंश्योरेंस कार्ड एक ऐसा कार्ड है जो हम इस वक्त इंशाल्लाह लॉन्च कर रहे हैं. और ये मेरा ख्याल है इतना फास्ट फॉरवर्ड रहा है, कितना जल्दी मूव नहीं किया जितना हमने अब मूव किया है. जो 4 साउथ के डिस्ट्रिक्ट्स हैं जिसके अंदर डीजी खान, राजनपुर, मुजफ्फरगढ़ और मुल्तान, जहाँ पावर्टी लाइन के से नीचे रहने के लोगों की तादाद बहुत ज़्यादा है, वहाँ सबसे पहले हम शुरू कर रहे हैं इंशाल्लाह. और ये जो कार्ड है it can go, the family can incur an expense of 3,60,000. जिसके अंदर हमने न्यूरो साइंसेस भी डाली है. God forbid there's a road accident and the child or the person ends up in a hospital where you require to have a CT scan, MRI, everything. All of this can be paid through it. And let me tell you, it doesn't stop at 3,60,000. It goes above 3,60,000 by a certain thing. Okay, we can take it up to, अगर उसका कार्ड खत्म हो गया है जितनी एक्सपेंस थी, तो 3,60,000 और उस पर लगाए जाएंगे ताकि एक गरीब आदमी को ये किसी किस्म का कोई प्रॉब्लम ना हो सर्विसेज लेने को. और ये सर्विसेज सिर्फ आप पब्लिक सेक्टर से नहीं लेंगे. सर्विसेज जो हैं हम प्राइवेट सेक्टर के जो प्राइवेट मेडिकल कॉलेजेस हैं हम कोशिश कर रहे हैं कि उनके साथ हम नेगोशिएट करना शुरू करें, उनको अपने पैनल्स में लेके आएँ. क्योंकि दैट्स वन वे ऑफ हैविंग अ वेरी रोबस्ट पब्लिक प्राइवेट पार्टनरशिप कि अगर एक प्राइवेट मेडिकल कॉलेज फैसिलिटी देता है और हमें एक कंपेटिटिव रेट पे फैसिलिटी दे देता है, फॉर एग्जांपल 12,000 के अंदर वो एक सिजेरियन कर देते हैं, 9,000 में उस एपेंडिसेक्टमी कर देते हैं, मतलब वी आर जस्ट कोटिंग अ फ्यू एग्जांपल्स, 5,000 में डिलीवरी कर देते हैं, तो हम इंश्योरेंस के थ्रू हम कहेंगे भी आप इंश्योरेंस कार्ड देख लीजिए, इस पर आप पेमेंट कीजिए. उनको मरीजों की ज़रूरत है, हम उनको मरीज दे देंगे, पैसे जो हैं वो इंश्योरेंस कंपनी दे देगी, and the patient will get best services whatever it is required. So that is one way of trying to do it. ये inshallah by end of our fiscal year, we are hopeful that inshallah half the districts will get it, and by the beginning of the next fiscal year, so which means by end 2019 we would have covered all the 36 districts. That is nearly 40% of the population will be given cards to more than 10 million people, 10 million families, which means कि roughly हम अगर 1 करोड़ फैमिली को हम कवर कर लेंगे तो इसका मतलब तकरीबन 11 करोड़ की आबादी में से 4 करोड़ लोग जो हैं वो कवर हो जाएंगे. इसका इम्पॉर्टेंट ये चीज़ है कि जी इमरजेंसीज के हालात बहुत ख़राब थे. आपको पता है हम तो जब आए हैं तो आधे साल पहले इमरजेंसीज के चक्कर लगाने शुरू कर दिए. क्लिनिक बहुत थे, लोग कहते थे गंदगी है वगैरह वगैरह, इक्विपमेंट नहीं है. तो हम लोगों ने ख़ास तौर पे अपने सारे टीचिंग हॉस्पिटल्स, बिकॉज आई थिंक मेन शोरूम इज योर emergency, and I'm very grateful to Dr. Sarva sitting here who was very kind to come and do a analysis and an assessment of our जहाँ अपना एडमिट थी इमरजेंसी का. जैसे आप फरमा रहे थे कि इट इज़ वेरी इंपॉर्टेंट कि आप पहले अपनी सेल्फ असेसमेंट तो करिए, नीड असेसमेंट तो करिए. उन्होंने एक बहुत अच्छी नीड असेसमेंट करके और गोंदल साहब को दी है. ना वेरी हैप्पी कि सबसे पहला जो emergency में a professor has been appointed to look after the emergency, which is a very good trend, and I think now all the emergencies are assigning it under a professorial unit, and I'm sure very soon they're going to be putting in courses regarding accident emergency, because that is what has to be done. We need specialization in that, and we need a very robust emergency system. Because a person coming into emergency, and we are ensuring free treatment, we are ensuring that not only they should be given free medicine and they don't have to go through a mess, and we're trying to even curtail the problem if anybody comes with a medical legal problem. जहाँ तक प्राइमरी और सेकेंडरी हेल्थ केयर यूनिट्स हैं, हम कोई तकरीबन 10 जो है हमको अपग्रेड कर रहे हैं to an extent where we want them to look what an ideal situation should be like, and inshallah by the end of our tenure, I assure you, I have 4,000 small and big units working under the healthcare department, and hopefully, inshallah, we would ensure that all these units start working together, and they have no problem at the human resources concerned. And we have given a huge budget for medicines, which is about 12 million rupees, which has already been given in the primary secondary healthcare, and an equivalent amount has been given in the specialized healthcare. So nearly out of 300 billion that I got, 260 billion that I got, a very large chunk has been given for medicines so that people get some quality medicines when they come to the emergency. We have a central monitoring system to ensure timely procurement. We are trying to become as IT savvy as possible, and I'll tell you what we're trying to do. So we are at the moment working on it to see that dispensation of medicines is controlled, and it is properly controlled, it's quality control. We have put in uniform diagnostic rates in all the, because some of the, you do understand that people have to come and pay for their x-rays, like they pay 100 rupees for their x-ray, or 50 rupees for an x-ray, or they come and pay, if they are outdoor patients, they come and pay some money for the blood test or whatever. तो हमने ये सोचा था कि अगर आप सारी इंस्टीट्यूशन में कोई 100 रुपये ले रहे हैं, कोई 500 रुपये ले रहे हैं, कोई 700 रुपये ले रहे हैं, तो सारा बैठ के इकट्ठे मिल के what we have done is हमने 300 टेस्टों का यूनिफॉर्म रेट दे दिया है for the outdoor patients. और इसका फायदा ये है कि जब कार्ड होगा किसी के पास, वो ये टेस्ट जो है वो उस कार्ड पे आके करवा सकता है, ताकि गवर्नमेंट अपना रेवेन्यू खुद भी जनरेट कर सके. हेल्थ केयर व्हेन आई केम इन, सबसे बड़ा तो प्रॉब्लम ये था कि 50% ये जो थी हमारे हॉस्पिटल्स में डॉक्टर्स ही नहीं थे, नर्सेज नहीं थे. आधे साल हम लोगों ने पब्लिक सर्विस कमीशन के थ्रू तकरीबन 9,296 लोग जो हैं उनको इंडक्ट किया और पोस्ट किया. दिसंबर के एंड तक हमारे सारे मेडिकल ऑफिसर्स जो हैं दे विल बी पोस्टेड इन द प्राइमरी एंड सेकेंडरी हेल्थ केयर यूनिट्स, एंड along with that we have also posted nurses, which are 2,834. We have advertised for pharmacists. At the moment they are going through an interview, and we are planning to recruit more than 13,000 people through the NTA system, basically where the paramedics are concerned, so that we strengthen human resource के मसले में हमें कोई प्रॉब्लम ना हो. और then we expect that इंशाल्लाह जब हम human resource मुकम्मल कर देंगे, फिर लोगों के गिले शिकवे खत्म हो गए कि मैं एक डॉक्टर हूँ, मैंने 100 मरीज कैसे देखूंगा. उनका शिकायत बिल्कुल ठीक है. I totally agree when the doctors say that they are overburdened. I agree with them. अगर आप 50% अपना कैपेसिटी रखें स्टाफ की और उसे एक्सपेक्ट करें कि वो 100% काम करे, तो ये तो फिर कोई मौजाना काम हो सकता है और तो कुछ नहीं हो सकता. आपको 100% अपना स्टाफ मुकम्मल करना पड़ेगा, उसके बाद उसे 100% काम ले सकते हैं. Complaint management system. We have a very, very robust complaint management system. You can go ahead and try it. It's and I'm sure it is being tried about it all the time. Dr. Asad is sitting here who looks after the emergency. It's a system where a person who enters an emergency or enters in the outdoor or comes to the indoor is complaining about something. We tell them to register the complaint. And this is a toll-free number where they register the complaint. Within half an hour, if the complaint has not been resolved, the operator calls them again to find out कि आपका मसला हल हुआ या नहीं हल हुआ, because वो पहले फोकल पर्सन को करता है. अगर फोकल पर्सन ने रिस्पॉन्ड नहीं किया तो फिर अगली कॉल जो वो MS हो जाती है. अगर MS भी रिस्पॉन्ड नहीं करता तो उससे अगली कॉल वाइस चांसलर हो जाती है. When we have to talk about, so right to the top we are keeping people informed. Of course, I get a lot of flack on the social media from the doctors who think what I'm trying to do is wrong, but this is absolutely right. A patient coming into your hospital requires to be looked after if you are available there. You have no business to be sitting and working on your mobiles or talking to each other and having a gupshup. इस मुल्क से बाहर जाए यहाँ से बाहर, और एक दफ़ा इंग्लैंड में ये काम करके दिखाएं जो आप यहाँ करते हैं, तो आपको पता चलेगा क्या होगा आपके साथ। 2 मिनट में वो आपको फायदा कहेंगे जाओ घर जाओ, मेहरबानी, बल्कि पाकिस्तान वापस चले जाओ। ये तो क्योंकि आपका अपना मुल्क है ना, इसलिए you people take full advantage of it. ना बाहर, my daughter is at the moment working in England. When I call her during the day hours, और मुझे भूल जाता है कि वो ड्यूटी पे है, तो she doesn't pick up a phone. वो फ़ोन कभी भी नहीं अपना उठाती, और कभी मैं उससे कहूँ कि मैंने 2-3 दफ़ा तुम्हें फ़ोन किया था, फ़ोन नहीं उठाया, उसने कहा no, मैं I was in the clinic, how can I pick up my phone? मतलब अगर वहाँ के लोग ये काम कर सकते हैं, और यहाँ मेरे पास तस्वीरें आती हैं जहाँ सारे डॉक्टर्स जो हैं वो बैठे अपने मोबाइल पे कर रहे हैं, टांग पे टांग धर के, और नर्सेज जो हैं वो बाकायदा कोट मार के बैठी, वो भी लगी हुई है मोबाइल पे, और फिर उसके बाद nobody wants to talk to the poor patient who comes in. So now we have ensured the system कि हमें शिकायत करें आप, and we will ensure that you will be looked after. And Alhamdulillah, what is the good part is that there is a lot of personal effort in which I intervene all the time. We have now got 99% resolution. It is very good. Patients are quite happy now. We have done already a health road show, which is, we have Punjab Health Foundation, जिसका काम था कि वो कर्जे देता डॉक्टर्स को जो पब्लिक सेक्टर में नहीं काम करते, ताकि वो अपनी क्लिनिक्स डेवलप करें। आपने टेली मेडिसिन की बात की कि टेली मेडिसिन का वो डेवलप करें किसी के साथ कोलैबोरेट करके, या वो न्यूट्रिशनल क्लिनिक डेवलप करें, या वो कुछ और नहीं तो हेल्थ एंड डाइट क्लिनिक करें। तो हुकूमत 7 लाख रुपया बगैर सूद के देने को तैयार है, सिर्फ उनकी डिग्री पे। और अगर 4 डॉक्टर मिलकर कर ले तो इसका मतलब है कि आप देख लीजिए कितने बन जाते हैं। 28 लाख रुपया उनको हुकूमत देती है सिर्फ उनकी डिग्री के ऊपर। यानी अगर आप 25 लाख रुपए लेना चाहते हैं तो कोई कोलैटरल दे दे तो आपको 25 लाख बगैर सूद के मिलने को तैयार। 40 नए हमने मॉडल तैयार किए हैं सिर्फ इस मकसद के लिए कि हर बंदा जो है वो पब्लिक सेक्टर में एब्जॉर्ब नहीं हो सकता, तो जो लोग प्राइवेट में काम करना चाहते हैं उनको ये सहूलतें देते हैं हम। And we are hoping that by the end of, because if you, let's say we have a diet and nutrition clinic, you have 4 dietitians sitting there, you will have 4 assistants sitting there, you will have 2 people who are working, one is working as BN. So we are ensuring that through this private sector we might be able to generate more than 100,000 jobs, because we have more than 1.5 billion rupees to give as loans. And I'm very happy after this road show we have had a very good response, and we are now working on about 100 loans that people have asked for. Previously it was something we lying very quietly. लोगों ने मुझसे पूछा कि ये 1.5 अरब रुपया पिछली हुकूमत से कैसे बच गए, मेरे को पता ही नहीं चला था इस वजह से बच गए। Next, now what are we planning to do next? Health insurance I've already talked to you about in detail. In all 36 districts of Punjab, that is what our vision is going to be. We are putting up 5 state-of-art dedicated 200-bedded hospitals in the periphery, not in Lahore, because Punjab exists beyond Lahore also. We are putting them in rural areas, which is Mianwali, Attak, and we are going on to Muzaffargarh, Bhavalnagar, Layya, and then Rajalpur. And we are going to put up a proper mother and child. The new concept is the mother and child has to come together. And important is that now there are a lot of statistics available. As you mentioned, how important it is to know what statistics are. Statistics are now available that institution-based deliveries definitely reduce maternal mortality and definitely reduce infant mortality. So to encourage that, what we are doing is we are ensuring that we will put up 5 such hospitals in various rural areas, and along with that we're putting up nursing colleges with all these 5 hospitals. Because at the end of the day, you need to produce nurses, and you need to produce paramedical staff and technologists. So we're going to put up technology and nursing colleges next to these hospitals so that we can train more and more people and have it. This is my baby, what I'm telling you about. A center of excellence, a mother and child center of excellence, a 400-bedded hospital, inshallah, with all subspecialties in obs and gynae, which is urogynecology, fetal medicine, in vitro fertilization, and gynecological oncology. we are going to make it in Gangaram Hospital, and we are doing already as on self-help basis on the 22nd. हमने सारों को रिक्वेस्ट किया कि जो गंगाराम में पैदा हुआ वो मेहरबानी करके अपने हिस्से के पैसे डाल दें, बजाय ये कि आप आकर पैदा हुए थे, और जो वहाँ से पास हुआ है उसका भी फर्ज बनता है कि वो पैसे कंट्रीब्यूट करें, क्योंकि एक अच्छा काम करने लगे। आप भी सारे इस कार्य के काम में इंशाल्लाह शामिल हो। बट दिस इज व्हाट वी हैव डन बिकॉज वी वांट दैट देयर शुड बी अ प्रॉपर referral place if God forbid there is a complication which cannot be handled by other institutions. School and health nutrition program. That's the tragedy. People have never thought about how important these children are. And previous government, आज से 10 साल पहले उन्होंने 1750 बंदों को एम्प्लॉय किया हेल्थ और न्यूट्रिशन प्रोग्राम के थ्रू और ट्रेनिंग की, लेकिन अफसोस से कहना पड़ता है वो बेचारा एक बंदा स्कूल किसी ने नहीं किया। तो when I discovered this huge booty, I should call it, कि जी 1750 बंदे ऐसे कुछ नहीं कर रहे, या अगर बेचारों को कभी पोलियो के उसके लिए भेज देंगे फलां के लिए, बिल्कुल पता नहीं था ना कि इनसे क्या काम करवाना है। So I got hold of them and we are starting a school and health. We have already initiated it. We have initiated it as a pilot in 20 schools, all public sector schools, and inshallah within this the next few months we are going to go into 27,000 public schools in rural areas of Punjab in the next 7 months. And I am very grateful to Dr. Asad, who is sitting here, who is very kind, because he does a lot of preventive work, and he is going to see to it that all the children studying in public schools get their eyes tested and find out if there is any problem. So I think it is a good help. And we do another end-to-end education, which means everything which is recorded, everything is going to be recorded. We are going to be collecting data, so that next time we make our policy, it's going to be based on evidence. And in case the child has any sort of complication, the child will be referred to the nearest health facility and free medical treatment will be given, and health sessions in the school will be carried out by this one. So we've initially started it here, and I've already shown you about 3 nursing colleges we will do this year, and next time we are going to put in another, the next fiscal year, we're going to put in another 2 more colleges. Now what is extremely important is there's no registration as such. हम बहुत सारी बातें कर लेते हैं, हम कहते हैं maternal mortality ratio इतना, तो इसी से पूछते हैं कि भाई कैसे पता चला तुम्हें? मुझे हिसाब लगाया है, हिसाब कैसे लगाया? अभी पहले इतना था अब इतना हो गया। तो वो इसी तरह का काम है जिस तरह हम बजट बनाते थे कि पिछले साल अपने बजट में 2 करोड़ रुपए मांगे, ऐसा वाली टाइम मांग रहा हूँ, भाई क्यों टाइम मांग रहे हो? भाई बात तो क्या हो गया ना, ये दैट सॉर्ट ऑफ थिंग। Maternal mortality कम तो हो गई होगी ना, so we have no proper ratios, we don't have proper data, we are missing all on our. So what we are working on is we are going to register all the maternal deaths, we are going to register all the infant deaths. That is what we are going to do, and we are going to have a uniform death seal. Now what is extremely important is that we need a death seal, and the training program is going to be on Monday, and we are going to train master trainers who are going to go and teach people how to fill up these slips, because that is the way that we will be able to collect all vital statistics. A national health policy is being devised. Dr. Amir is here, he is part of our task force. We had a very comprehensive consultative workshop for 2 days, and I'm very grateful to the population planning minister, who I made it a point that he sat with us for 2 days. And I was there for 2 days, and we had all the vice chancellors sitting there for 2 days, and we worked on, these were 10 pertinent points which we brought up again and again, and I think these are very important points. One of the most important ones, patient safety and quality control. That was extremely important. We do realize that we can harm a patient more at times than really treating the patient. So we are working on these 10 points. We already have our first draft ready, and inshallah it will be a part of our strategic framework, which will be a part of the health policy. We're putting in legislations. First and most important legislation is that all the universities are going to be, along with their hospitals, will be declared independent. They're going to have financial and administrative independence. We give them a one-line budget, and we'll tell them what we expect from them, as he was talking, and then we'll look at them and ask them, आपने क्या किया? अगर आपने काम ठीक नहीं किया तो पैसे निकाल लेंगे वापस, अगर काम ठीक करेंगे तो पैसे बढ़ा देंगे. But they have a chance to generate their own revenue also, which is extremely important because we want institution-based practices, which were previously being done in all these medical colleges. ये तो आज कोई नई बात नहीं है. This is not reinventing the wheel, लेकिन एक बड़ा successful کام تھا کہ جی AVH کے اندر مریض آتے تھے, داخل ہوتے تھے, پرائیویٹ مریضوں کو دیکھا جاتا تھا. اب ہم انشاءاللہ آؤٹ ڈورس کو ریویمپ کر کے and we are going to work with. Then we are making a Punjab Regional and District Health Authorities Act. Punjab is going to be divided into 9 regions, which are 9 divisions, and these will be regional health authorities, where each regional health authority will be looking after 4 districts. We're going to break up the system, devolve it, so there are smaller number of institutions which are being looked after. I mean, it is impossible for me, maybe in these next 5 years, I might not be able to see all the 4,000 institutions which work under me. However, when I break it up, then I have a board of governor who I can question, I have an authority which I can question, and I give them my indicators. This is what I want from you. They have then work according to our indicators. Bill for thalassemia prevention program, we are bringing about the thalassemia prevention because it's a huge problem for us. Every year, 5,000 to 6,000 new children are being born with thalassemia, and we want to bring about an act which is going to ensure all the males who are getting married will be screened first to remove the stigma from a woman, and if the male turns out to be a carrier, then whoever he is engaged or she to will be tested for thalassemia, otherwise we will not test them. So if the male comes out negative, no problem. If the male comes out positive, we test the woman, and in case they both are positive, then we have got to counsel them to tell them that the facility of prenatal diagnosis is available in Pakistan, and they must take that facility for a simple reason that you don't want the birth of any more thalassemia patient children. We have had a huge problem regarding security of healthcare personnel. کچھ ہمارے بھی غصے تیز ہو گئے ہیں, کچھ ہمارے بھی مزاج جو ہیں اس میں لاوالی آ گئی ہے. ہم بھی طبیعت جو ہے ہماری, ہم سمجھتے ہیں کہ جب میں ڈاکٹر ہوں تو میں سب کچھ ہوں. کچھ مریضوں کے حالات بھی کیسے, تو ایک مریض کے ساتھ 4 رشتہ دار بھی آتے ہیں اور ایک مسلسل مسئلہ ہمارے لیے کھڑا ہوتا ہے. آج ادھر مار پیٹ ہوئی ہے, آج فلاں جگہ مار پیٹ ہو گئی, آج ادھر. مقصد یہ ہوتا ہے, میں nobody wants to talk to a patient. میں کئی دفعہ حیران ہوتی ہوں, مجھے تو فرینکلی اسپیکنگ 4 دوائیوں کے نام آتے ہیں, وہ 5-6 ہوں گے, 10 دوائیوں کے نام آتے ہیں. میرے پاس تو جو اب بھی مریض آتے ہیں وہ صرف اس بات پہ آتے ہیں کہ میں ایک تو کی ہسٹری خود لیتی ہوں. میں کہتی ہوں ہاں بتائیے آپ, تاکہ میں وہ 5-6 منٹ مجھ سے گفتگو کر لوں. پھر گفتگو کرنے کے بعد میں 4 سوال میں بھی پوچھ لیتی ہوں ان سے, پھر اس کے بعد میں ان کو تسلی دیتی ہوں. عموماً میری کلینک پہ روتے ہوئے مریض آتے ہیں, تو کیا ہو گیا ڈاکٹر صاحب فلان ڈاکٹر کو کیسے اور کسی جڑے آنے ڈسالو. میں کو کس طرح پتہ چلو مجھے دیکھا سی. میں کہ کس طرح, وہ ٹیسٹ کرایا سی, نہیں جی دیکھا سی. میں کہ جب پتر وہ گالا کی ہے کہ جڑا والی رسولی کا ٹیسٹ طرح نہیں پتہ لگا. تو بالکل ٹینشن نہ کھا, اسی ٹیسٹ اگر کو خدا نہ خاصا ضرورت پڑے تو کر کے دیکھ لیں گے, آپ ٹینشن نہ کھائیں. بجائے مریض کو تسلی دینے کے ڈاکٹر ان کو ڈراتے ہیں, ڈرا کے پھر وہ کہتے ہیں اسٹیکٹمی کرا دو, بند کرا دو, فلاں کر دو. مطلب دیز تھنگس, مطلب ایتھیکلی ہم کہاں پہنچ گئے. میں ابھی بھی ایک وہاں گئی تھی, ایک لیکچر دے رہی تھی میں وہاں. میں سوچتا ہوں آج میں ڈاکٹر کو اسی بات پہ لیکچر دے رہی ہوتی. میں frankly speaking, I think I'm one of those doctors who doesn't own anything, which I'm very happy. I have no property. بڑی خوشی کی بات ہے, 100 کنال میرے پاس بارانی علاقے میں نے ایک جگہ خریدی تھی 6 لاکھ کی. وہ میرا جو الیکشن کے دوران جج نے میرا مذاق اڑایا کہ ڈاکٹر صاحب سستی مل رہی تھی. میں 6 لاکھ کی ملی تھی, تو بارانی علاقہ تھا, وہاں کوئی نہیں جاتا تھا. I don't own anything. نہ میں نے کبھی کوئی ہسپتال بنایا, نہ میں اپنی پرائیویٹ پریکٹس کے پیچھے کبھی بھاگی. لیکن ایک بات میں بچوں کو بتا رہی تھی, میں نے کہا مسئلہ یہ ہوا ہے کہ میرے ہاتھ میں تنگی کبھی نہیں آئی. میں آج تک کبھی پیسے کی طرف سے تنگ نہیں, اس لیے نہیں ہوئی. I always thought کہ اگر اس اوپر والے نے وعدہ کیا ہوا ہے تو اس نے میری ضرورت پوری کرنی ہے. اگر میں اس کی مخلوق کی خدمت کروں تو پھر میں یا تو اتنا اعتماد اس پہ کروں, یا تو اتنا اعتماد کروں کہ میں چھوڑ دوں اس کے اوپر کہ ہی ول لک آفٹر مائی نیڈس, یا پھر اس طرح اللہ مسلمان ہوا کہ وہ پہاڑ تو ڈگ گئے, درمیان درخت اڑ گئے, تو ان کا یا اللہ میں بچانا تھا. اللہ تعالیٰ نے آواز دیتی کہ چھوڑ دو اس درخت کو. انہوں نے کہا یار کوئی اور ہے, مطلب اگر تو یہ رویہ رہے گا تو پھر تو کچھ نہیں ہونے لگا. یا تو چھوڑو پھر اس اللہ کے اوپر, اور پھر دیکھو وہ کیا کرتا ہے. You will be astonished. I am 68 years old. I was retiring at the age of 60. One of my very close colleagues who will been with me for 24 years was extremely concerned کہ آپ نے کوئی انویسٹمنٹ نہیں کی, آپ نے کوئی کسی قسم کے پیسے پہ وہ دھیان نہیں کیا, کل آپ ریٹائر ہو جائیں گی, پھر آپ بوڑھی ہو جائیں گی, آپ سے کام نہیں کیا جائے گا, پھر آپ کیسے اپنا خرچہ پوری کریں گے. دماغ میرا کھا لیا, میں تھوڑی دیر بعد جب 15-20 منٹ دماغ کھا لیا, میں کبھی تک گھر سن گئی. وہ کوئی اللہ میاں میرے نام ریٹائر ہو گیا, جب اللہ ریٹائر ہو رہا ہے تو پھر تو بڑی ٹینشن آ گئی تھی. وہ جس نے میرے اب تک بندوبست کرتا رہا, یا تو وہ آپ فیتھ رکھے نا. میں وہاں سکردو جاتی تھی, آئی بین گوئنگ ٹل اباؤٹ 3 years ago. یہ الیکشنوں نے مجھے پاگل کر دیا, ورنہ تو میں ہر سال سکردو جاتی تھی, آپریشن کرتی ہوں وہاں جا کے. آئی ہیو ڈن مور دین 800 میجر آپریٹنگ پروسیجرز. مجھے میرے ساتھ کلینک میں وہ جو بچی کام کرتی ہے, مائی سسٹر, اس بیچاری کو ہمیشہ مسئلہ تھا. میڈم آپ کو خیال ہی نہیں ہوتا اپنی پریکٹس کا 10 دن کے لیے چھوڑ کے آپ چلی جاتی ہیں, فلاں کرتی ہیں, کام کرتی ہیں. میں نے کہا بات سنا, حساب تم رکھتی ہوں, کبھی کوئی حساب میں گڑبڑ ہوئی ہے؟ بلکہ جس مہینے میں جا کے وہاں کام کر کے آتے ہیں اس مہینے دورے پیسے آتے ہیں. مقصد یہ ہے کہ لیٹس ہیو فیتھ on the one who has promised us. ہم تو شاید یہ حکومتیں بھی وہ وعدہ نہیں کر سکتی جو اللہ تعالیٰ نے وعدہ کر رکھا ہے, اور آپ لوگوں کو وعدہ کیا ہے. ڈاکٹر سٹنگ ہے, اس نے کہا ہے کہ تم مسیحا ہو, یعنی لوگ ہمیں مسیحا پیغمبری پیشہ ہو کے ہمارا, لوگ ہمیں کہتے ہیں کہ اوپر اللہ نیچے آپ. درمیان میں پیغمبروں کا نام نہیں لیتے, وہ نہیں کہتے کہ درمیان میں 1,24,00,000 پیغمبر کیا ہے تو پھر تسی یہ ہو. وہ کہتے ہیں کہ ہوتے اللہ تھلے تسی. میں نے تو یہ سب کچھ آپ پہ چھوڑا, اللہ تمہیں نظر آتا ہے, آپ نظر آتے ہیں. لیٹس ورک دیٹ وے اینڈ آئی ایشور یو. میں آپ کو لکھ کے دے دیتی ہوں, میں گارنٹی دیتی ہوں. I will give you written in golden words. You serve His humanity. دیکھیں آپ کے حالات کیسے اچھے ہوتے ہیں. مجھے تو آج تک کبھی کوئی پرابلم ہوا, بال بچہ بھی پڑھ گیا, اچھے خاصے نلائق بچے تھے میرے. میں کہتی تھی یہ کیا کریں گے, تو میں جاتی ساؤتھ کریسنٹ ماڈل تو استانیہ میں سوائے ایک کے بچے کے درمیان والے دو جو تھے کہتے تھے یہ پڑھتے نہیں ہیں, آپ کو پڑھاتی کیوں نہیں ہے. میں نے کہا کہ آپ آ کے آپ پڑھا لیں, میں ان کو پڑھا دیا اس نے کرے گا. Pilot and Emirates is doing very well, earning a lot more money than doctors, you know. And then the other one is working in Pakistan State Oil. I believe it is not because وہ بہت قابل تھے. I believe this all happened because my God was happy with me. میرا اللہ مجھ سے خوش تھا, اس نے میری اولاد کو قابل کر دیا. یہ آپ کو صلہ جو ہے ہر طریقے سے ملے گا, ہر طریقے سے. ابھی میں کھڑی ہوتی ہوں, آپ دیکھیں نا الیکشن کے اندر میں کھڑی ہو کے تو تقریر دے رہی ہوتی ہوں, اور میں کہتی ہوں فلاں چور ہے, ٹکان چور ہے, بھی بڑا بھائی مان ہے. وہ بیچارے نواز شریف کی میں نے مت مار کے کہتے لٹ کے کھا گیا وغیرہ. آپ کا خیال ہے اگر اس پارٹی کو میرے خلاف کوئی بات ملی ہوتی تو وہ چھوڑتے مجھے کچا چبا کے کھا گیا. میں نے ایک کام کیا, میں نے کہا کوئی غلط کام نہ کرو تاکہ آئندہ کھڑے ہو کے چور کو پتا چور تو کہہ سکے. And that's what you want. I kept it for you at the end. We are developing an integrated health management system. We are putting everything online, inshallah. If a person gets registered in a hospital in Sadkabad and ends up somewhere in Lahore, you just have to go onto the system and get what his history out. You will be able to get what his history was concerned. So we are, inshallah, working on it, and inshallah, hopefully we'll be doing it very successfully, and by the end of this fiscal year, it would be to quite an extent 80% complete, and whatever is left out of it, we'll inshallah complete it. Primary healthcare reforms ke andar, we are bringing in basic health units, which is the main thing after filter clinic. We are ensuring 24/7 coverage, which means a doctor would be available in the morning, but during the evening and night, we would have a lady health visitor who can do the birthing part, and we would have all sorts of facilities available there, and we have a very strong reference system through ambulances. If a person ends up in a complication, she can be easily taken over there. And inshallah, by the end of 5 years, we will have manned all the 2,500 PHUs that we are, and we're working on now on the upgradation of rural health centers. We are setting up 6 districts primarily, which is known as the Prime Minister's Initiative, where he has asked us to specially do an operational research to see that if right from a basic health unit to a rural health center to a tehsil headquarters to a DHQ and tertiary referral center, we develop a proper referral system, man all the hospitals, provide them with all equipment and medicines. Do we make a difference? Do we make a difference? So rather than going all over, we are initially doing it in 6 districts. It will be a pilot. It's going to be an operation research. And through this operation research, we are going to know our teething problems. We'll come to know what are the other issues that we need to address. And inshallah, if that is successful, we will then replicate it all over Pakistan. Punjab. Thank you very much.
Wow, that was inspiring. Don't you agree? So, कहते हैं कि करेंगे अहले नज़र ताज़ा बस्तियां आबाद. So, for the first time, I feel the energy and the dynamism and the vibrancy. So, I feel hopeful. I think she may be 68, but anybody who's seen her campaigning on the streets of Lahore will probably know that she is still young at heart, young in mind, and razor sharp mind. So thank you very much, Professor Yasmin Rashid. She has to go to an urgent meeting, and she has spent a lot of time with us, preparing for this, delivering this, and inspiring us. So let's give her a big round of applause. So just as a token of our gratitude, if you come to the stage, we can offer you just as a token of our worship. Also by the chief guest, this is Shakula Johnson. So our meeting continues. We have another speaker who was going to travel specially from Islamabad. Unfortunately, she had to go urgent surgery, but she is now a standing professional called Dr. Sania Nishtar. She has recorded this presentation especially for us on video, so we'll play it for you now.
Symposium, both for convening this event as for giving it such a befitting theme. Universal health coverage has become the central pillar in the global health discourse. It is the unifying thread that moves through the sustainable development agenda. It has become the #1 policy choice for governments all around the world, and for very good reason. Because universal health coverage can create avenues to fix broken health systems, it can help to save lives, it can avert death and disability, it can be a vehicle for achieving programmatic goals, and most importantly, if it is delivered effectively, it could become the 21st century welfare contract between the state and the citizens, a state's promise to its people. But what does it mean in public policy terms for a country like Pakistan, a country of 200 million people with a large mixed health system and with the highest and worst newborn mortality rate in the world? Well, first, to put things in context, we have to bring to bear that Pakistan has many health systems and not one. The revenue-funded armed forces health system, the self-sustained Fauji Foundation, Systems Health Establishment, the Employees Social Security Institute, financed through compulsory social security contributions, the health services delivered by Pakistan's autonomous Pakistani organizations, the state's entitlement to social and insurance systems, in other words, the card-based systems, all of these together, according to my earlier estimates, cover more than 21% of the country's population, of course in financial access terms. This is more than 50 million people, 5 times the population of Sweden, which is considered the bastion of welfare services. So my first message to you is that we must disaggregate data when we talk about universal health coverage in financial access terms in Pakistan's context, because there is some good news too. And it is to be expected that health outcomes for those covered through these systems would be much better, but we have actually never disaggregated data health systems-wise in Pakistan to be able to document that. But as opposed to this missed good news, there's a lot of bad news as well. Outside of these vertical systems which I referred to a moment ago, there is a large mixed health system with private health providers predominating, where out-of-pocket expenditures are the major means of health financing. As you know, ladies and gentlemen, universal health coverage is about 3 things. It's about geographic access, it's about financial access, and it is about quality. And we have a long way to go in all 3 areas. In geographic access terms, our services are concentrated in urban areas. For a very long time, we've been striving to improve access in rural areas. Of course, there has been some progress over the last 15 years, but a huge gap remains to be filled. In financial access terms, more than 79% of the population of the country is not fully covered. That is a huge number. These individuals run the risk of spending catastrophically on healthcare, and they run the risk of being pushed into poverty. And in terms of quality, we know that barring exceptions, there has been little attention to service quality regulation in the last 70 years. We know that pollution is well institutionalized in medical education regulation, human resource regulation, and drug regulatory regimes. All these are critical gaps, because without quality, universal health coverage is an empty vessel, which is what we also outlined in the United States National Academy of Sciences and Medicine report on the quality of healthcare, which was released earlier this year, and which I had the honor and privilege of co-chairing. So what are our options in terms of the way forward? And here I would like to make 3 big points. My first point is about the importance of changes in overall governance and the fight against corruption. These are critical for making quantum strides in the health sector. Health reform is not a sectoral phenomenon. It is interlinked with macroeconomic management, which is needed to create fiscal space for universal health coverage. Effectiveness of governance can deeply impact the performance of the health system. I strongly believe in rule-based control on government functioning, respect for merit, integrity, ethical conduct, accountability, and transparency. I believe oversight of discretionary powers and safeguards against conflict of interest are the basic foundations to enable that. It is critical to appreciate that government openness, strong audit institutions, laws relevant to white-collar crime, citizens' empowerment, and right to information are some of the most important investments to improve health systems. And we must understand why there is a lack of incentive or even a disincentive in the public system to embrace these attributes. To change behaviors, we must change the design of institutions and the incentive structures that drive them. I strongly believe that improvement in overall governance can have a massive impact on the performance of hospitals. It can turn around Pakistan's 1,200, over 1,200, in fact, private healthcare centers, and we have seen isolated examples of that in a few provinces over the last 10 years. I believe improvements in governance can be a key ingredient to reform regulatory bodies, and not just that, but it will also help engage the private sector, which has to be part of the universal health coverage solution. Without leveraging the outreach of the private sector, we simply cannot achieve universal health coverage in Pakistan. So governments have no option but to go the strategic purchasing route. This has to be conducted as a political choice, as a health reform lever, but it is impossible to turn this around in a collusive context. I can tell you that technical reform approaches to universal health coverage is not what is the issue. It is how they are implemented which is where the constraint is, and that can't be fixed without good governance. I strongly believe, and especially in resource mobilization terms, because after all, universal health coverage costs, we already calls for increased spending. So within that context, I strongly believe that there are also potential synergies to be exploited with the current anti-corruption and anti-tax evasion drives, as this could potentially plug the diversion of resources which can then be made available for universal health coverage and other similar welfare initiatives. That is the first point which I wanted to make strongly. My second point is about the importance of disruptive reform. We cannot wait forever for governance to be fixed. People are dying today, and action has to begin now. And here it is important to draw on lessons from other developing countries who have embraced universal health coverage. If you reflect back in history, in all those settings where universal health coverage was adopted, there has either been a balance between population size and resources, or the power of strong institutions to draw reform, or a contribution of the constitutional entrenchment to the right to health, and strong civil society institutions that have capitalized on judicialization of health rights. These policy levers have been at play. Any of these three policy levers have been at play whenever universal health coverage has been made, anywhere in the world. And we have to appreciate that we have none of these conditions in play, which is why we need to use disruptive reform approaches. Fortunately, technology provides an unprecedented opportunity to do that. These opportunities have been tapped by the private sector and have created islands of progress in the public system. The critical question is with governments, both federal and provincial governments, able to harness them to bring about the quantum change that is desperately needed in the health sector of Pakistan today. So even in Pakistan, when you seek online services today, fast food chains and online taxis such as Careem will deliver on the objective of trackability, efficiency, transparency and accountability. The same technological capabilities which underpin these service delivery mechanisms, if strategically deployed, I strongly believe could support the development of public sector digital ecosystems in health. And that is critical for universal health coverage. There is no reason why we shouldn't be using simple things such as distribution chain security coupled with mass serialization to combat the menace of serious drugs. No reason why we shouldn't be using video surveillance to monitor and counter absenteeism and invasive health units across Pakistan's infrastructure of 12,000 primary healthcare centers. There is no reason why we shouldn't use last-mile solutions such as drones to deliver blood products to Hamilton women in labor in far-flung areas, just like Rwanda has done. No reason why we shouldn't use integrated, interoperable information systems across the public and private sector health systems. We know the potential for increasing digitization, and we know what cell phones and digitization they do to disrupt the global health landscape. And to usher in these innovations, we must partner with entities other than the health sector. Today, health systems are being re-engineered not by ministries of health, but by financial institutions and organizations involved in online retailing. They are disrupting and redesigning healthcare all over the world, and we need to learn how to leverage that potential. I believe we could usher in a transformation even with our constraints. And that is the second point I wanted to make. I strongly believe we could usher in a transformation with the use of digital disruptive technologies that are currently being used by the private sector and in isolated settings in the public system. Ladies and gentlemen, my third point is about future health systems. Today I would like to challenge you to reimagine healthcare in our lifetimes. In 2030, a woman in a rural setting anywhere in Pakistan with diabetes could potentially be able to manage her conditions from a smartphone in a context where artificial intelligence would make up for worker shortages. Her wearable sticker could monitor blood glucose and sweat. The Internet of Medical Things would gather this and other information from a microchip in her pin and upload information to a blockchain-secured electronic health record in the cloud. In 2030, the same woman will be able to take her own retinal image on a smartphone, and artificial intelligence algorithm could analyze it and book an appointment with the doctor automatically if it is abnormal. It could also order a colleague for her automatically to take her there, deduct money from her mobile wallet saved account, and it could send her an SMS. The doctor, on the other hand, before she arrives, would have tested the basic therapy on her digital twin before she checks in to see what works best. The woman would be able to order medicines through Amazon, print bills at a local pharmacy, verify their authenticity through text message, and have an instant delivered to its doorstep by her phone. You're probably smiling by now because you think I'm going into science fiction. This is not science fiction. Even today, each one of these solutions exists in isolation, and efforts are underway all over the world to bring them together at a health systems level. When you view this in the overall context of changes in the market, the potential for a massive quantum shift in the near future is evident. There are other massive transformations in health underway also, which will be commercially available in Pakistan regardless of what governments do or do not do. Healthcare will be transformed very soon in our lifetimes, and we can reimagine health even in a country like Pakistan. We can reimagine for it to deliver on the premise of quality and equity if we make the right public policy investments now. But alongside these, governance and normative imperatives are also emerging in the wake of this paradigm shifts, and we need to invest in developing norms and standards, ethical patient safety, human resource and institutional capacity issues need our urgent attention. The issue of capacity is a critical issue because when the first industrial revolution came, it increased the demand for unskilled workers. But today's fourth industrial revolution is calling for investments in human capital. So profound is this realization that very soon the international financial system will stop begging the borrowing costs of countries like ours with their human capital rankings. So we need to accord attention to umbrella policy areas like universal health coverage, not because they are rights-based, but also because they make good economic sense. So to summarize my 3 points, we must build capacity to tap opportunities that are around the corner. But we must also make use of disruptive technologies that can make a difference today. Alongside efforts to drive a broader anti-corruption drive to free up resources for health and welfare and to make systems more effective and responsive. Ladies and gentlemen, we must appreciate that the needed changes have to be adopted by federal and provincial governments in a context where legislative lists have outlined respective roles for the federal government, federation and provincial governments, and these integral layers have the interprovincial interface, and I'm not even talking about further down. It is imperative that at all levels, governments think beyond the horizons of their 5-year terms, so that universal health coverage can be isolated from policy legislations that are inherent to changing government. We need an all-party consensus on directions for universal health coverage policy reform. We need a sustained effort to build institutional capacity to conceptualize and implement reform and build the evidence base to reinforce elections. This is a commitment which will traverse decades, and stakeholdership is needed to broker this. Universal health coverage in these states promise includes people, and I hope we can get on the way to laying the foundations for a crossing Asia very soon because we have no other choice. I thank you.
Ladies and gentlemen, we've had very informative talks, real eye-openers on many issues today. We will now conclude, and I'm sure by now we must have been able to bring forward very conclusive recommendations for the government for health reforms in Pakistan. I would request our worthy chief guest for today, the Honorable President, Pakistan Medical and Dental Council, Justice Shakarullah Jan Sahab, to please come onto the stage and take your seat here. Our worthy Vice Chancellor, King Edward Medical University, Professor Khalid Mohammed Gondal, is joining on the stage as co-chair of this the ex-chairman, Healthcare Commission. Please join us on the stage. Dr. Tabitha Gogol, she is representing Kemkhana UK President. Aisha Najib, she is the co-chair for APNA this year. Professor Fareed Zafar, President, Pakistan Society of Gynae and Obstetrics. Professor Asad Aslam. Dr. Junaid Sarfaraz. He is Professor of Medical Education at CMH Lahore. Dr. Imdad Ali from Pakistan Medical Dental Council. Before we request our worthy chief guest for his concluding remarks, are there any questions from the audience, from our worthy speakers and guests here?
एड्रेस किए बगैर डायरेक्टली अपनी बात करता हूँ। हेलो, अब मेरा कुछ क्वेश्चंस तो थे मैडम हेल्थ मिनिस्टर से, लेकिन वो चली गई। अब मेरे कुछ थोड़ी सी फीलिंग और कुछ क्यूरीज भी हैं, वो पीएमडीसी के हवाले से चेयरमैन साहब से। सर, मैंने 79 में इस कॉलेज में दाखिला लिया था। उस वक्त पूरे पंजाब में सिर्फ 7 मेडिकल कॉलेज थे, 7, एंड नो प्राइवेट मेडिकल कॉलेज। आज पंजाब में मेरा ख्याल है 16-17 सरकारी मेडिकल कॉलेज हैं और मोर देन 40 प्राइवेट मेडिकल कॉलेज हैं। सरकारी मेडिकल कॉलेजेस के अंदर जो एक चेंज आई है, हमारे बेसिक साइंसेस के डिपार्टमेंट टीचर से खाली हो गए। एवरीबॉडी वेंट टू प्राइवेट because they offered big salaries. और जो हमारी क्लिनिकल साइड थी, मेडिसिन, सर्जरी, इसके तमाम टीचर पोस्ट ग्रेजुएट एजुकेशन के अंदर इन्वॉल्व हो गए। 79 में अगर गोंदल साहब के सर्जिकल वार्ड में 2 या 3 ट्रेनी होते थे स्पेशलाइजेशन के, तो आज वहां पे 20 या 25 ट्रेनी थे। उसके बाद अगली मसला ये हुआ कि पोस्ट ग्रेजुएट्स के मसाइल ने ऐसा रुख इख्तियार कर लिया कि पिछले 10-15 साल से पूरे पंजाब में एक ही मसला है कि यंग डॉक्टर्स को कैसे डील करना है। सड़कों पे हड़तालें हैं, अस्पताल बंद हैं, मार कुटाइयाँ जारी हैं, एमरजेंसियों में लड़ाई हो रही, फॉर मैनी रीजन। आई डोंट से दे आर रेस्पॉन्सिबल ओनली, देयर आर मैनी अदर फैक्टर्स। तो इस वक्त सिचुएशन ये है कि हमारे सरकारी मेडिकल कॉलेजेस में क्लिनिकल एजुकेशन अंडर ग्रेजुएट के लेवल के ऊपर बहुत निगलेक्ट हो रही है, और जो थोड़ी बहुत हो रही है वो جونیئر ٹیچرز کر رہے ہیں، سینئر ٹیچرز اس کے لیے اویلیبل نہیں ہے. اس کا نتیجہ یہ ہوا ہے کہ ہم ایک کمزور میڈیکل گریجویٹ پیدا کر رہے ہیں، اور یہ کمزور میڈیکل گریجویٹ آگے آ کے ایک کمزور پوسٹ گریجویٹ اسٹوڈنٹ کے طور پہ سامنے آ رہا ہے، اور ایک کمزور اسپیشلسٹ کے طور پہ سامنے آ رہا ہے. اس کے بعد یہیں پہ بات ختم نہیں ہوئی، ایک اور مسئلہ ہوا. پنجاب میں سیاست کچھ ایسا رخ اختیار کر گئی کہ یونیورسٹیوں کی ایک لائن لگ گئی. یونیورسٹیاں بنانے سے پہلے کسی نے کوئی سالڈ ہوم ورک نہیں کیا کہ اس صوبے کی میڈیکل نیڈ کیا ہے. ایک انفلوئنشل بندے کے لیے ایک میڈیکل یونیورسٹی بنا دی گئی. یونیورسٹی کا نہ کوئی وجود تھا، نہ کوئی جگہ تھی، نہ کوئی انفراسٹرکچر، لیکن کسی انفلوئنشل آدمی کو خوش کرنے کے لیے اس کے کالج کو یونیورسٹی ڈکلیئر کر دیا. بلکہ اکثر یہ ہوا کہ جہاں کوئی انفلوئنشل ڈاکٹر ریٹائرمنٹ کے قریب ہوتا تو وہ اپنے ریسورسز استعمال کر کے اپنے کالج کو یونیورسٹی بنوا لیتا تاکہ اس کو 5-6 سال اور بلکہ 10-15 سال اور کام کرنے کا موقع ملے. جی کل بہت انٹریسٹنگ ہو گئی صاحب. But I'm talking to the panel. Let's talk about the realities, not about the theoretical things, not about the medical education. یہ بچے ہیں جن کو ہم نے نیگلیکٹ کیا ہے. تو میں یہ کہنا چاہتا ہوں اس صوبے میں 2 یونیورسٹیاں موجود تھیں، یونیورسٹی آف ہیلتھ سائنسز اور کنگ ایڈورڈ میڈیکل یونیورسٹی. اس کے بعد کسی یونیورسٹی کی ضرورت نہیں تھی. تو ایک دوسرا کی جو نئی یونیورسٹیز بنی ہیں، آپ بھی ایک پی ایم ڈی سی ممبر یہ پتا کریں کہ ان کی جسٹیفیکیشن کیا ہے، یہ ہمیں کیوں چاہیے اور اب تک یہ کیا اچیو کر رہی ہیں. میرے حساب سے پنجاب میں 2 یونیورسٹیاں، یونیورسٹی آف ہیلتھ سائنسز، کنگ ایڈورڈ میڈیکل یونیورسٹی، یہ کافی ہیں. اور میں سمجھتا ہوں کہ یونیورسٹی آف ہیلتھ سائنسز کو پرائیویٹ میڈیکل جو کالجز ہیں ان کی ایجوکیشن کو ریگولرائز کرنے کا اختیار کیا جائے، اور کنگ ایڈورڈ میڈیکل یونیورسٹی کو سرکاری اداروں کی ایجوکیشن کو ریگولیٹ کرنے، سنبھالنے اور ڈیل کرنے کا اختیار دیا. پی ایم ڈی سی پلر ہے جس کے اوپر ساری میڈیکل ایجوکیشن بیسڈ ہے، اور ماضی میں یہ اپنا کام بہت اچھی طرح سے کر رہی تھی. بدقسمتی سے ڈاکٹر آصف حسین صاحب ایک بنے پی ایم ڈی سی کے انچارج پچھلے دور میں، انہوں نے آ کے پی ایم ڈی سی کے بالکل بخیے ادھیڑ کے رکھ دیے. پی ایم ڈی سی انڈر گریجویٹ ایجوکیشن کو دیکھتی تھی اور پوسٹ گریجویٹ ایجوکیشن کو کالج آف فزیشنز اینڈ سرجنز آف پاکستان دیکھتا تھا، اور یہ کام بڑی خوش اسلوبی سے ہو رہا تھا. لیکن ڈاکٹر آصف کے دور میں انہوں نے سی پی ایس پی کو ڈیفیٹ کرنے کے لیے اپنے ایکٹ میں ترمیم کرائی اور پوسٹ گریجویٹ اداروں کو بھی اپنے کنٹرول میں لے لیا. اور انہوں نے یہ رول پاس کیا کہ اب اگر کسی ادارے کو پی ایم ڈی سی نے انسپیکٹ کر کے اس کو کلیئر نہیں کیا کہ یہ پوسٹ گریجویٹ ایجوکیشن کے لیے فٹ ہے تو اس کو پی ایم ڈی سی ڈگری نہیں دے گا. ماضی میں یہ ہو چکا ہے کہ سی پی ایس پی کے فیلوز کو پی ایم ڈی سی نے اس بنیاد پر ڈگری دینے سے انکار کر دیا کہ نیو ہسپتال کی انسپیکشن کالج آف فزیشن نے تو کی ہے، پی ایم ڈی سی نے نہیں کی، لہٰذا ہم اس کو ایف سی پی ایس کی ڈگری کو رجسٹر نہیں کریں. ایک بہت بڑا کرائسس ہے جس کو گوندل صاحب نے، میں بھی اس وقت کونسل کا ممبر تھا، پوری طرح سے. تو سر یہ جو انہوں نے نیا اپنے کالج آف فزیشن 50 سال اس کی عمر ہے، اس کی اسپیشلائزیشن ہے کہ وہ پوسٹ گریجویٹ ایجوکیشن کو جا کے دیکھے، اس کو ریکگنائز کرے. ایک ادارہ کام کر رہا ہے، اس کے اوپر ایک اور ادارہ آ گیا. اب نیو ہاسپٹل کو سی پی ایس پی نے انسپیکٹ کرنا ہے ایف سی پی ایس کے لیے، یونیورسٹی کے خود اس کو انسپیکٹ کرے گی ایم ایس اور ایم ڈی کے لیے. یہ تو چلے یہی ایڈوانٹیج ہے نا. سروسز ہاسپٹل کو یونیورسٹی آف ہیلتھ سائنسز نے انسپیکٹ کرنا ہے اور پھر پی ایم ڈی سی نے انسپیکٹ کرنا ہے. ہر انسپیکشن کے لیے لاکھوں روپے جمع کرانا. تو اس قدر یہ کمپلیکیٹڈ سسٹم ہو گیا ہے کہ اس وقت عملاً اگر آپ لکھے ہوئے قوانین پڑھیں تو ہماری جو ڈگریاں ہیں ایم ایس ایم ڈی ایف سی پی ایس پی ایم ڈی سی کی انسپیکٹ نہیں کی ہوئی اور اس کے نتیجے میں ہمارے لوگ جب امتحان پاس کر کے جاتے ہیں تو پی ایم ڈی سی کہتا ہے ڈگری نہیں دے سکتے، آپ نے ان کی انسپیکشن ہم سے نہیں کروائی ہوئی. لہٰذا اب جو ہاسپٹل کی انسپیکشن پی ایم ڈی سی نے الگ سے کرنی ہے کہ یہاں ایم ایس جو ہے وہ ہونا چاہیے کہ نہیں ہونا چاہیے. یہ وہ ادارے ہیں جنہوں نے ڈاکٹر پروڈیوس کیے جن سے میڈیکل کی ایجوکیشن نے جنم لیا، آج ان کے بچوں کو، یہاں کے انڈر گریجویٹ، یہاں کے پوسٹ گریجویٹ کو اس قسم کی مشکلات کا سامنا ہے کہ جی PMDC سرٹیفکیٹ دے گی تو ملے گا، ورنہ کچھ نہیں ملے گا۔ پرائیویٹ میڈیکل کالجز نے آگے سر ہمارے سرکاری سیٹ اپ کو آل ٹوگیدر چینج کر دیا۔ جس طرح کسی بندے کی ایک پہلی بیوی ہوتی ہے اور پھر دوسری بیوی آتی ہے، اب اگر دوسری بیوی تھوڑی جوان بھی ہو، خوبصورت بھی ہو، دولت مند بھی ہو، تو پہلی بیوی کو تو بالکل ہی کنویں میں پھینک دیا جاتا ہے۔ اس وقت سرکاری میڈیکل کالجز کے ساتھ بالکل یہی ہو رہا ہے کہ جو بھی نئی لیجسلیشن ہو رہی ہے وہ پرائیویٹ میڈیکل کالجز کے لیے ہو رہی ہے اور سرکاری میڈیکل کالجز کو جسٹ اس کو فالو کرنا پڑ رہا ہے۔ ماضی میں اس ادارے کے پرنسپل یا وائس چانسلر اپنے ایسوسیٹ پروفیسر کو سرٹیفکیٹ دیتے تھے ایکسپیرینس کا، آج یہ سرٹیفکیٹ PMDC سے ویریفائی کرانا پڑتا ہے، کیونکہ پرائیویٹ کے اندر روز بندے بدلتے ہیں، جعلی بندے رکھے جاتے ہیں، لہذا جتنے رولز PMDC بنا رہی ہے پرائیویٹ کالجز کے اندر ہونے والی اونچ نیچ کو ڈیل کرنے کے لیے وہ سارے کے سارے سرکاری سیکٹر کے اوپر لگائے جا رہے ہیں، جس سے ایک نہایت ہی اننیسیسری ڈاکومنٹیشن اور فی کی پیمنٹ اور اس قسم کی چیزیں کرنی پڑ رہی ہیں۔ میری آپ سے یہ گزارش ہے کہ آپ کے ٹائم آ گیا ہے کہ پرائیویٹ اور سرکاری اداروں کی ایجوکیشن جو بالکل ڈفرینٹ چینل سے ہو رہی ہے، ڈفرینٹ انداز سے ہو رہی ہے، ان کو تھوڑا الگ الگ کر کے دیکھا جائے اور سرکاری میڈیکل کالجز کو پرائیویٹ کی دم کے ساتھ باندھ کے پیچھے نہ گھسیٹا جائے۔ دیز آر دی ریئل پلیسز کے جہاں سے اس ملک کا آنے والا جو مستقبل ہے وہ اس سے کنسرن ہے۔ میری آپ سے ریکویسٹ ہے، میں آپ سے کوئی کوشچن نہیں کر رہا، میں نے اپنے کومنٹس اور اپنی فیلنگز آپ سے شیئر کی ہیں اور آپ کی پریزنس کا فائدہ اٹھایا ہے کہ آپ میڈیکل ایجوکیشن کے ان سلگتے ہوئے ایشوز کے اوپر کائنڈلی ضرور توجہ دیں اور ان کو امپروو کرنے کی کوشش کریں۔ تھینک یو ویری مچ۔
امجد صاحب نے جو باتیں کی ہیں یہ حقائق پہ مبنی ہیں کسی حد تک، لیکن ہمیں صرف یہ دیکھنا ہے جو کرنٹ PMDC کے پریزیڈنٹ اور یہ آئے ہیں، ان کے آنے کے بعد پرابلی جو ایک امپورٹنٹ ایشو ہمارا تھا مشروم گروتھ آف دا میڈیکل کالج وہ اسٹاپ ہو۔ ان کے آنے کے بعد پرابلی دیر از ناٹ ایون اے سنگل سب اسٹینڈرڈ میڈیکل کالج جو ایکریڈیٹ ہوا، اور پھر جتنے کالجز تھے وہاں پالیسی آف اسٹینڈرڈائزیشن دے ہیو امپلیمنٹڈ اور چیک اینڈ بیلنس کا ایک سسٹم دے ہیو آئی تھنک امپلیمنٹڈ ان لیٹر اینڈ اسپرٹ۔ اور جو سب سے بڑی بات جسٹس شاکر اللہ جان صاحب نے کی ہے جو پہلے کوئی پریزیڈنٹ نہیں کر سکے، آئی تھنک آئی ایم ان کانٹیکٹ ود کالج آف فزیشینز ان پاکستان میڈیکل ڈینٹل کونسل اینڈ دا یونیورسٹی فار لاسٹ 3 decades۔ He is the first president کہ جنہوں نے ہائر ایجوکیشن کمیشن پاکستان میڈیکل ڈینٹل کونسل اور کالج آف فزیشین سرجن کو ایک پیج پہ لے گیا۔ اور سیکنڈ جو امجد صاحب نے بات کی وہ بھی ٹھیک ہے کہ PMDC کا کام ریگولیشن اور ایکڈیمکس، ماضی کی پالیٹکس کو اس انداز پہ ختم کیا ہے کہ ابھی میں نے تذکرہ کیا کہ جو ٹیچرز کی ریسرچ کی ایجوکیشنل ورکشاپ ہے وہ پرابلی PMDC لیول پہ فرسٹ ٹائم ہوئی اور جسٹس شاکر اللہ جان صاحب کے دور میں اس انداز میں ہوئی کہ پشاور کی ورکشاپ میں صبح 8 بجے تک سے لے کر 2 بجے تک خود بیٹھے، اور کے گورنمنٹ میڈیکل یونیورسٹی کی ہسٹری میں he was the first president who came at 8 o'clock and left the university at 3 o'clock ورکشاپ میں پارٹیسپینٹ کے طور پر خود بیٹھے۔ اور ایک جو بات سامنے آئی ہے کہ ایکریڈیٹیشنز اگر کالج کے لیول پہ اداروں کی ہو رہی ہے تو اس کو اس انداز میں دیکھ لیا جائے، وہ ایک ڈبل چیک سے اداروں کو نہ گزرنا پڑے۔ بہرحال ان تمام باتوں کے باوجود جس انداز پہ PMDC کا ایک رخ اس وقت متعین کیا جا رہا ہے، آئی ایم شیور آنے والے دنوں میں یہ جو اپریہینشنز ہیں یہ ختم بھی ہو جائیں گی اور نیا ایکٹ آرڈیننس لے کے آئیں گے، اس میں جو چیزیں سامنے ہم نے سامنے رکھی ہے وہ کور بھی ہو جائیں گی۔ جی ویسے
Sir, I have the highest regard for PMDC. One small question.
یہ آپ نے بہت سارے سوالات اٹھائے اکٹھے ہی، جس کو یاد کرنا بھی ذرا مشکل بات ہوتی ہے، لیکن آپ درمیان میں مجھے یاد کراتے رہے اگر میرے سے کوئی ڈوب جائے۔ سب سے پہلی بات آپ نے کہا کہ اس طرح پرائیویٹ کالجز کی، ایک تو پرائیویٹ کالجز بہت سارے بنتے ہیں، پرائیویٹ یونیورسٹیاں بنتی ہیں۔ ہم نے سب سے پہلے ابھی جو کام کیا ہے، ہم نے ابھی نیا آرڈیننس بنایا، نیا آرڈیننس میں ہم نے یونیورسٹیوں کے اسٹیبلشمنٹ کے لیے کرائٹیریا مقرر کیا، اور اس کے لیے ہم نے اس میں مینشن کیا کہ ہاؤ مینی فیکلٹیز دیٹ یونیورسٹی ول بی ہیونگ۔ اس میں صرف یہی نہیں ہے کہ وہ میڈیکل کالج یا میڈیکل اسٹوڈنٹس کے لیے ہو، تاکہ اس کی فیکلٹی الائڈ سبجیکٹس میں بھی ہو، اور 4 فیکلٹی میڈیکل ریلیٹڈ ہو، تو تب وہ یونیورسٹی ایک میڈیکل یونیورسٹی بن سکتی ہے۔ اور اس کرائٹیریا کو پورا کرنا ہمارا یہی ہے کہ جو سٹینڈرڈ پہ آئے وہ یونیورسٹی بنے، جو سٹینڈرڈ پہ نہ ہو وہ پرائیویٹ ہو، پبلک ہو، کبھی بھی نہیں بن سکتی ہے۔ ہم نے ایک کرائٹیریا اس کے خدا کرے کہ وہ آرٹیکلس جو ہم نے ڈرافٹ کیا ہے اور وہ گورنمنٹ سے گیٹ تھرو ہو جائیں، تو آپ دیکھ لیں گے کہ اس میں ہم نے کتنی امپرومنٹ اور کتنی چیزیں ڈالی ہوئی ہیں۔ اور ایک مثال یہ یونیورسٹیوں کی اسٹیبلشمنٹ کی ہے۔ ہم نے ابھی فرسٹ ٹائم پہ یونیورسٹی اسٹیبلشمنٹ کے لیے اور کرائٹیریا بھی بنایا ہے، اور یہ پہلے کبھی نہیں تھا کہ اس کے لیے ریکگنیشنس کے لیے جو موجودہ ہے، جو ہے ریکگنائز نہیں ہے، اور جو آلریڈی ہیں ان کو ریکگنیشن کے لیے کیا طریقہ کار ہوگا۔ پروفیسروں کی بات ہے کہ ابھی پرائیویٹ کالجز میں جاتے ہیں سینئر اور ادھر نہیں، تو ابھی جا کے بلوچستان کی مثال لے لیں تو انہوں نے جو 2-3 کالج ابھی اسٹیبلش ہوئے ہیں اور فار فلنگ ایریا میں، جس طرح تربت، درالائی اور خوزدار یا اس طرح کوئی علاقے ہیں جو کہ کوئٹہ سے 800 کلومیٹر کے فاصلے پہ ہے، جن کو ابھی ہم نے انسپیکشن ریسنٹلی کی، اس میں ایک پروفیسر کو وہ تنخواہ 7 لاکھ روپے دیتے ہیں، وہ کبھی پرائیویٹ کو نہیں دیتے۔ تو اس طرح یہ جو تنخواہ کی بات ہے یا پروفیسروں کو پرائیویٹ کالجز میں جانا ہے، یہ تو مارکیٹ فورسز ہے، وہ کنٹرول کرتی ہے۔ اگر پبلک سیکٹر کی یونیورسٹیاں یا کالجز اتنی تنخواہیں دیں ان کے انسینٹیو کو، تاکہ وہ پرائیویٹ کی طرف نہ جائیں، یہ تو وہ کنٹرول کر سکتی ہے، یہ تو ہمارے بس کی بات نہیں۔ جہاں تک کہ پبلک آرڈیننس پرائیویٹ کالجز، اچھا اس کے لیے تو ہے۔ ابھی بات ہو گئی پوسٹ گریجویٹ انسپیکشنس کی۔ یہ میرا خیال میں یہ گورنر صاحب اس وقت ممبر تھے ACPSP کے، اور یہ ظفر اللہ چودھری صاحب کے ساتھ جو پریزیڈنٹ ہے اس کے ساتھ ہمارے انہوں نے وزٹ کیا، آئے تھے PMDC، اور ایک دفعہ میں پہلے بھی ادھر گیا تھا۔ پہلے سے جو تھوڑے سے اختلافات تھے PMDC کے درمیان اور اس کے درمیان، تو میرے سوچ کے مطابق وہ آپ دی سفرر دا اینڈ یوزر دیٹ از یو، تو ان کے انٹرسٹ میں کرنے کے لیے PMDC کے دوست کے ساتھ CPSP کے ساتھ بیٹھ کے اور سمپل ایک فارمولا دیا، آپ بھی آرڈیننس کے نیچے کام کرتے ہیں اور ہم بھی ایک آرڈیننس کے نیچے، آپ کے ڈومین میں جو آتا ہے آپ کریں، ہمارے ڈومین میں جو آتا ہے ہم کریں گے۔ دس از دا بیسٹ فارمولا، اسی سے ہم چل رہے ہیں۔ اور ابھی ماشاء اللہ جتنی بھی ابھی PMDC اور CPSP کے حوالے سے میں بات کروں تو ابھی ایک کیس پینڈنگ ہے، that is in the Supreme Court with regard to who will have to inspect the postgraduate courses or qualifications. اس کے لیے ابھی پینڈنگ ہے، تو دو عدالتوں میں 2 بینچز میں، اسلام آباد ہائی کورٹ کے سنگل بینچ میں اور اسلام آباد ہائی کورٹ کے سول اپیل میں DB میں وہ فیصلہ کیا کہ نہیں، ہر ایک کا اپنا اپنا ڈومین ہے، اس میں وہ کام کریں اور اس میں ہم دیکھیں۔ ابھی جب CPSP یہ فار دا ٹائم بینگ سبجیکٹ ٹو دا ڈیسیژن آف دی سپریم کورٹ، ویسے ٹینٹیٹولی میں کہہ رہا ہوں کہ ابھی اگر آپ ہمارے پاس رجسٹریشن کے لیے آتے ہیں تو کیا ہمیں تسلی نہیں کرنی ہوگی کسی، جس طرح آپ اپنے بارے میں مت سوچیں کہ آپ نے بہت اچھے کوالیفائڈ طریقے سے، اچھے طریقے سے کوالیفیکیشن گین کیے، کیا آپ کو اس مارکیٹ میں اور اس فیلڈ میں इस तरह लोग नज़र नहीं आएंगे जो कि सही नहीं करते या करते हैं। और अभी हम रजिस्ट्रेशन देते हैं, रजिस्ट्रेशन इज विद इन और डोमेन। जब रजिस्ट्रेशन देते हैं तो हम कहते हैं कि यू आर द क्वालिफाइड वन, तो उसके लिए हम कुछ भी न देखें और कहते हैं बस यू आर द क्वालिफाइड वन। तो थोड़े से जो हमारे स्टेट्यूट में है, हमारे ऑर्डिनेंस में है, जो हमारे डोमेन में आता है कि हम उसको देख रजिस्ट्रेशन देंगे, तो रजिस्ट्रेशन देखने के लिए हमें भी कुछ चीज़ें अपनी तसल्ली के लिए होनी चाहिए ताकि हम उस साइट को इंस्पेक्ट करें कि क्या उसके सुपरवाइजर या जो क्राइटेरिया है वो पूरा उतरता है उस पर या नहीं। CPSP के अपने डोमेन के ट्रेनिंग के लिए वो अपना ही काम करेगी और हम अपना ही काम करेंगे, जो कि हमारे लॉ रेगुलेशंस और ऑर्डिनेंस ने हमें इख्तियारात दिए हैं। और अभी आज हमारे पार्ट में कोई ये पोस्ट ग्रेजुएट की पब्लिक सेक्टर का कोई केस आज पेंडिंग नहीं है। जितने भी कॉलेजेस थे, जितने भी प्रोग्राम्स थे और जितने भी डॉक्टर साहिबान थे जिनकी क्वालिफिकेशंस थी, हमने सारों की इंस्पेक्शन की और हमने फेडरल गवर्नमेंट को भेज दिए और हमने देखी, तो हमारे पास में कोई पेंडिंग नहीं। ये सिर्फ हमने ये नहीं किया कि CPSP वालों के साथ हमारे अच्छे मरासिल, यहाँ तक बात आ गई कि CPSP के जो प्रेसिडेंट साहब थे चौधरी जफरुल्ला, उस वक्त इधर के जो वाइस चांसलर साहब थे उधर साहब वो भी उसके साथ थे। जब UPC आए तो उन्होंने क्लियर कट कहा कि हमारे जितने भी लिटिगेशन हैं हम ख़त्म करना चाहते हैं और हमने जितने भी फाइल किए हम विड्रा कर रहे हैं। तो हमारे ताल्लुकात अभी इस नेच पे पहुँच गए, लेकिन सिर्फ एक फार्मूले के साथ आपका डोमेन है आप करें, हमारा है हम करें, और उसमें सारे मसाइल हमारे खत्म करें। इसी तरह हायर एजुकेशन कमीशन के साथ PhD के हवाले से इस तरह जो पोस्ट ग्रेजुएट क्वालिफिकेशंस होती है उसके साथ थोड़ा सा मसला था। उसके जो प्रीवियस जो उसके फार्मर चेयरमैन थे हायर एजुकेशन कमीशन के मुख्तार साहब, हमने इन्वाइट किया, वो आए हमारे साथ बैठ गए। इसी तरह मौजूदा चेयरमैन हायर एजुकेशन कमीशन के बनोली साहब, वो आए हमारे कौंसिल के मीटिंग में, वो आए, उसने अपना भी पॉइंट दिया और मुख्तलिफ चीज़ें डिस्कस हो गई। तो अभी हम एक पेज पे उसके मुख्तलिफ जो हमारे जनरल सेक्शन के या जो हमारे मेडिकल एजुकेशन के हवाले से जो हमारी सब कमेटियाँ बनी हैं उसमें वो आके पार्टिसिपेट करते हैं और हमने उनको बोर्ड लिया है और हमारे जो फैसले होते हैं वो उनसे मिल के तो हम फैसले करते हैं कह रहे हैं ताकि आप लोगों को कल मुश्किलात ना आए। इसके अलावा कौन सा और क्वेश्चन था? ये कोई
सर मेरा एक बहुत छोटा सा सवाल है।
अगर चाहिए लफ्ज़ मुझे बार बार रिपीट करना पड़े, जो भी आपकी प्रपोजल है आज ही भेज दे प्रेसिडेंट के ईमेल में, हम उसको देखेंगे और हम कंसिडर करेंगे और कहाँ तक, और अगर उसमें वी आर ओपन ऑलवेज फॉर द इम्प्रूवमेंट, ऑलवेज फॉर द जो भी आपकी बात हो वो हमें भेज दें, हम देख लेंगे, कंसिडर करेंगे, आपको इन्फॉर्म कर देंगे कि हाँ आपका ये बात सही है नहीं है या हमने पहले उसको डिसाइड किया। तो ये सारी चीज़ें, बट यू विल नॉट बी लेफ्ट विदाउट एनी रिप्लाई और आंसर और एनी रिस्पॉन्स।
सर मेरा एक बहुत छोटा सा सवाल है। जो प्राइवेट मेडिकल कॉलेजेस हैं उनकी जो फीस थी वो 8.5 लाख पिछले सालों में रही है। सुप्रीम कोर्ट ने कहा दिस इज टू मच and it has to be reviewed. The responsibility was given to PMTC to talk to the private medical colleges association representative. They had a meeting and it was very surprising for everybody that 8.5 लाख रुपए को कम करने के बजाय उन्होंने PMTC ने अग्री कर लिया 9.5 लाख रुपए पे, and now the fees is 9.5 लाख रुपए. How was the fees increased by 1 lakh per student with the I should say the blessings of PMDC, sir.
So, one thing I have forgotten, that is with regard to the Central Admission Committee. Now this time, preference has been given to the public sector colleges. First, in the Central Admission Program, previously it was only not Central Admission Program, but Central Testers. Central Admission Test, ये टेस्ट की हद तक था. इस दफा हमने एडमिशन को भी इसमें इंक्लूड किया, and the admission is arranged, that is by the one in each province, one public sector university. तो अभी वो करते हैं, तो उसमें जो एप्टीट्यूड टेस्ट की जो बातें थी और सारी जो बातें थी वो बात खत्म हो गई, और पहले पब्लिक सेक्टर का करेंगे और उसके बाद जो बाकी स्टूडेंट रह जाए तो उनको फिर प्राइवेट में, दैट इज ऑन मेरिट्स ऑन द बेसिस ऑफ प्रेफरेंसेस. ये सारा अभी हम का. जहाँ तक बात है इसकी फीस की, ये इस तरह बात हुई थी कि 2 दफ़ा हमारी मीटिंग हुई थी चीफ जस्टिस साहब के साथ, और ये जो प्राइवेट कॉलेजेस एसोसिएशन है उनके नुमाइंदों के साथ हम मिलके बैठ के चीफ जस्टिस साहब के साथ ही, तो एक मीटिंग में जब वो हमारे साथ बैठ गए, तो जब फीस की डिस्कशन आई तो चीफ जस्टिस साहब ने कहा, उन पे अपने जो बातें थी कि अभी डॉलर की कीमत उस वक्त अभी तो ज़्यादा कम हो गई, हम इक्विपमेंट लाते हैं और चीज़ें लाते हैं, और इस तरह हमारे खर्चे बाहर जो उसके हवाले से है हमारे खर्चे पूरे नहीं होते. तो उन्होंने जब बात की तो ये चीफ जस्टिस साहब ने फैसला किया कि ये 9.5 लाख की, तो हमने उनके कहने भी किया है, सिर्फ उसमें मिनट्स में बात नहीं आई, हमने उसको मुनासिब नहीं समझा, अदरवाइज दैट इज अकॉर्डिंग टू हिज डिसीजन आउट ऑफ कोर्ट. तो उसने कहा, लेकिन अभी जब हम देखते हैं कि डॉलर की कीमत कहाँ पे पहुँची, तो अभी आप देखेंगे तो वो कीमत खुदा करे कि प्राइवेट मेडिकल सिर्फ 950 में तो रह जाए, अभी जो मैं सुन रहा हूँ इवन मोर देन दैट उससे ले रहे हैं. तो ये उसके साथ उसके डायरेक्शंस पे और उसी की वजह से ये 950 की बात हुई है. और हाँ, ये तो अभी वो क्वेश्चन के हवाले से बातें थी, बाकी तो खैर.
थैंक यू वेरी मच. सर ने बड़ा डिटेल रिप्लाई किया है और वे फॉरवर्ड भी बताया. अभी चूंकि आपका लंच रेडी है, अगर आप चाहते हैं तो 50 और सवाल करा लेते हैं, वरना लंच की तरफ चलते हैं. लंच की तरफ नहीं, क्योंकि अभी विल आल्सो रिक्वेस्ट द चीफ गेस्ट फॉर द कंक्लूडिंग रिमार्क्स. बिफोर आई रिक्वेस्ट फॉर द कंक्लूडिंग रिमार्क्स, आपसे सिर्फ मैं शेयर करना चाह रहा हूँ कि गवर्नमेंट मेडिकल यूनिवर्सिटी में हमारी एलुमनाई यहाँ इस वक्त तशरीफ फरमा है. नासिर भट्टी पता नहीं मौजूद हैं कि नहीं इस वक्त. नासिर हैज लेफ्ट. नासिर ने अनाउंस किया था कि वी वांट टू इस्टेब्लिश यहाँ पे विद द सपोर्ट ऑफ के 86 क्लास एडवांस स्किल लैब. एक एडवांस स्किल लैब 86 क्लास के सपोर्ट से वी आर गोइंग टू इस्टेब्लिश. सेकेंड प्रपोजल कल जो एकेडमिक काउंसिल हॉल में आई थी दोस्तों की तरफ से, वो था किंग एडवर्ड मेडिकल यूनिवर्सिटी दिस लाइक एक अजायब घर, क्या कहते हैं उसे, म्यूजियम, किंग एडवर्ड मेडिकल यूनिवर्सिटी म्यूजियम वी आर गोइंग टू एस्टैब्लिश दैट, जिसमें 1860 से लेकर आज तक की तमाम पुरानी यादें और पूरी हिस्ट्री उसमें मौजूद होगी. तो म्यूजियम इज वी आर गोइंग टू एस्टैब्लिश. एंड लास्टली आखिरी जो है वो फॉलोइंग द विजन ऑफ प्राइम मिनिस्टर ऑफ पाकिस्तान, ग्रीन पाकिस्तान, हमारा जो कैंपस है ग्रीन के, उसमें 5000 ट्री लगाने जा रहे हैं. और ग्रीन पाकिस्तान के कन्वीनर हमने बनाए प्रोफेसर जाहिद कमाल. तो जाहिद कमाल साहब ग्रीन पाकिस्तान के बारे में थोड़ी सी बात करेंगे और फिर कंक्लूडिंग रिमार्क्स के लिए चीफ गेस्ट से हम रिक्वेस्ट करेंगे. ओवर टू जाहिद कमाल.
बिस्मिल्लाहिर्रहमानिर्रहीम. खुदा करे कि मेरी अर्ज़ पाक पर उतरे वो फसल गुल जिसे अंदेशा ज़वाल ना हो. यहाँ जो फूल खिले वो रहा खिला रहे सदियों, यहाँ खिज़ां को गुजरने की भी मजाल ना हो. यहाँ जो सब्जा उगे वो हमेशा सब्ज रहे और ऐसा सब्ज के जिसकी कोई मिसाल ना हो। प्राइम मिनिस्टर की ग्रीन पाकिस्तान फंड को आगे फर्दर कर रहे हैं हमारे वाइस चांसलर साहब, और जैसे सबने बताया 5000 ट्रीज की प्लांटेशन का टारगेट हमने रखा है अपने न्यू कैंपस में, उसमें से 1000 हम ऑलरेडी लगा चुके हैं और 4000 मजीद लगाने हैं। उसमें हमें कैंपोलियंस की सपोर्ट की ज़रूरत है, इसके लिए सर ने मुझे नॉमिनेट किया। वर्किंग हार्ड, स्पेशली जो 87 और इसके आसपास के बैचेज हैं, वी विल नीड योर सपोर्ट। इस बैंक अकाउंट का टाइटल है ट्री प्लांटेशन फंड ऑफ KEMU और इसके कोऑर्डिनेटर मैं हूँगा और प्रोफेसर ताहिर जमील और शफीक साहब इसके एडमिन ऑफिसर हैं। आपको ये शेयर कर देंगे व्हाट्सएप ग्रुप पे। इसको इनिशिएट करने के लिए बारिश का पहला कतरा मैं 100,000 पाकिस्तानी रुपीज वाइस चांसलर साहब को पेश करता हूँ एंड आई होप यू विल ऑल्सो कम।
थैंक यू जाहिद कमाल। लेकिन ये कतरा चौथा पांचवा है। इससे पहले मकसूद गोंदल और ख्वाजा खुर्शीद साहब और कुछ और दोस्त अपना कतरात उस गिलास में डाल चुके हैं, बट एनीवे आई थिंक इससे और कतरात की स्पीड बढ़ेगी और 5000 भी एक साल में मुकम्मल हो जाएंगे।
May I now request our worthy chief guest for today's event, President Pakistan Medical and Dental Council, Justice Shakirullah Jan Saab, for his concluding remarks.
Who is the host of this symposium, of this gathering? The worthy guests who have come from abroad, they have participated. The speakers who have given their valuable input, the senior alumni in the medical profession, and dental profession, ladies and gentlemen. It is an occasion of extreme pleasure that I have been given this opportunity to be with you. Though I couldn't join it in the morning, since the start of this session, but because of my certain compulsions, because I was having already a commitment in the Jinnah Sindh Medical University, and there, first I went there and I have also asked them and requested to please start their program instead of 9:30 to be at 8:30 so that I may be able to come here and join at the earliest. So, after my joining, what I have heard for the learned speakers have added in my knowledge with regard to this medical and dental profession a lot, and particularly in the health sector, that is the healthcare. Generally, I cannot technically define this healthcare for all or everyone, but shortly I may say in the crude manner that healthcare for all, so healthcare that each and everyone may be having, and we must be enabled to have the healthcare facility and having an access to the healthcare facility at his own ease and possible for him. The healthcare, if we looked at, it may be divided broadly in two parts. First part, the healthcare, that depends and that is the responsibility of the individuals, for example, the lifestyle. So, the healthcare starts from his lifestyle. Whether he is a mother, that is for her child, or whether he is a grown-up, or whether he is a child, that is also responsibility of the father and parents. So, but that starts from the individual. So, how he lead his lifestyle, what is the way of his lifestyle? Because the foremost thing for a healthy body, that is the lifestyle of a person. If overeating, not eating properly, not at proper time, not having exercise, etc. So, in this, the medical doctor or the person belonging to the medical profession is having no except to sensitize him and to advise him to do like this. The second part then comes, if a disease comes, then who will be responsible to care or to treat him? That is then the doctors. And this facility must be given by the public authority, the persons in authority, that is the government. Whether a person, the vulnerable people, are having an access to the hospital, to the doctor, or having a fee to pay for that or not, primarily this is the responsibility of the public, of the government, who is having an authority to enable him to have a health care for that person. Today, what I have heard from the learned speaker, they have given a lot of their input with regard to the health care and also given the examples and elaborate the systems of the countries abroad, that is the UK and the USA, and particularly of the UK. So very good systems. We have been sensitized, but what the next step would be? The next step would be, that is the responsibility of the persons in authority to follow this principle to the extent which can be done, keeping in view our circumstances. For example, population and other resources. And so that is for the government. Every person holding a public authority must do his utmost. I will give now an example of the Pakistan Medical and Dental Council. When this council has taken over in the month of January, this council didn't spare a single moment to do for the welfare, for the improvement, for the promotion of the medical profession, medical education, and medical institutions. Because the domain of the Pakistan Medical and Dental Council is in three areas, that is the medical education, medical institution, and medical profession. Though we are now attending the two areas that we have given our full time, that is the medical education and medical institution, but we have ignored to some extent the medical profession. We have not given any time to the medical profession, also for the improvement of this profession. In this short time, what the PMDC has done, that is, first of all, to uplift the standards of the education. So the first step would be, so whether their educational institution is capable of giving a standard education or not. For this, we started inspections of the colleges which were already in existence, and even their inspections were not conducted for the last 15 years, 12 years. We started this campaign, and in this process, we recognized a few colleges which were not up to the standard. keeping in view that whether they can impart a standard education or not. So keeping in view this factor in mind, so we have re-recognized, we have stopped admission of certain colleges, and we also reduced the annual admission of some of the colleges, keeping in view their capability. Regarding this medical education, so about 70 colleges have been inspected in this process by this council. We have held so many meetings at the gap of 10 days average of the council. And these were not the meetings by name. So the meetings started early in the morning at 9 a.m. and till continued up to 11 and 12 at midnight. So we tried to attend to every aspect of the medical education and medical institutions. We started the curriculum, established a special section for the medical education, and now that is working on. In order to provide you the facility abroad, we have taken up the matter, the long-standing matter with the WAFMI, World Medical Education Forum. And an application has been submitted for accreditation of the PMDC, and the amount of fee has already been paid, and now they have given a date for the visit, for the inspection of the PMDC, so that the medical graduates who are going abroad, they may not feel difficulty, and they avail all the facility which are available to them, and there may be no hindrance on account of, because in your country, the regulatory authority has not been recognized. A number of steps have been taken, but cannot I remember at the moment, but shortly I may say that we have drafted an ordinance in addition to the regulations. That ordinance, which provide also, as has been pointed out with regard to the accreditation of the universities, which university can be called a medical university, having so many 4 faculties at least, medical faculties and allied subjects as well. So, and the other thing, the most important, whatever the reforms have been made, that is because of you. Because we have invited the proposals. Whenever any proposal has come, we have welcomed it, we have incorporated, we have considered it. So many reforms have been made, that is because of your contribution. And we shall keep continuing further improvement, further changes, further amendments in these regulations whenever any suggestion and proposal we receive from your side. And most welcome for that.
Thank you, sir. Thank you very much. We are all extremely appreciative of your efforts that you are doing in improving the healthcare system as well as the medical education in our country. Thank you again, sir. Thank you very much. May I now request our worthy chief guest and the Vice Chancellor of King Edward Medical University to please come forward to present shields to our speakers for today. Said, the organizer for today's event. Dr. Kapinta Rugal, please come forward for your opinion. Professor Asad Aslam Khan, Professor Sarwat Hussain, Professor Fareed Zafar, Mr. Rizwan Rashid, Mr. Saflan Haider, Dr. Tariq Gohar, Professor Mahmood Adil, who's travelled all the way from Scotland to speak here with us. Professor Junaid Sarfaraz, the organizers for today's event who really made this event successful, Professor Sara Afzal, Professor Imran Ashraf, Professor Saeed Ahmed, and please act as a backbone for this event today. Dr. Fawad Ahmed, and it is because of him that all circumstances also they were turned into positivity. Our very worthy Professor Sayyid Tanzeen Hyderabad. Aisha Najib, Dr. Azimuddin Zahid Sahab, May I now request Dr. Nahid Usmani, she is the President-elect of ATHA. Dr. Imdad Ali, he is specially here from the Pakistan Medical and Dental Council to attend this informative session, and I'm sure the recommendations made today, they will be beneficial for our health reforms of the country. Thank you very much. Now invite Dr. Athar Said for his vote of thanks. Before we finally conclude, I would request the worthy Vice Chancellor, King Edward Medical University, to hand over the shield to our worthy Chief Guest, the President, Pakistan Medical and Dental Council, as a token of remembrance and appreciation for his time that he has given us today.
Very much, Aisha. I think all of us will agree that this has been a great day. When I thought of this event back at the end of September, I spoke to Khalid, and I'm very grateful to him that he saw and shared my view that this is the time. There is a new government, there is hope, there is optimism in the air, and there are countries like us who have transformed themselves. For example, Turkey, and Sri Lanka and other countries who were on the road to progress. Gathering the speakers was difficult. In the end, we were able to gather together quite a stellar panel of speakers. I must thank them all, especially who have sat through the whole day, starting from this side, Rizwan, Tariq Gohar, and especially Said, who didn't speak, but actually was in the background organizing the whole thing. Mahmoud Adil, who traveled with some difficulty on the way, but eventually arrived here in time. Thank you very much. Also, Fareed Zafar and Asad Aslam, who were, I think, outstanding in their contribution. So, I hope to be able to hold these events in future. I'm hoping that the next event will be in Peshawar in 4 months' time. What we also intend to do with the Speaker's permission is to put together what we have discussed today and preserve it, for general public. So I'm hoping that I can publish all the PowerPoint presentation online. I'm also hoping that we can publish a special issue of the King Edward Medical College Annals of the KEMU with the help of Saira Afzal. We have already agreed on that. If there are any members of the media, just for their information, we are hoping to make this available in the popular press as well, in the terminology and language that common people will understand, basically to disseminate information and to create awareness and to create demand, so that we can actually ask our representatives, people who are in authority, and actually support them, but also hold them accountable to meet the timetable of our expectations. So also some people, there was to be a panel discussion, unfortunately due to the pressure of time, that will not take place. I forgot to thank Sania Nishtar, who was to be a keynote speaker, but she had to have an urgent surgery, but she tried hard to send us the video message. In the end, I thank Khalid, Tanzeem Haider and Justice Saab, who has been very patient, and thank you all. So the lunch is ready. You're all invited in the college grounds, or university grounds, I should say.